So steroid-sensitive nephrotic syndrome has definitely become easier to treat. However, steroid-resistant nephrotic syndrome remains quite a problem because many children do not respond to immunosuppression and develop multiple complications, drugs, toxicities, and many of these children will develop end-stage renal disease and even have transplant recurrence. So in this talk today, I will only cover idiopathic childhood nephrotic syndrome, which usually encompasses, although we do not do biopsies in them, previous biopsies in such children have shown that most of these children have underlying minimal change disease, whereas a few will have FSGS or mesangial proliferative glomerulonephritis. And the majority of minimal change disease and even a few of mesangial proliferative and FSGS conditions will be responsive to steroids. I will not try today to cover this vast topic. I will leave out the congenital and infantile nephrotic syndrome. I will leave out supportive therapies, vaccinations, complications of nephrotic syndrome and their treatment, details of drugs and monitoring, and post-transplant recurrence. However, these are very, very vital parts of managing nephrotic syndrome and very well covered in these very detailed guidelines. So I would appeal to you all to go through the guidelines, and a summary of the guidelines is given in the brochure in your bags. What I will include is the specific management, the diagnosis, the definitions, and the monitoring of childhood nephrotic syndrome. And this in itself also is really a huge topic to cover. So in case I do not finish, again, I ask you that the guidelines are open access, a summary is available to you. So please do go through the guidelines. I think the most important part of the talk is this slide and the next slide. Why do we need guidelines? So I think my most important task today is to convince you all to follow the guidelines. So we know that the majority of pediatric nephrotic syndrome is relatively easily treated compared to many other renal diseases. However, many of the effective drugs also carry a large amount of toxicity. We know that pediatric nephrotic syndrome in many children lasts for a long time throughout their childhood often, and it affects their social activity, their psychological status, including their physical well-being. And we want to limit both the short-term and these long-term morbidities as well as possible. And there's a huge amount of data and evidence that looks at the treatment monitoring of these conditions. And we need to know how to balance the evidence so that we use the most effective medications that are also the least toxic. So this balance is extremely important. And we need people to trawl through these huge amounts of data. And this is what the guideline does for us. It has all these guidelines that I will talk about have graded the evidence available, and the recommendation is based on evidence. So these are all evidence-based guidelines. And because of that, we need to follow these guidelines. The second reason why we should follow guidelines is to standardize care, because we all know that our patients tend to sort of hop around and shop around from consultant to consultant. We need to give these patients a very standard message so that the patients themselves know that this is what is expected of the disease. This is what everybody is telling me. From the doctor's point of view, also, when patients come to us having seen 3 other different people, it is easy to pick up and continue. It is also easy to refer patients, to talk about patients with other consultants. So I think because of all these reasons, we really need to follow guidelines. Do we treat children the same as adults? And again, the answer is no. Pediatric patients need specific guidelines for children. And the reason again is that the disease, nephrotic syndrome, is very different when it affects children compared to adults. In children, the majority are minimal change disease. We rarely do renal biopsies, and we start with standardized treatment according to our guidelines. Pediatric nephrotic syndrome is relatively easily treated with short courses of high-dose steroids compared to adults who usually need longer courses. The complications are different. Children more commonly present with infections and hypovolemia than adults. They have a long course, as I have already mentioned. And most importantly, randomized control trials have been available, which have led to standardized guidelines evolving right from the 1970s. And this is a little different compared to adults. If you look at the KDIGO guidelines for adult nephrotic syndrome, adult MCD, you will find that there are very few recommendations and most of them are practice points. So there are relatively fewer RCTs in children compared to in adults compared to children, because the childhood nephrotic syndrome seems to be a little more of a homogenized group. So these are the new guidelines I will be talking about: the International Pediatric Nephrology Association guidelines, the Indian Society of Pediatric Nephrology guidelines that I think most of us follow, most of us pediatric nephrologists follow, and the KDIGO guidelines. And all these guidelines mention the method by which they have looked at previous evidence, graded the evidence, and provided the recommendations. So coming to the guidelines themselves, first, the diagnostic criteria, I think you're all very aware of. The child usually presents with edema, with frothy urine. In idiopathic nephrotic syndrome, it is rare to find hypertension or hematuria. And the diagnosis is made by simple urine and blood test. The urine protein dipstick may be 3+ to 4+. For protein, and the protein creatinine ratio is more than 2 mg/mg of creatinine. This is on a spot urine sample, which is usually an early morning sample, early morning, to exclude orthostatic or exercise-induced proteinuria. And nephrotic syndrome means that you have this nephrotic range proteinuria associated with hypoalbuminemia, albumin less than 3 grams per deciliter, with or without edema. The initial workup includes a thorough history, clinical examination, and investigations to not only diagnose the condition, but also exclude any atypical features which might suggest underlying pathologies, such as hematuria, rashes, family history, etc. We also want to detect complications, because many children will present with nephrotic syndrome complications, such as infections, such as severe edema, such as thromboembolic manifestations, etc. And if there is no suggestion of an underlying cause, we call it a presumed idiopathic nephrotic syndrome. And in such cases, we do not need to do an initial biopsy or genetic tests. So renal biopsy is indicated in pediatric nephrotic syndrome only if there are atypical features, if there is AKI which is not attributable to hypovolemia, if there is steroid resistance, or a late renal biopsy may be indicated during the course of treatment if the child has been on cyclosporin or tacrolimus for more than 2 to 3 years. Treatment of the first episode, and all the 3 guidelines agree that it should be with prednisolone given at a dose of 60 mg/m² per day, initially for 4 to 6 weeks, followed by alternate day prednisolone 40 mg/m² or 1.5 mg/kg. This is every alternate day for another 4 to 6 weeks. And this is based on evidence that shows that whether you treat for 2 months or for longer, 3 months or more, or whether you treat for 3 months and for up to 5 to 7 months, the outcome is really no different. So therefore, looking at good RCTs with low bias, it seems the outcome does not differ with prolonging the treatment in the first episode beyond 3 months. And that is why this 2 to 3 month course has been suggested by all the guidelines. And it is also in order to reduce the potential side effects of corticosteroids. Dosing weight versus body surface area. In smaller children, body surface area calculations means that 15% extra of the dose of prednisolone may be given, and this may be more effective in reducing the number of frequent relapses later on. However, it is difficult in day-to-day practice to use body surface area, and so the guidelines suggest that weight, that is 2 milligram per kg initially and 1.5 milligram per kg every alternate day subsequently, may also be used. Single or divided doses do not show any difference in outcome. However, there is a suggestion of a lower toxicity profile with a single morning dose. Now, once the child has been diagnosed, treatment has been started, it is really vital to teach the parents to monitor the urine protein and record, because most of the complications occur due to prolonged untreated relapses. So the idea is to monitor, pick up the relapses quickly, and ask them to come in if there is suggestion of a relapse or an infection or any other complication. Now, on treatment of the first episode of nephrotic syndrome, the child may go into complete remission, that is, urine protein becomes nil or dipstick nil or trace for 3 consecutive early morning samples. And if this occurs within 4 to 6 weeks, it is termed as steroid-sensitive nephrotic syndrome. And if complete remission does not occur within this time, it is called steroid-resistant nephrotic syndrome. Steroid-sensitive relapses are treated, are defined if there is again proteinuria occurring for 3 consecutive days. And it is treated again by short courses of steroids, which are again similar to the previous episode, 60 milligram per meter squared per day or 2 milligram per kg per day until complete remission, followed by alternate day therapy, 40 milligram per meter squared or 1.5 milligram per kg for 4 weeks. There is some suggestion that lower doses or lower duration of therapy in relapses may be as effective. However, these studies are still involving very small numbers, and therefore the guidelines have not changed based on these studies. Now, this is a very topical issue. Do we change or give children or daily steroids during infection to avoid relapses? And the previous guide, the older guidelines, KDIGO and ISPN, suggests that daily steroids should be given to prevent relapses. However, the current IPNA guidelines actually suggest otherwise. So actually suggest otherwise. And this is based on the latest Prednos study, which was adequately powered to look for the change in outcome. And the Prednos study showed that there was really no change in the number of frequent relapses if you gave this daily steroid therapy. However, the circumstances are different. Our patients are different. The Prednos study was in UK, whereas all the other studies which supported this daily therapy was in Southeast Asia. And therefore, this is still a ground of open debate. And I think many of us are still resorting to change to daily steroids during URTIs to try and prevent infection-associated relapses. Now, frequent relapsing nephrotic syndrome and steroid-dependent nephrotic syndrome, I won't read out these definitions because you have them in the handouts and there is very little time. But the diagnosis of frequent relapsing and steroid-dependent nephrotic syndrome is absolutely vital, because it is an indication that these patients need some maintenance therapy to reduce steroid toxicity and to prevent multiple relapses. And these are the multiple steroid toxicities that you know that many of the nephrotic children develop if they are having to have repeated steroid therapies. So the options for treatment of FRNS and SDNS are prolonged low-dose alternate day therapy, or if the child is becoming steroid toxic on this treatment or requiring high-dose steroids to maintain remission, then we go for the steroid sparing agents. I think most of us pediatric nephrologists in this room like to follow the ISN guidelines, which suggest that in steroids, when we are using steroid sparing agents, we would initially like to use the agents that have low toxicities. So we would like in milder steroid dependence, we would like to use levamisole or MMF, whereas in more severe steroid dependence, we may use MMF in higher doses or cyclophosphamide. And only patients who do not respond to this, we then go on to using the calcineurin inhibitors and subsequently rituximab. Again, I do not have the time to go through all the evidence that these guidelines are based on, but there are Cochrane meta-analysis and many studies that back up the recommendations given by these guidelines. So now coming to steroid-resistant nephrotic syndrome, again, it is lack of complete remission at 4 to 6 weeks, depending on which guideline you're going to follow. And the majority of steroid-resistant patients need a kidney biopsy, except if there is defined infection, malignancy, or a previous diagnosis of a monogenic syndrome in the family. So the kidney biopsy requires at least 20 glomeruli and involvement of the corticomedullary junction to definitely exclude the diagnosis of FSGS. Genetic testing is required, particularly if there are syndromic features, if there is familial SRNS, and if there is CNI resistance. So these are the particular conditions under which genetic testing is done. And Dr. Anil will talk a lot about genetic testing subsequently. Specific therapy for non-genetic SRNS, again, this is evidence-based, and cyclosporin, tacrolimus with RAS inhibitors are the drugs of choice, with tapering of prednisolone. Cyclophosphamide, if CNIs are not available, costly, or causing toxicity. MMF, if there is low GFR, and rituximab, if none of the above have worked, or if there is a prolonged CNI requirement. So again, these are the evidence tables that provide support for the recommendations given. Algorithms are available in all the guidelines that I have spoken about, but we have to always remember that all these drugs carry multiple toxicities which need to be looked at. And the final issue is that many of our children will actually keep relapsing till late adolescence and sometimes even into adulthood. And gradually from the age of 14 to 16 years, we need to keep teaching children how to look after themselves, how to monitor themselves, so that as they become adults, they are able to take on a lot of self-care. And eventually we need to transfer care when the child is above 18 years old. And we need to organize this transfer in a smooth manner with our adult nephrology colleagues so that the children are well looked after even in adulthood. So in summary, there are excellent guidelines, very all-encompassing guidelines available, open access for you to look at. With steroid-sensitive nephrotic syndrome, there's a very high potential for cure. We need to use effective treatment, but we need to minimize the short-term and long-term adverse effects. With steroid-resistant nephrotic syndrome, there are newer diagnostic methods involving genetics. There are newer drugs being used. So a guideline-based specific treatment is recommended for these children. And these are patients, the ones that are unmasked are the patients who have gone through many years of nephrotic syndrome and are now doing well. So this is a lady who has her own child. She received cyclophosphamide in the pediatric age group. This is a young man who is now 18 and going to college. And The last child is a child with steroid-resistant nephrotic syndrome who went through a very hard time, was on dialysis for many years, and has now 5 years ago received a kidney transplant from her mother. Luckily, the disease had not recurred and is now doing well. Thank you.
Thank you, ma'am, for your excellent deliberation. It was very informative, very comprehensive, and definitely we have added so many new things in our pre-existing knowledge about the treatment of the nephrotic syndromes. Any question and comment from the audience? Our co-chairperson, Dr. Patrick, will say something.
Thank you, ma'am, for your informative lecture. Although this is not part of your lecture, but some practical points I want to ask you. So I have three kind of patients which we normally see in our day-to-day practice. One patient is on nephrotic syndrome, on steroids, and developed fever. So what should be our steroid dose? The second set of patients are those who are on...
Can I go one by one?
Yeah, sure.
So a child who has fever, definitely treat the fever. He's already on immunosuppression or not?
Already, he is on immunosuppressive drugs.
So definitely, treatment of the infection and the fever, etc. If it's a very sick child, then we need to give stress dose of hydrocortisone and continue antibiotics. If it is something like varicella, we might consider discontinuing any secondary immunosuppression like cyclosporin, MMF, etc. But stress dose, hydrocortisone, adequate treatment of the infection with antibacterials, etc., and stopping very aggressive or weaning any aggressive immunosuppression temporarily is what I would suggest.
Okay. So you want to give the stress dose of hydrocortisone?
Yes.
So my second set of patients, those patients who are nephrotic syndrome in remission, had infection and relapse. So what should we treat first? Should we treat infection first, or we start right from the first day?
On any treatment or not on any
Patient
treatment at all?
Patient is in remission. He is not on any treatment.
Okay, so again, I think, practically, it depends on how sick this child is. If a child is extremely sick, and the child has had steroids in the recent past, then again, just start the stress dose and treat the infection. Once the child is stable, go on to the full dose.
And suppose after treatment,
sometimes if it's a very mild infection and you treat the mild infection alone, the relapse might get better. So it depends on how bad the child is.
And a pediatric patients with LRTI or some kind of infection, and during that evaluation, he found to have nephrotic range proteinuria. So should we wait for infection to go, or should we start steroid?
We can wait for some time for the infection to come under control, but not too long. We don't want, if the child is already edematous, then we do not want to wait for very long.
Thank you, ma'am.
Patrick.
Actually, looking after pediatric patients is also easy, but could be very challenging also at times, especially as you mentioned, the frequently relapsing nephrotics or the steroid dependent or steroid resistant. Now there is a lot of, I think next talk where you would address, we have to reach a stage where in difficult patients who respond even if they are infrequent relapses, not a problem. But by genetic analysis, if we can move in a direction that there is a targeted therapy available for difficult patients, I think that is the way probably management.
I think Dr. Anil will speak in detail about that, but only about, steroid resistant also, only about 25 to 30% patients will have genetic abnormalities detected, and the rest of them we will have to treat with our CNIs and RAS inhibitors, etc. But that is can be a very difficult. When we started training and treating patients, CNIs were not, I think Dr. Srivastav will be able to say even in greater detail, CNIs were not so easily available. And all we had were these Mendoza protocols, huge doses of steroids and IV cyclophosphamide, etc., which made the children really toxic and didn't work that well actually. So since these guidelines and CNI started being used even in steroid resistant nephrotic syndrome, a large proportion, I think more than 50%, and according to the data, 50 to 70% of patients will respond to CNI plus RAS inhibitors, even the steroid resistance. So I think, in the sort of 20 years of my practice, I have seen a major change even in the treatment of steroid resistant nephrotic syndrome for the better. And I'm sure, the next 20 years will bring even better news for these patients.
So since this is a very important topic, we can take couple of questions.
Dr. Sushmita, one question from my side.
Yes.
One of my patients is in first relapse and she's doing well, but in between she got 2 episodes of RTI and developed swelling and 2+ proteinuria. So, but ultimately when the thing is getting corrected, she's getting okay. So should it be bothersome or not?
I think if they're getting swollen, I would treat them. But often they come with an infection with urine protein of 2+ for a few days. And then if they do not have edema, I sometimes say, let's wait another few days and see. But if they are having edema, I think I would treat them, because otherwise sometimes it gets out of control. The infection also keeps increasing. They get hypovolemic, they need admission, etc.
Thank you.
Sushmita,
George,
thank you
yes.
for that excellent and lucid presentation. Children with relapsing nephrotic syndrome, steroid sensitive. Once I had a child, I was calling Arpana. Arpana said, sir, why don't you lower the dose of steroid and also add MMF as a therapy? And this worked very well, addition of MMF, because the child was taking previously cyclosporin and other things. So I found that now child is on 180 milligram of MMF a day and 5 milligram of prednisolone. No relapse at all. So I just wanted to say my personal experience of using MMF because of the advice given by a renowned pediatric nephrologist.
So
Thank you, Dr. Georgie. I think the just 1 or 2 points to make. One is that follow the
Yeah.
pediatric guidelines for doses,
We
because
are
the
already running. We are already late running, so please.
I'm just concluding.
So follow the pediatric doses, because pediatric and adult doses for steroids are very different, but the pediatric doses are evidence-based. So I think follow the pediatric dosing schedules that are recommended in the guidelines, number 1. Number 2 is, if they're having frequent relapses and steroid dependence, as Dr. Georgie mentioned, don't let them get steroid toxic. Start the maintenance therapy early.
Okay,
Thank
we
you,
are
ma'am.
running.
Thank you.
Thank you, Chairperson. Thank you.
Thank you.
All the chairpersons and the speaker are requested to collect their memento and also to get a group photograph then. So our next speaker is Dr. Anil Basudevan from Bengaluru, and he is going to deliberate on molecular basis of nephrotic syndrome sensitive to resistant. And to chair the session, we have Dr. A.K. Jaswal, ex-HOD, Pediatrics PMCH, Dr. Sanjay D. Cruz, Professor and Head, Department of General Medicine, GMCH, Chandigarh, Dr. Alka Singh, HOD Pediatrics, NMCH, Dr. Mrityunjay Singh, Senior Consultant Nephrologist at AIIMS Gaya, and Dr. Himadri Shankar, Consultant Nephrologist, Ashray Clinic, Bhagalpur. So the chairpersons are requested to introduce the speaker and proceed. Thank you.
First of all, I would like to thank the organizers for inviting me as chairperson in this first state conference of pediatric nephrology, and the theme being kidney and the child. We have a noted speaker for this session, Dr. Anil Vasudevan, and he'll be speaking on the molecular basis of steroid sensitive and resistant nephrotic syndrome. His areas of special interest, he's professor and head Department of Pediatric Nephrology at St. John's Medical College Hospital and adjunct professor, Division of Molecular Medicine, St. John's Research Institute, Bengaluru, And he has done a lot of work on this molecular basis. His area of special interest is genetics of kidney diseases and has had several awards and recognitions. He's member of the editorial board, Asian Journal of Pediatric Nephrology, member task force on tubular disorders, Asian Society of Pediatric Nephrology, member of committee for competence-based syllabus in pediatric nephrology, member curriculum committee for postgraduates, member of PhD committee, JIPMER. And he has more than 50 publications in national and international journals and authored more than 20 chapters on various kidney diseases. And I'm sure this is going to be a very interesting session and we'll learn more about this subject.
Thank you, ma'am, for your kind introduction, and good afternoon to all. At the outset, I'd like to thank Professor Hemant Kumar and team for inviting me here, and in a unique interface between adult nephrologists, pediatric nephrologists, and pediatricians, trying to find a common path towards managing children with kidney diseases. And thank you, Rajiv, for I am aware that you were part of designing this program. So what I'm going to talk about is probably the most common kidney disease in children anyone treats, be it an adult nephrologist or a pediatric or a pediatrician. The most common kidney disease in children that you face in an OPD is a child with nephrotic syndrome. And needless to say, it's a very intriguing disease for all of us. So this is a review that was published way back in 1940 in NEJM by Bradley and Stanley Bradley, where they discuss about the origin of nephrotic syndrome. And they speculate whether it's an extrarenal cause or a renal sui generis, that is a primary kidney disease. And they conclude by saying that it is viewed as a discrete entity, and as such, it remains an unsolved riddle. Now, coming to 2023, how much we know of this riddle, how much we have solved this riddle, I'll be touching upon the various molecular mechanisms that have been implicated in the pathogenesis of nephrotic syndrome. And when I say that, it refers to the idiopathic nephrotic syndrome of childhood. Each of these components are chapters by itself with large amount of experimental, clinical, in vitro, in vivo data that are often confusing, often contradictory. So I'll be just giving a gist of these current status of the immune system, the circulating factors, the podocyte itself as a key player in the pathogenesis, and finally the genetics of nephrotic syndrome. So as Dr. Shushmit has said, the nephrotic syndrome is probably more prevalent in the South Asian as compared to the other populations. The hallmark of this disease is the remarkable sensitivity to oral prednisolone therapy, which especially in children, most of them do respond. However, the subsequent course, there is a large amount of inter-individual variability that is not predicted by the age, the demographics, the previous treatment, despite the fact that all the children receive the same diagnosis. The subsequent course is very variable, with more than 50% of them requiring steroids during the frequent relapses, or continue to remain on steroids to maintain remission. And of these, probably 1/3 of these children are very difficult to treat. In the sense that they require multiple immunosuppression, and nearly 1 in 10 to 1 in 3 continue to relapse in adulthood. The younger the child has an onset, more likely that it may relapse in the adulthood. That's what the data shows. But fortunately, despite this terminal course, less than 1% have kidney failure. And this is in contrast to the steroid-resistant nephrotic syndrome, which is a different beast by itself, where 50% of them progress to some form of chronic kidney disease in 5 years of the diagnosis. So over the years, what has been very clear is nephrotic syndrome being a kidney disease, to being a glomerular disease, to being a disease that involves the filtration barrier. Now we know that the specific cell that is targeted in this disease, and that's the podocyte, which is a very interesting cell because it's a terminally differentiated cell. It has a unique architecture in form of foot processes that interdigitates and forms the critical slit diaphragm, which is the main component of the filtration barrier. And what is well known in nephrotic syndrome in childhood, or the idiopathic nephrotic syndrome, is that all the children will have effacement of the foot process, which is with the starting point being the derangement of actin skeleton. So now these two processes are reversible by medication, by using immunosuppression and other forms of therapy. It tends to become problematic when there is detachment of these cells from the GBM or death. and then and which is fortunately seen in only in a few subset, that is 10 to 15% of idiopathic nephrotic syndrome. So what causes all this remains in the realms of hypothesis and conjectures. So one of the first proposition was by Robert Salob way back in 1970 in his seminal article, where he proposed that idiopathic nephrotic syndrome is a kidney manifestation of a systemic T cell dysregulation. And this he based it on 4 clinical observations, most of them indirect, right from remission with measles to remission induced by steroids and cyclophosphamide and its association with Hodgkin's disease. Publication of this hypothesis prompted subsequent numerous studies, both in humans and in animals, where they did show this thing to be quite prevalent, such as the transcriptomes analysis or infusion of supernatants of these cultured cells from patients with MCNS induced relapse in proteinuria in rats. While a lot of experimental evidence was provided to confirm that hypothesis of association of T cell mediated pathogenesis in idiopathic nephrotic syndrome, the subsets of T cells that were involved remains to be unclear. So the initial work was on a particular type of subset of T cells. As you're all aware, there are 4 subset of T cells, and these are all produced from the CD4 cells in the thymus, and the differentiation and proliferation into a particular phenotype depends on the cytokine exposure from the antigen presenting cells that are exposed to various antigenic stimuli and conditions. For example, the IL-2, IL-4 induces the formation of Th2 cells that are involved in cell-based immunity, immunity and humoral activation. IL-2 induces Th1 that are, the IL-12 induces Th1 that is involved in cellular immunity, while Th2 is involved in allergic and humoral allergic responses and activation. And these cells secrete their own signature cytokines, like in Th1, it is interferon gamma, whereas in Th2, it's IL-4 and IL-10. So the initial work focused on these 2 subsets, and they showed that there is a Th2 bias or there is an activation of the Th2 pathway, especially with the association of atopy and allergy with nephrotic syndrome. But subsequently, the role of T regulatory cells or the Treg started becoming more clear, especially with conditions such as IPEX syndrome, where there is a genetic mutation that causes a impairment of the T regulatory cells. Now, how this happens and what has been shown is that the T regulatory cells seems to be suppressed or low during the relapses in idiopathic nephrotic syndrome, and probably this because of this imbalance of the T regulatory as compared to the Th17 cells, there is probably amplification of the neutrophil induced oxidative pathways in these group of children. While but unfortunately, there has not been significant clinical translation of all these findings. It was very intuitive that, probably looking at these signatures of cytokines, we could, try to understand and target these group of children specifically based on the cytokine pattern. But unfortunately, the evidences have been not only very heterogeneous, but also quite contradictory. For example, there are cohorts in which interferon gamma was suppressed, TNF alpha was suppressed, but we have FONT trial where they have used anti-TNF alpha therapy as one of the therapy for management of these difficult nephrotic syndrome. So nothing much could be clinically gained from these understanding of the T cell mediated pathogenesis of nephrotic syndrome. Although the Salob's hypothesis has dominated the literature for many decades, there were evidences that other components of immune system are also involved, such as the dysregulated immunoglobulin metabolism, association with Hodgkin's lymphoma derived from the B cell secondary to an EBV infection, but it was never paid much attention. Like T cells, B cells are also a heterogeneous group of cells. Briefly, they constitute either of memory cells or the plasma cells. The plasma cells are either short-lived, that is, they remain in circulation for a short period of time, or they're long-lived, where they go back into the bone marrow and continue to produce the antibody independent of the antigenic stimulation. So this importance of B cell in the pathogenesis came in the nephrotic syndrome came quite accidentally. And it was with the use of rituximab in a child who had ITP with nephrotic syndrome. So as you can see here, this child who was very young had multiple relapses despite using many of the immunosuppressive medications. And the clinician gave rituximab for his thrombocytopenia, not for these relapses. And they found quite surprisingly that after the use of rituximab, there was sustained remission of the nephrotic syndrome. So it was an accidental discovery that pitchforked this B cell, importance of B cell in the pathogenesis of nephrotic syndrome. Now the question is, how is B cell involved in the pathogenesis of nephrotic syndrome? Again, here, there are a lot of postulates and theories and experimental data, which shows different mechanisms, just as with T cell, different mechanisms that can explain the involvement of B cell in the pathogenesis of nephrotic syndrome. One is probably by altering the T cell homeostasis, because they do express a lot of surface receptors such as HLA class 2. They also have the ability to secrete a lot of cytokine and inflammatory mediators such as TNF-alpha, IL-6 and IL-17 that can influence the T cell activation. It can also probably be because of secretion of what is called an hyposialylated IgM, which actually inhibits the effect of steroids on T cell, keeping them active for much longer than what is required. And this may explain why some of those children with steroid sensitive who are genetic negative do not respond to steroids. In addition to this activation of the T cell pathway, there is also evidence that it could be through an antibody-mediated mechanism. Now, nephrotic syndrome is generally not known as an autoimmune disease, but what has been shown in both adult and in children with idiopathic nephrotic syndrome is the presence of antibodies and these antibodies are very specific to proteins that are expressed only in podocytes, such as anti-CD40 antibody, which has been identified in those adults with recurrence of following kidney transplant, presence of anti-ubiquitous ligand protein in children with minimal change disease, and anti-nephrin antibody, again in children with minimal change disease. So it could also be an antibody-mediated disease. But again, these data in small subgroups of patients with nephrotic syndrome. But the fact that there are many other markers that has been identified in this group of children, such as soluble CD23, IL-21, B cell activating factor in adults with idiopathic nephrotic syndrome, all this are factors that activates B cell independent of these other mechanisms. So it seems like there is also an antibody independent mechanism that plays a role in the pathogenesis of nephrotic syndrome. Similarly, they have shown that IL-4 activated B cells can produce proteinuria in mice models. Again, as you can see here, a lot of data in different types of nephrotic syndrome in different contexts have shown various mechanisms. But it's very clear that B cell is indeed involved, but it could be probably different between children and adult. Because when they looked at the different types of B cells, they found that the total B cells and memory B cells are increased in children, whereas plasma blasts are increased in adults with idiopathic nephrotic syndrome. So just as with T cell mediated hypothesis, even here, we do not have much of a clinical translation into having a newer therapies. The rituximab, as I said, was more of an accidental discovery, but exact way in which it acts and prevents relapses is clearly still to be delineated in nephrotic syndrome. So, we all know that immune dysregulation happens in nephrotic syndrome, but is there a trigger? Because many a times, most of the relapses, like around 60 to 70%, happen following a viral URI. Many of them are reported following vaccinations or allergic events. So clearly there is a trigger that causes the uptick of this immune system. More recently, the French cohort in their population of nephrotic syndrome with relapses and first episode, what they did identify was that the EBV DNA was much higher in those who had relapses as compared to the controls. And they put forward this interesting EBV hypothesis where they postulated that the antibody against one of the EBV antigen called the EBNA1 cross reacts with the podocyte protein, the nature of which is is unknown. Initially, we used to think that influenza and other viruses, but here is some of the documented evidence that it's probably an EBV virus that triggers these relapses and may be involved in the pathogenesis of nephrotic syndrome. So often now we also consider that podocytes are usually the target of the immune system, which is generally systemic in nature. The frustration of not finding a specific pathway or a specific molecule which we could nail down into the pathogenesis led to a group of researchers who had this controversial hypothesis that it is not the immune system. Probably we are overplaying the immune system, but it is actually the podocyte that itself acts as a key player in the pathogenesis of nephrotic syndrome rather than just being a target. And this evidence came from a lipopolysaccharide-induced experiments in mice, especially in SCID mice, the combined immunodeficiency mice, where they do not have any form of T cells or B cells. In them, this LPS injected, when they're injected LPS, it triggered proteinuria, suggesting that there is some non-immune mechanism or the podocyte itself is playing like an immune player. And later on, they documented that toll-like receptors, inflammatory or cytokine receptors are seen on podocytes. And now there is a paradigm that is being considered is that podocyte is a part of the adaptive immune system and plays an active role by activating a lot of these immune pathways within the podocyte, and that results in podocyte injury. In addition, there are other non-immune factors that are secreted by podocyte, such as angiopoietin-like 4, which also can cause proteinuria. So, and another interesting hypothesis was by the Japanese group, which suggested a two-hit hypothesis that again, where the podocyte is a central player rather than being a target, where the trigger could be a genetic, toxic, or immunological that results in induction of CD80 on podocytes. And this results in transient proteinuria. But a second hit that prevents the clearance of the CD80 because the CTLA4, which is required for the clearance, is impaired. And this results in persistent activation of the CD80, resulting in persistent proteinuria. So all in all, this suggests that these evidence suggests that podocyte is just not a target, but also an active player amplifying these immunological signals and pathways and causing injury. So we tried to explore this pathway in our own cohort, where we took plasma from different groups of children, steroid-resistant, infrequent relapses, frequent and steroid-dependent nephrotic syndrome. We took this plasma and exposed them on immortalized human podocyte cell line. And after the exposure, we did a transcriptomic analysis. And we could see that the gene signatures obtained from the podocyte are quite different. And a blinded classification yielded something similar. As you can see, they categorized itself without providing the clinical data. It's called an unsupervised hierarchical clustering, that it falls into SRNS, frequently relapsing and infrequently relapsing. When we looked at the specific pathways that are expressed by these podocytes, while there are non-immunological pathways that are different between SRNS and FRNS and IFRNS, we also observed a lot of immunological-like pathways that are activated in podocyte, again supporting the fact that probably podocyte itself has an active role in the pathogenesis of nephrotic syndrome. The second hypothesis that was put around, as you can see from this interesting case report, just around the Salob's hypothesis in early 70s, was of this report of recurrence of idiopathic nephrotic syndrome after transplantation. But this hypothesis was much earlier in 1950s, but not much attention was given. And this gentleman, Dr. Gentili, actually did this daring experiments, which we cannot think of it now. He took plasma from infants with idiopathic nephrotic syndrome and injected it to healthy children and documented proteinuria. So assessing that it's probably a circulating factor. And thereafter, there were a lot of evidences that did suggest that probably a circulating factor could be the main cause of idiopathic nephrotic syndrome in children, such as transplant-central transmission, serum from patients with post-transplant relapse inducing proteinuria in rats, and so on. However, that has been a holy grail in the identification of the circulating factor. There are a lot of actors in this field, many of which were validated again in small subgroups of children with and adults with nephrotic syndrome. Many of them are immune factors like CLC1, interleukin 13 and 18. Many of them are non-immunological circulating factors such as vasoactive proteinuric factor, hemopexin, and more recently, SUPAR. But none of these have been shown to be consistently associated with nephrotic syndrome. Neither inhibiting these molecules have shown to remit nephrotic syndrome, again providing a disappointment in terms of translation of experimental evidence into actually converting that into some clinical benefit. So here again, we try to look at the circulating factor. And this was during my training in the basic science in Montreal, when there was a child who came with recurrence following kidney transplantation. And at that time, TNF-alpha was being considered as one of the putative circulating factor. So what we did was we took plasma from this child and exposed them to the immortalized podocyte cell line. And you can see here, the cell lines which were having a linear actin organization got destroyed. Then we treated these podocyte with anti-TNF-alpha antibody, and then exposed this podocyte to the plasma from the same patient. And as you can see, the injury was prevented, thereby attributing to the role of TNF-alpha. And finally, based on this, we did give this child the TNF-alpha adalimumab, and there was some amount of control in the proteinuria for a year or so. So one of the dramatic developments has been in the genetics. I will be not talking about the clinical aspects. I'm happy to take the questions because of lack of time. And I may take 1 or 2 minutes before the bell. You can extend the bell by 1 or 2 minutes. It reminds me of the school break. One of the dramatic developments in the pathogenesis and understanding of nephrotic syndrome has been the genetics, especially in steroid-resistant nephrotic syndrome. And it pitchforked not only genetic, it pitchforked the podocyte biology into the central theme of pathogenesis of nephrotic syndrome. And it started with the discovery of the first genetic variant in the NPHS1 by Corey-Antinac's group in France. Subsequently, a lot of attention was, and you know that nephrin is in the slit diaphragm, a lot of attention was paid to discover more and more of these genes that regulate the proteins in the slit diaphragm, like as in podocin and so on. But now we have discovered so many genes that not only regulate the structure, but also the function of the podocyte in general, such as a nucleus, mitochondria, in the actin cytoskeleton, and so on. So now we have more than 90 known single genes, but all this 90 gene probably explains 1/3 of the steroid-resistant nephrotic syndrome. So, which means that 70% of those steroid-resistant nephrotic syndrome, we do not have a clear etiology. It could be a circulating factor, immune dysfunction, or a gene that is yet to be discovered. But what it did help, unlike the immune pathway and hypothesis, it did help in the management of these patients. It not only helped in confirming a diagnosis, but it also in modifying our immunosuppressive therapy, in prognosis, and also at the time of transplantation in predicting recurrence, in identifying a suitable donor, especially if it is an autosomal dominant variant. And more recently, there is a nice study that has looked at particular gene variant in the CoQ pathway. And for the first time, a genetic variant is amenable to therapy. That is, by CoQ supplementation, they did observe, especially the CoQ2 and 8 are amenable to CoQ supplementation. Similarly, the gene called tubin is amenable to vitamin B12 therapy. Although strictly not a podocyte gene, it is expressed also in the tubular cells. They were amenable to therapy. Similarly, another gene called the ARGHDIA gene was amenable to eprenolone therapy. So we have now increasing evidence to say that some of the genetic mutations are amenable to medical therapy. And then which proportion of children have these genetic variants? This is the data, latest data from the Chinese, a large study, which multi-center study. As you can see, the proportion is highest in congenital and infantile nephrotic syndrome. And the blue squares are those with the genetic variants. And probably the least amount is found in the adolescent group, less than 10%. And there is no correlation between the histopathology and the probability of finding a genetic mutation. It could be either an MCD or FSGS. Similarly, while the most common genes that are found to be associated with mutation are podocin and nephrin and WT1 and PLC1, in our study of screening of more than 100 patients, we didn't find much of podocin or WT1, thereby attesting the importance of doing these kind of genetic studies in your own population. But when we did use in a NGS panel or a next generation sequencing panel, although a small number, we did find some prevalence of 30%. I mean, so the the prevalence of overall genetic burden doesn't change, but the genes that are associated with steroid-resistant nephrotic syndrome are probably different between population. And Dr. Rajiv's study from Calcutta showed that COL4A4 genes variants are increasingly being associated with steroid-resistant nephrotic syndrome. While in steroid-sensitive, there is not much of data. There is only identification of susceptibility factor. This is the data from a meta-analysis involving various population, including the South Asian population. And you do find not only HLA-DQ, but also non-immune hits, such as TNSF, NPHS1, as being a susceptibility area, which means that presence of these loci increases the risk of steroid-sensitive nephrotic syndrome. So the recent understanding has helped us caricature into three broad clinical groups of nephrotic syndrome, or the understanding. So one is that steroid sensitive are more likely to have immune dysfunction, and they tend to have a favorable course despite the number of relapses. Those with circulating factors are more likely to be late SRNS, rarely primary SRNS, where have variable response to CNI, and a proportion progresses to end-stage kidney disease and have recurrences post-transplant. Whether these are overlapping groups or two discrete entities are not very clear, because with our clinical practice, we do find that those who respond to steroid become late steroid resistant and have a subsequent poor course. So, but what is very clear is the primary defect in podocyte, the monogenic ones, which forms a distinct entity, and they are usually CNI resistant and have a family history of SRNS. So while our understanding has become better, but patients like these reminds us how less we know, and our treatment continues to be empirical. So this is a child who had an onset of nephrotic syndrome at 3 years of age. These orange bars indicates the number of relapses, not all I could include. And this is the proteinuria, the line graph. As you can see, despite the use of steroid-sparing agents, the child continued to remain steroid dependent, requiring long-term steroid therapy. As the child grew older, we were challenged with the biopsy showed minimal change disease. And as the child grew older, we had to face a lot of steroid-related side effects, right from cataract surgery to spine fractures and so on. This is a child which did not also respond to rituximab, but had developed hypogammaglobulinemia. When we biopsied this child after 14 years of the disease, we still found exactly the same picture as we found at the onset. A minimal change disease, and IF is completely negative. And this is the child, you can see a 17-year-old short with all the textbook complications of steroids, and reminds us that how less we know about this interesting disease. Thank you.
Thank you, Dr. Vasudevan, for your really very mesmerizing and very exciting celebration on a very, very new subject. I think that is molecular basis. And just I wanted to ask you one thing, that can we see on the basis of this genetic basis on this genes, the podosine and nephrin and other genes, can we see the future of gene therapy or CAR T cell therapy? So these two have new implication. Can we see the future in management of nephrotic syndrome?
So we are hopeful of having some form of therapy. These are all podocyte specific genes, and targeting. The challenge with this is that podocyte is a terminally differentiated cell. It is not easy to transfect a terminally differentiated cell with a new gene. And that probably is the challenge that needs to be overcome before we say that gene therapy can be a realistic therapy in future. Unfortunately, the short answer is no for the near term.
What about this CAR T cell therapy?
So it all depends on the etiology. So as I said, these monogenic mutations are in podocyte specific genes. So unlikely that it'll work. The main issue is that it's an we have tried it in our own lab to transfect, and it becomes very difficult when it is differentiated completely. It's very easy to introduce the gene while it is proliferated, but not while it is
Thank you. I think any questions or our co-chairperson will.
Just a couple of comments I'd like to make. A wonderful talk. It was a pleasure listening to you. Genes and all these things which have come over the last 20 years have helped us in a way. As Professor R.K. Sharma said, you should not be over immunosuppressing your children or even adults. Some of the patients spill over into our situation, adult group also. So it helps us in stopping the immunosuppression and managing them conservatively. There is a family history, consanguinity, young age at onset, and if there are some phenotypical markers, then obviously there's a case to screen these people. If there is any questions from the audience, please raise your hand.
Thank you.
How much this genetic testing will cost to my patient? And third, how will it change the treatment of that patient?
Thank you for the question. I didn't put it here because of lack of time. So the indication for genetic testing is very specific. So if you have a CNI primary steroid resistant who is CNI resistant, that is one indication. Second is a family history of steroid resistant nephrotic syndrome. The third is an infantile or a congenital nephrotic syndrome. The fourth is a syndromic patient. So many of these nephrotic, a small proportion have syndromic, like Galloway-Mowat, Pearson syndrome, Neil-Patella syndrome. So if you have extrarenal features that suggest a particular syndrome, I think you should do a genetic test before treating them. And the last is at the time of transplant. It's a good idea to do this, and which will help us predict recurrence. And also in autosomal dominant form, it helps us choose a donor, because if the donor has the same variant, you may be hesitating in taking that donor for as a potential for the kidney transplant. So this is the indication. The management wise, it helps in withdrawing immunosuppression. We are no longer aggressive in empirically changing the immunosuppression once we find that the variant is identified. It helps us prognosticate because 75% of them will land up in end-stage kidney disease within 10 years of diagnosis, those with a genetic form. It helps us predict the recurrence rate because that has less than 1% chance of a recurrence after. So in this way, and also, of course, in antenatal diagnosis and preventing a steroid-resistant nephrotic syndrome, these are the utility. The challenge is in getting a report, because most of the time it ends up as variant of unknown significance, and that becomes a real challenge. Sorry, the cost has come down very much. It's probably costing less than a PET or a MRI now. You can get this panel for 11,000 rupees to 13,000 rupees in commercial, and whole exome is around 15 to 18,000. So since there are no genotype-phenotype association, we can't predict unless it's syndromic. So we have to send a panel to identify the genetic etiology, and that will be the massively parallel sequencing or the NGS panel.
Okay, so nobody has any questions from the audience? Okay. No, he wants to ask.
So, am I audible?
Yeah, I can hear you.
So Anil, sorry. So is steroid sensitive nephrotic syndrome a genetic disease?
Right now, whatever the evidence suggests, it may be, I didn't bring it up because it leads to confusion. This is genetic susceptibility because around 5% can have a familial steroid sensitive nephrotic syndrome. But there are few genes that may show some response to steroids, such as PLC1 variant. But they're doing a genetic testing doesn't help because anyway, you're going to continue the management as in a steroid sensitive nephrotic syndrome. So right now there is no indication for genetic testing, but a genetic basis, definitely it seems like an environmental genetic and a kind of a paradigm in steroid sensitive.
Okay, thank you, Dr. Vasudevan, for your very nice talk. And it was really interesting. It will decide the course of immunosuppressive therapy and in making new diagnostic tools and therapeutic effects. Thank you.
A very nice talk by Dr. Anil Vasudevan, but I think the things got a little bit heavy for the pediatricians, I feel. So we'll try to change your mood. And now we are going to hear something different. We'll have some case-based approach. And for that, we have someone who is difficult to bind to a particular locality, but still we take pride to say that he belongs to our state. So we welcome Dr. Narayan Prasad to come and talk about the case-based approach. And we are very glad to welcome you, sir. And for this session, we have chairpersons, Dr. N.P. Narayan, sir. He is ex-HOD Pediatrics, PMCH. Dr. Gopal Prasad, who is HOD and Associate Professor at Patna Medical College and Hospital in the Department of Nephrology. Then we have Dr. Birender Kumar Singh, Senior Consultant Pediatrician, and he is Assistant Professor at IGIC Patna and Pediatric Cardiologist. We have Dr. Anil Jaswal, who is Consultant Nephrologist at ISN Hospital, Patna. And we have Dr. Chandan Kumar, Consultant Nephrologist at Department of Nephrology, AIMS, Patna. So all the chairpersons are requested to introduce our speaker, Dr. Narayan Prasad, and we are very glad to welcome you, sir.
Thank you, Dr. Madhu. Very good afternoon, all of the delegates. And it's a great initiative. And I thank Dr. Hemant and his team, Dr. Om and Dr. Amresh, who have made this possible. And this is a great initiative, especially if you account the state of Bihar and the, you see, quantum of pediatric nephrology cases. But it's quite unfortunate that we don't have that kind of super specialization right now, very much in practice right now. And sometimes it becomes very difficult for the nephrologists, I mean, who are really adult nephrologists and trained in adult nephrology, to tackle with these kind of pediatric nephrology cases. So I am sure that this is a great initiative. This is the first of its kind, and it's a very innovative idea. And I really congratulate the whole team. And today's speaker right now is Dr. Narayan Prasad, who is professor and head of Department of Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And I appreciate that he is from state of Bihar.
I am from Patna Medical College only.
Yeah, that's right. That's right. I'm very, very thankful to you for that correction. Yes, that's right. And subject also is very lucrative for all the pediatricians, practicing pediatricians, who will find it sometimes difficult, you see. We are getting the steroid sensitive ones, which are in everyday's practice. But sometimes we are really stuck up with these kind of cases, which are difficult ones. And I think Dr. Narayan Prasad is going to address that issue. Sir.
Dr. Narayan doesn't need any introduction. He is son of soil. And I think his deliberation will enlighten us with such a difficult subject of nephrotic syndrome in children. We are getting our day-to-day practice nephrotic patients, and we face so many problems. And I think Dr. Narayan will enlighten us. Dr. Narayan.
At the outset, I would like to thank Professor Hemant Kumar, sir, and all the organizing team members, Professor Om Kumar, all the team of East Zone, who is organizing this great meeting. I always become nostalgic whenever I come back to Patna, so that is already there. And we all understand we have not to speak on this slide because the steroid sensitive nephrotic syndrome might have the different courses like infrequent relapser, frequent relapser, steroid dependent and resistant. And we all by this time know that complete remission can be achieved in 30% of the patients at the end of the treatment. And many of 31% patients might be frequently relapsing, 40% may be infrequent relapser. Some of the patients may become steroid non-responder. The good thing is that the only few percentage of the patients reach to end-stage kidney disease. So coming to this, you can see here there are 3 photographs of the patients. All 3 children have similar phenotype of the nephrotic syndrome, but when we look at the genotype, that were different and the patient has been treated differently. So coming to the case first, nephrotic syndrome child, steroid responsive initially in 2003, remained in remission for 3 years, relapsed in 2007, started on steroid, but no response this time. Cyclophosphamide has been given for 2 months. Kidney biopsy has been done. The patient has turned out to be focal segmental glomerular sclerosis. And subsequently, the patient has been treated with the cyclosporine for almost more than a year time with AC inhibitor. Partial remission achieved. Urine protein was 2+, serum albumin was 3.5 gram. And in view of some declining renal function and due to cosmetic side effects, that is very usual in the practice after starting cyclosporine, the cyclosporine was stopped. He remained in partial remission with the AC inhibitor on low dose of the steroid for 6 years, so approximately. In February 2007, he had severe relapse with proteinuria. Serum albumin came down to 2.5 gram per deciliter. He has been treated with a 4 dosage of rituximab, monitored CD19 count, achieved 0 cell count, but showed only partial remission. Albumin a little bit increased from 2.5 to 3.5 grams per deciliter. The patient has been caught in 2017. He came to us at SGPJ. He has episodes of very abnormal behavior, weakness of all 4 limbs and altered sensorium. The patient traveled from Bihar to SGPJ. We have got the MRI done. MRI was suggestive of acute demyelinating syndrome. And patient has been immediately treated with a 4 doses of methylprednisolone, and patient improved a lot with a little residual damage of the bleaching. He was in partial remission with a serum creatinine value of 1.7 to 1.9 up to December 2019. And after that, he has been caught in COVID and he could not turn out for 2 years. When he came back to us in 2021, he developed end-stage kidney disease, hence initiated on maintenance hemodialysis. He was worked up for living donor transplantation. His father was the donor. With induction therapy of the antithymocyte globulins, patient has been successfully transplanted and he has been discharged from our kidney transplant unit. The second case we can see is 7-year-old boy with nephrotic syndrome. So partial response to multiple courses of steroid, achieved plus minus partial remission. Kidney biopsy was done. Light microscopy was showing minimal change disease. IF was negative. Electron microscopy was not done. This biopsy has been done outside. Cyclophosphamide was added with steroid and developed, but patient developed leukopenia and thrombocytopenia. That is very common with this 3-month therapy of cyclophosphamide. When you look at the search for what are the different options for the therapy for this group of the patient, levamisole, cyclophosphamide, mycophenolate mofetil, CNI, and amongst the CNI, tacrolimus versus mycophenolate mofetil. Mycophenolate mofetil versus cyclosporine. When we look at the crossover design of the one of the study, what they have shown, usually MFF inferior to cyclosporine, but when you get this adequate AUC of mycophenolate mycophenolic acid, then the response rate is similar. And tacrolimus is looking like relatively better than mycophenolate mofetil and cyclosporine that I will show you. We have in early 2004, we have done pulse cyclophosphamide therapy for this group of the patient, and we have successfully demonstrated these patients had relatively less toxicity as compared to the patient on the oral cyclophosphamide. So this child was added on tacrolimus with a steroid. What to do next then? And there was no response at all. So we have thought that we should go for the genetic testing, and what we have got, NUP107, that is a very uncommon genetic mutation, but reported in the literatures that can have the steroid-assisted nephrotic syndrome. So this patient can be avoided with steroid, repeated courses of the steroid. Case scenario 3. Here we can see 3-year-old female child, edematous illness. Again, started on this course of the treatment of the 2 milligram per kilogram of the steroid for the 6 weeks. And what we have reassessed at 4 weeks, edema was persistent, proteinuria was 2+, serum albumin was still low. So as per definition, we can go for, although hiding, there's someone takes 6 weeks of therapy, someone takes 4 weeks, but for all practical purposes, 4 weeks is standard. So what to do next now? So this patient has been biopsied. Biopsy was showing again minimal change disease, no response to steroid. And we can see the biopsy report was showing the minimal change disease. So what to do next? Genetic analysis, when we have done, no pathogenic variant in the genes responsible for steroid-resistant nephrotic syndrome has been reported. So then now what to do? So what we have done, initially many patients responds to the extended course of the steroid. But at that point of the time, one of my PhD was working, and we have got the PGP expression on the lymphocytes, and that expression on the flow cytometry was 11%. So this is the one pump which efflux all the drugs from inside cells to the outside. There is no drug available to action on the receptors. So what we have tried to do, we have given this tacrolimus was added, and the patient achieved partial remission at 3 months and complete remission at 6 months. So this was the one new way to add on the therapy, particularly when you have the difficult cases. And PG expression on the lymphocyte declined to 1.9% at 6 months. So this was the one, despite common monogenic resistance, what we see, we might have the pharmacogenomic aspects of the steroid resistance. So what is the difference in the steroid sensitivity in the same disease? Why some patients respond to higher immunosuppression? We have 3 scenarios, as Dr. Anil Basudevan has already spoken to us. You might have the alteration in the podocyte structure and function. Non-genetic mechanisms could be there of the steroid resistance or poor response, or some genetic mechanisms. In case 1, what we have seen, there was transformation from minimal change disease to FSGS. You might have the permanent damage to the podocytes due to repeated injury because of the so-called circulating permeability factors. And there is no podocytes, there might be podocytopenia, there might be the permanent injury in the form of the fibrosis or sclerosis of the podocyte, and there is no cells to act on. So that was the case 1. In case 2, we have seen new gene mutation, and that was the reason of the steroid resistance. Third is the more important. In third cases, what was the reason why he has responded to increasing dose of the immunosuppression? So what are the things which can, is there any biomarkers to detect whether this patient is likely to develop to a steroid resistant or in FSGS, MCD patients into FSGS? One study has shown IgM nephropathy, 50% chances that on repeat biopsy patient may develop FSGS, or one of the biomarker like PAX8 positive cells. If this is, it is epithelial cell biomarkers. If it is positive, then also the chances of progression to FSGS is high. What is more important for all of us, for the clinician, what we can see? Monogenic causes steroid resistance, it is very certain, but you can see in this study, what we have been seeing, 25% of the patient has responded to increased immunosuppression. If you are adding on, this patient was all patient steroid resistant, but when we have increased the dose of the immunosuppression, particularly the CNI, the patient have responded, 25% patient has at least responded, and some patients of them from the monogenic cohort also responded to the treatment. That is basically about 2 to 3% or 4% maximum. So what are the evidences of the efficacy of CNI in SRNS? These studies have shown definitely it is better than placebo. When you have this active control, then it has similar effect like the CNI tacrolimus comparing with cyclosporine. But when you have monogenic mutations, then response rate is very less. When without monogenic mutations, response rate is 68%. So we should think of not all steroid resistant patient, nephrotic syndrome patients are monogenic mutations. They are amenable for the treatment. At least in 70% of the patient, after increasing the dose of the immunosuppressions, you may get some response. We have our own study, which we have followed for the long time. Patients were cyclosporine versus tacrolimus we have tried to get, and all patients were steroid plus cyclophosphamide resistant. what we have seen, tacrolimus was relatively better than cyclosporine, and patients also responded. Why do we believe the genetics play a role in the development of steroid sensitive nephrotic syndrome? Dr. Rajiv was just asking Dr. Vasudevan, is steroid sensitive nephrotic syndrome can be genetic reasons? As this is a suspicion. We have many patients who have the familiar brother, sister, and all children are having this nephrotic syndrome. So definitely it comes in the mind. Some of ethnicity role, like the South Asian and African American descent, has a higher incidence of nephrotic syndrome than children of European descent. So when you have the genetic background, ethnicity influence, and environmental trigger, some of the patients may develop nephrotic syndrome, and these patients might be the genetic factors which is causing underlying playing role in development of nephrotic syndrome. So monogenic causes you can see only in 30% patients, and 70% patients might be immune mediated mechanism, something non-genetic immune mediated mechanism you're working and causing this nephrotic syndrome, steroid assisted nephrotic syndrome initially, and who can respond to increased amount of the immunosuppressions. So Mendelian inheritance of the steroid sensitive nephrotic syndrome, these are the 6 genes which has well documented in the literature that are associated with the steroid sensitive nephrotic syndrome, and it has been hypothesized all these genes when comes together might have the complex interaction to each other and might have the phenotypic appearance of the nephrotic syndrome, may present as a nephrotic syndrome. And as already Anil Vasudevan has pointed out, HLA-DQ has been most studied and associated with the steroid sensitive nephrotic syndrome particularly, and the complex inheritance. Almost 6 genes are all coming together, partially affecting each other, and it is possible that they may develop nephrotic syndrome. So here is some of the factors what we can see. Pathogenic non-self antigen, pathogenic self-auto antigen, antigenic stimulus, HIT1 and HIT2. HIT1, HLA susceptible, and HIT2 when you are trying to modulate T cell or B cells, and then abnormal T cell functions, and the patient may develop nephrotic syndrome. So steroid assisted nephrotic syndrome, genetic FSGS, no recurrence after renal transplantation. That is very helpful if we can test before. Immunological sporadic cases, FSGS, treatment responsive, 40 to 80% of the cases, but recurrence is high. And CNIs are usually the drug of choice. So response usually in 2 months, but should be continued for a longer period of that time. Present recommendation is for at least 1 year. Previous recommendation was for 2 years. And we have experience, and there are several literature evidences. They have used up to 9 years or 10 years, and then the patient went into complete remissions. So non-genetic mechanism of steroid assistance could be there. One of the important mechanism, what we are trying to emphasize, it is possible that glucocorticoid receptors on your putative target like the lymphocytes might be less. Nuclear factor kappa beta, that is involved. So these kind of the mechanisms are also working besides your monogenic causes of steroid assisted nephrotic syndrome. So gene associated with the steroid assisted nephrotic syndrome already talked by Dr. Anil Vasudevan, like coenzyme Q, you can see mitochondrial proteins. Very much now amenable to treatment. We thought that many literatures came. If you can detect, you can supplement with the coenzyme Q and patient may get better. So from this slide, what we can see, 44% of the patient by exome sequencing issues are not resolved. Issues remains unsolved. And there where we have the clinician have to play a wise role by increasing the immunosuppression, looking at the response, clinical response becomes better here. So other mechanism of steroid assistance like CNI can act, as Dr. Vasudevan has told us, on podocyte, you have already calcineurin receptors. They can stabilize the cytoskeleton and can reduce the relapse, can make it steroid sensitive. And one might be the totally different mechanism, disease entity like the Alport syndrome. In our series, I will show you of the 68%, 5 patients gene turn out to be Alport's genes. So pharmacogenomic aspects, as I was talking about the PGP. PGP is an efflux pump present on the cell's border, particularly on lymphocytes. It does not allow the steroids or any drugs to go into the cells to act on the receptors. So that's how they can cause steroid resistance. So this was the 8-year-old child developed nephrotic syndrome treated with the steroid non-responsive at 6 weeks. PGP again showing some in the range of more than 9% of the expression of the PGP always turn out to be steroid resistance. So added tacrolimus is the substrate as well as inhibitor of the PGP. So when you add on, it inhibits the PGP, level becomes better and the patient responds. So this was the one from our study which has been published in pharmacogenomics journals, the Nature's journal, and here we can see if the expression of the PGP of more than 7% and MRP expression of more than 9%, it is possible that you can detect sensitivity and specificity of 90% and 80% that the patient is likely to develop steroid resistance in the beginning. So T cells and PGP expression during relapse and remission. This was another our study which I've shown. During the relapse, PGP expressions go up. As soon as this patient go into the remission, this PGP levels go down. And similarly, we can see that T regulatory cells during the remissions go up, and effector T cells like Th1 cells and Th2 cells go down. So there is a role of epigenetics also. So for that, we have what we have studied, what we have seen here. Here is the acetylation and deacetylation. Acetylation of the histone leads to opening of the two strands of the DNA. There is increased formation of the genes, particularly the pro-inflammatory genes. But when we use theophylline, which can block, which we can stimulate HDAC, then strands do not open up, and there will be no further release of different kind of the cytokines, and there would be no steroid resistance. So this makes the steroid availability better and action on the site, particularly on the receptors, a little better. And what we have demonstrated in our lab that as the PGP expression go down, HDAC expressions go up. So genetic and non-genetic steroid resistant FSGS can be there. Non-genetic, first choice is CNI. Genetic SRNS, no response to CNI. Only a few like WT1 or nephrin associated nephrotic syndrome may respond, like NHSP genes like photosyn protein can respond to some extent to some of the immunosuppressions. There is no podocyte stabilizing effect of cyclosporine. Rituximab can also have the direct action on stabilizing the cytoskeleton. Some precision medicines again comes into the role, as Dr. Anil Vasudevan has pointed out. When you have the extrarenal manifestations in this form, you can think of there is something else is playing a role, and we can investigate the patient for that syndrome. Rituximab, again, Dr. Aditi has published this paper in NEJM. At that point of the time, 2007, 5 patients, 3% went into complete remission. But the same group has again a study, and same group has again a study, and they shown only 70% of the patients may not respond to the rituximab if they are truly steroid resistant nephrotic syndrome. So we have different panels here. We can see in infantile group what we have to test, in adolescent what we have to test, and these are the different genes panel that is already readily available, commercially available. We can get now. This is our SGPJMS data. We have patients of 69% we have got genetic testing. What we can see, you cannot see in the list any common genes. So NPHS1, nephrin, or these genes are not NPHS1, NPHS2 are not common, not seen in single patient. What we have seen, abnormally we have seen the uncommon genes like NUP1, NUP2. What we can see, we have seen actinin. What we have seen, INF2. So uncommon genes have been reported, but common genes are not in our scenario. So we have to think of, we have to see the multicentric study. But Vasudevan has also published one genetic analysis in steroid resistant nephrotic syndrome patients. And there also probably one patient might have the NPHS2. So it is looking like it is very uncommon mutation in Indian scenario. These are some of the drugs, and that if the patient do not respond, these are difficult to treat patient, we can think of taking this patient into the drug trials rather than going and thinking of and repeating the same kind of the drugs again and again. So novel therapies for the FSGS, what we can see, modulation of immune system and inflammation, rituximab, ACTH, abatacept, adalimumab, some antagonism of circulating factors like galactose, some antifibrotic, some stem cells. We have to think of whether the patient has the obesity or hyperfiltration related injury that is unlikely to respond. If your patient is obese, do the biopsy, see whether this is really due to obesity or this FSGS like lesion or podocytopathy which you are seeing is related to obesity, or it is related to some nephrotic syndrome kind of problems. So thank you, ladies and gentlemen. Thank you for your kind attention.
Thank you, Dr. Narayan Kuchhat, for your wonderful deliberation. And it was well backed up by your own researches. And definitely, I mean, we were moving from genetic to immune system disturbance, and then PGP and lot many things which we learned today. Thank you very much. And I think House will be open to questions, but before we have some comments from our chairperson.
Thank you, Dr. Prasad, for your nice different type discussion about the different types of difficult nephrotic syndrome. We have learned from your discussion, and we also practice it, that once the child is not responding to your steroid and they have become resistant to steroid therapy, we should refer the clinician like you. And we are doing the same thing in our practice also. Thank you very much for your highlighting the different types of difficult cases of nephrotic syndrome. Thank you.
I think House is open for questions or comments, please. Quick, one or two. Yes, please, please, take the mic. Introduce yourself and take the mic.
Good afternoon, sir. I am Dr. Chandan, pediatrician. Very simple question, sir. If a child diagnosed at first time as a nephrotic syndrome, we started steroid. We go on for the 6-week daily treatment. When we came to alternate the therapy, after 1 or 2 weeks, suddenly started again proteinuria. Previously was protein nil, now is 1+, suddenly going to 2+. We tested for infection, there is no infection at all. What to do now? We are already on alternate therapy. The proteinuria increasing day by day. We should go back to 2 milligram per kg, or we should add something or continue with alternate therapy.
Yeah, this is looking like the steroid-dependent nephrotic syndrome. If during the tapering or within the 2 weeks of the stopping a steroid, if the patient has a relapse, it is steroid-dependent. But you should demonstrate it on 2 occasions if the same thing happens. So then you establish the diagnosis of steroid-dependent nephrotic syndrome. Now you have to see, there are 2 approaches. One, you can again increase the dose of the steroid, get the remission, and do on tapering. But always it has to decide by the clinician, and we have to explain the patient or patient's parents whether you want to take the toxicity of the steroid or you want to take the toxicity of other drugs. It is better to take the toxicity of other drugs rather than steroid, which is broadly thought to be the more immunosuppressive and the more metabolic complications and other problems. So I will definitely like to, if it is established steroid-dependent nephrotic syndrome, we will achieve the remission, add on the cyclosporine. Presently, it's my preferred choice, but you can add on levamisole, you can add on cyclophosphamide, and then you can see whether you would be able to taper off the steroid slowly and continue the drugs, CNI, like the 1 year or 2 years of the kind.
So even if it is first episode, we can add on.
No, first episode, actually, you have to demonstrate on 2 occasions, what I have told you. So this is the reason why steroid-dependent nephrotic syndrome should be demonstrated on 2 occasions.
Yeah, Dr. Vasudevan, please take the mic.
Diagnosis of steroid resistant dependent has to be made quite consistently. Otherwise, we are giving a wrong diagnosis to the child. So I think if steroid sensitivity is there, although high dose steroid dependent, they have a far better outcome than a steroid resistant. So making the diagnosis becomes very important. And the use of steroid sparing is to remove the steroids as quickly as possible, not as a substitute for a steroid. That's the other thing in the sense of steroid sensitive nephrotic syndrome. So I think a steroid sparing can be considered after you document a steroid dependence.
Just one thing to add. Aditi, you want to go ahead? So just one thing to add to this, children, as I tried to, I think for lack of time, I could not sort of focus on this issue, but children usually present commonly between 2 to 4 years, and the children who are presenting earlier tend to have a longer course. And if we start things like CNIs very early on, then imagine how long this child will need to be on such a drug, and may even have develop a CNI dependence. CNIs we know are nephrotoxic, and therefore I think from the pediatric nephrology point of view, what we would suggest is try the other medications first. If in your patient you have a very high, you will probably have a very high steroid threshold. So in that patient, maybe levamisole may not work, but MMF, cyclophosphamide, etc. might work. In children who are relapsing with a lower steroid threshold or FRNS, you could try levamisole or long-term alternate day low-dose steroids. So we would suggest that try the other options first before starting CNIs, because we have to take them through this long course of childhood and ensure that they do not have any long-term toxicity from any of these drugs, if possible.
Seems logical. Dr. Narayan, please.
Yeah, very clear, please.
If I may, I would agree with Sushmita ma'am and Anil here. The approaches to treating pediatric nephrotic syndrome are centered around certain assumptions that the disease is going to last about a decade. You tend to have frequent relapses early on, and then later the disease becomes infrequently relapsing. If you exhaust your options early on, you will not have anything left to do later, plus you will add on toxicities right away. The first relapse has to be treated in a substandard manner. As in your child, the child has just relapsed on alternate day once. It might just be by chance. He's not doomed to be a steroid dependent. Treat the relapse, see how he does. Maybe he will not have a bad course. Let's see.
Thank you.
And there is one more question.
Yeah, please.
And because there are so many controversies, like suppose first time only we grade it as a steroid dependent, we finally document it. Then is that the right time if we start, because there are different protocols. Some say that you start low dose steroid along with levamisole. Some say you start only levamisole. Some say you go for mycophenolate mofetil, because as you have told that in the beginning, because steroid toxicity also, because it has to be done in the long run. So, can we have a very clear cut protocol?
Yeah,
we have
this
that
is
in our
already guideline there of this
Guidelines
Indian
in
Society of
2021,
Nephrology.
May 2021.
In short, just low dose steroid with levamisole, or just low dose steroid for the first time,
I'm
what
just-
his case is.
What I practice, I am just telling you. When I see there is no too much of the steroid toxicity, if the patient is able to maintain of the 5 milligram alternate day therapy, we try to maintain them on the 5 milligram alternate day therapy. Patients do well. You have to monitor over the growth. You have to see other metabolic complication on the child. If too much of the steroid toxicity, we don't continue steroids. Always we try to shift on. If a high dose steroid dependency is there, clinical suggestions will always be there. Use either cyclophosphamide or go for the CNI. Usually levamisole does not work too much. So levamisole, if milder low dose relapse is happening, levamisole we used to in day-to-day practice of what I'm trying to tell you. We maintain on the levamisole. If there is high dose requirement, we go on the CNI or cyclophosphamide gives for 2 to 3 months. Now cyclophosphamide is again coming back. Definitely toxic medicine, but you have to monitor. This is the responsibility of the clinicians to do in day-to-day activities, in day-to-day practice.
How much length of time, you go for this cyclophosphamide? 4 to 8 weeks or 6 weeks?
Sir, 8 to 12 weeks are the standard. With many times initially we used to repeat it also, but it should not be more than 150 milligram per gram body weight total cumulative toxicity.
Right. I think last question, please.
Sir, I am Dr. Pritpal Singh, additional professor at Nephrology. Sir, My query is regarding NGS reports in patients with primary SRNS in pediatric age group. Most of the times, but our team has found that they are heterozygous and of variants of unknown significance. If they are clearly pathogenic, we stop immunosuppression or do not start it. But what is your approach or take on these patients whose report is heterozygous and not known to be pathogenic in reports and unknown significance? Sir.
So these are the few things emerging that you can know. We go on, search out the literature, see the reports, whether this was associated with any times in steroid-resistant nephrotic syndrome, what is the suggestions comes in. But definitely now there are different genes panel which are showing that this is clearly associated with these monogenic genes mutations. But as I have spoken out, it is only seen in 30% of the patient. 70% patients, it remains unresolved issue, and there you have to find out some other region of the steroid resistance, and we should work on that. We should increase the immunosuppression, see what is happening. Many patients, most of the patient responds at least 6 months of the heightened dose of the immunosuppression, particularly the CNI. If within 6 months, if it does not respond, even then we will suggest that you can continue for the longer period of time. Many patients respond so long later on, but within 6 months, if do not respond, chances of response becomes a little lesser.
Okay, Dr. Rajiv, last question.
Sorry. Just one comment about this VUS, like don't take the report by just on the paper of it, because we have got experience that often this VUS that is reported there may be true also.
True also.
So
Yeah, we have to go to a setback literature.
Advisable to consult a doctor who is more in like a nephrogenetic. For example, I often call Anil or have discussion with my colleagues abroad. So please don't take the report as it is.
That is just computer-based matching.
Thank you. Yes, thank you. Thank you, Dr. Narayan Prasad. And it was success of your talk that you aroused so many of questions. Thank you very much.
Now we are to hear Dr. Aditi Sinha from New Delhi, and she would be talking about use of rituximab in childhood nephrotic syndrome, lessons learned from various trials. So we pediatricians are hardly using this molecule, so we are very eager to learn about it so that in future we can use it and take help from nephrologists like Dr. Aditi. So to chair the session, we have Dr. P.K. Rai, Senior Consultant Nephrologist at Opal Hospital, Varanasi. Dr. A. Wahid Khan, Senior Consultant Nephrologist at Brahmanand Hospital, Jamshedpur. Dr. Deepak Kumar, Senior Consultant Nephrologist at Department of Kidney and Transplantation, Medanta Jayaprabha, Patna. And Dr. Kaushal Kumar, Senior Consultant Nephrologist at Railway Super Specialty Hospital, Karvigaya, Patna. So chairpersons to introduce the speaker first.
Good afternoon, everyone. As you all know that we are all treating pediatric nephrology patients, and in and day out, we are getting nephrotic syndrome patients. And especially those patients, we really get a lot of difficulties when the patient has got steroid resistant or steroid dependent or frequently relapsing nephrotic syndrome patients. In these situations, we really start with the steroids, we go for CNIs, we go for MMF, but in good number of patients where there is a steroid resistance or steroid frequently relapsing nephrotic syndrome patients, in these situations, we have to resort to the other drugs like rituximab. Now, I request Dr. Aditi Sinha, who is additional professor in Department of Pediatrics, AIIMS, New Delhi, And she has got a vast experience of treating steroid resistant and frequently relapsing nephrotic syndrome patients with rituximab. And she is going to enlighten us with her talk on this topic, where to use rituximab in pediatric nephrotic syndrome patients. Dr. Aditi, please.
Thank you, sir. At the outset, I'd like to thank the chairpersons for introducing me to, and Professor Hemant Kumar for inviting me to this session. I am very, very grateful to you, sir, for this honor. This opportunity to teach about rituximab in pediatric nephrotic syndrome is a bit, I would say that it's a bit of a niche drug, an agent that you would use only in specific circumstances. And by no means should it mean that it should become very prevalent in its usage. This is just discussing about a drug that should rarely get used in most scenarios. So this would be the outline of my talk I would like to go through. And I would like to discuss the indications of chiefly in pediatric nephrotic syndrome, because dealing with membranous nephropathy and other adult kinds of nephrotic syndrome would not be within the purview of my talk or expertise. So B-cell targeted therapies, we have heard in the last two talks how increasingly we now understand that it is not just a T-cell mediated disease or just T-cell dysfunction that underlies the pathophysiology of nephrotic syndrome. We now understand that also B-cells have a lot to play in this. And Anil has brought out the serendipitous manner in which rituximab came to be used in nephrotic syndrome and how it was used for ITP. And increasingly, people have studied and understood now that B cells do interact with T cells. And probably it is through this B cell T cell crosstalk that rituximab influences the T cell functions probably, and therefore induces long-lasting remission in patients with pediatric nephrotic syndrome. Now we do know that there are a variety of agents that target T cells and B cells through their various receptors, and rituximab is but one of them. Rituximab acts on the CD20, and what it does to the CD20, if you can look at on the left side of the screen, it binds to the CD20. It gets internalized, the CD20 gets internalized, and certain pathways are activated within the B cell then, which lead to apoptosis. Now, apoptosis could be due to a variety of mechanisms, and chiefly it is antibody-dependent cellular cytotoxicity, but also complement-dependent cytotoxicity that gets activated, leads to entirely B cell depletion from the circulation. And how this influences the T cell populations is now beginning to be understood. Now, CD20 is not expressed by, say, all the cells. So the pre-B cells are not expressing it. It is being expressed in the later cell stages, and then it is not anymore expressed in the late plasma cells, etc. Therefore, theoretically, IgG production should not get impaired by use of rituximab, because late plasma blasts and plasma cells do not have CD20. However, by repeated usage, if you are going to deplete out the initial population, probably you lead to hypogammaglobulinemia. We also know now that there are a variety of other molecules that have come into play, which are, so rituximab is chimeric, and by that look at the heavy and variable chains of the immune globulin and see that only 75% of it is human origin and 25% is of mouse origin, whereas there are certain humanized antibodies, which we'll talk about, which are probably more safe in the sense that they might have potential of causing less side effects. So T cell binding of rituximab to the CD20 leads to B cell depletion, and we don't exactly know how this happens, but then the CD20 gets internalized, certain calcium channels and pathways are activated, and through a variety of mechanisms, the entire B cell population is wiped out. Now we also know that B cells are not just present in circulation, they are also present in other lymphoid organs such as lymph nodes and spleen, etc. And depending on the dosage, you may or may not be targeting those organs also, but slowly and slowly the B cells come back, both by regeneration, new population coming up, as well as by release from these reservoirs. And by 4 to 6 months, usually B cells are back in circulation, and potentially the action of rituximab has gone away. The mechanisms in nephrotic syndrome are proposed to be many. We now understand that how they influence T cell populations is by increasing the T regulatory cell compartment and down-regulating the Th17 cell compartment. Now, Th17 T regulatory axis has come to be understood as an important player in various autoimmune conditions and also in nephrotic syndrome, being linked to the relapse state of nephrotic syndrome. And correcting this probably leads to improvements in the state in rituximab, in nephrotic syndrome, leading to remission. We don't know exactly whether it acts on the podocyte or not. There are probably 1 or 2 papers that talk about how it binds to podocytes on the SMPDL. There are also papers that say that it might be influencing the CD80 excretion from the podocyte. podocytes, and so on. But all said and done, after that serendipitous exposure of that patient with ITP, which was reported in 2006, there have been a variety of experiences that have been reported all across the world, which talk about improvement in the disease state in patients with steroid-sensitive nephrotic syndrome following therapy with rituximab. So administration of 1 or 2 doses of rituximab at 375 milligram per meter square during disease remission has induced remission lasting from anything from 4 to 17 months after 2 shots or 1 shot of rituximab. Other therapies could get discontinued. There was sustained remission at last follow-up in a variable proportion of patients. And usually these were from Japan, mostly 1 dose, from Europe and Asia, other parts, 1 to 2 doses. And some centers have also used 3 or 4 doses. Now, this was initial practice in the early 2000s, in the second decade of 2000s. And relapse rate reduction was massive. There was considerable steroid sparing. Patients could go off all other drugs. Now, we summarized all this information in our review article in the Nature Reviews in 2013 and showed that there was immense improvement in patient steroid-sensitive nephrotic syndrome. When we looked at our own experience, which we began to use for steroid-sensitive nephrotic syndrome in 2009, and then we summarized this up to 2015 in this paper, in these 2 papers, we looked at 2 aspects. One aspect we looked at was how it compares to say a CNI, and we have demonstrated that there was comparable efficacy as compared to CNI in a small cohort of patients of about 23 patients. So these patients who were anthropometric change, people have demonstrated, including us, that there is significant improvement in body habitus and improvement in height parameters. So then people have done a few randomized control trials. Now, these are only a handful of randomized control trials that have looked at the response to rituximab in patients with steroid-sensitive nephrotic syndrome. The chief topic that I was given was this topic that I have to explain to you what's the evidence of the clinical trials. And these are a few of the trials that have looked at the impact of rituximab on disease course in steroid-sensitive nephrotic syndrome. Summarizing all this, a meta-analysis has been done, which I'll come to, but this was a very important randomized control trial from Japan, which really changed the game for Japan licensing for rituximab. They looked at patients with frequent relapses or steroid dependence, and they did a placebo-controlled trial in which they administered actually 4 doses of rituximab at 375 mg per meter square 1 week apart. And they, on the other side, they administered placebo. And they showed that immunosuppression could be discontinued by 4.5 months. And on 1-year follow-up, patients did considerably better with real postponement of first relapse by several months in the patients who received rituximab versus those who received placebo. They relapsed quite early. Likewise, patients with receiving placebo required to receive other immunosuppressive agents because of treatment failure. Another RCT from this part of the country, from Kolkata, NRS Medical College, Dr. Basu demonstrated in patients with frequently relapsing steroid-sparing nephrotic syndrome, the effectiveness of rituximab vis-a-vis tacrolimus. He demonstrated that when you look at about 120 patients, 60 each allocated to tacrolimus or rituximab, patients receiving rituximab clearly did better than patients allocated to receive tacrolimus. Now, this data was published in JAMA Pediatrics, and it showed that rituximab was not only comparable, but it was probably better than tacrolimus in this group of patients. Now, there is a difference in this. This is an open label trial compared to the Japanese study, which was placebo controlled. This looked at sort of both these studies kind of used it in both firstly diagnosed frequently relapsing as well as later diagnosed frequently relapsing. So it could have been used very early on. We looked at a small study comparing the same 2 agents, rituximab and tacrolimus, in difficult to treat nephrotic syndrome. 20 patients each were administered either rituximab or tacrolimus quite late into disease course when they had failed at least 2 second-line agents such as cyclophosphamide, levamisole, MMF, and had evidence of significant steroid toxicity such as being very Cushingoid, having cataract, raised IOP, etc. We could show that rituximab was not inferior to tacrolimus. However, we did find that after 6 months, the effect of rituximab begins to wane off, and probably these patients require redosing. And that's why you can see that the Kaplan-Meier graph falls off beyond 6 months and patients begin to relapse. Now, this tendency to become frequently relapsing was definitely more pronounced in the patients with rituximab than tacrolimus. Now, what do we have the summary of this evidence from randomized controlled trials for steroid sensitive nephrotic syndrome? There have been 6 randomized controlled trials so far that have been submitted by Larkins et al. In 2020, excluding the study from our center, which came in later. So that was the 7th RCT. So these 6 RCTs, including a total of 269 patients with frequently relapsing or steroid dependent nephrotic syndrome, provided moderate certainty evidence that definitely the risk of relapse was reduced by almost 80% at 6 months and by almost 40% at 1 year when patients were receiving rituximab versus, say, placebo or another therapy. And therefore, this was a very beneficial therapy. However, the meta-analysis also demonstrates a very, very high risk of infusion reactions. So you know that the rituximab is a chimeric molecule. There is a risk of allergic response to it when the administration of infusion is going on. And you can make out that there is almost a 5.8 odds of getting an infusion reaction with rituximab versus getting a placebo. So clearly the risk of infusion reactions is there, for which very, very close monitoring is required, because of which it must be given in very closely monitored environments by pediatric or adult nephrologists. What about going on that topic of what after 6 months when the B cells come back and the tendency to relapse returns? What do you do afterwards to prevent relapses? So people have tried to use concomitant immunosuppression or sequential immunosuppression, that is giving, say, MMF or CNI or some other agent just after rituximab is given, or adding it maybe 6 months down the line. Now, people have shown that there is a high proportion of patients in sustained remission when you use, say, MMF in this way after a single dose of rituximab. And this has been consistently an experience reported from Japan, that if they were to add on or continue to use CNI or MMF following rituximab single dose, the response is better than not adding on. But then what did we really achieve? We continued to give them plenty of immunosuppression. Probably they became even more immunosuppressed than they were before rituximab. And that's the downside to it. When we look at giving 2 doses, we seem not to require to add on any other agent. And this is what has come out in this nice, elegant study, which was an international survey of how people give therapy for frequently relapsing steroid sensitive nephrotic syndrome with rituximab, whether they use 1 dose, 2 dose, or 4 doses, and whether they add on maintenance immunosuppression or not. And this international survey looked at outcomes in relation to these things. So they have shown that if you were to use 1 dose, the time to next relapse is about 8.5 months. If you were to use 2 or 4 doses, the time to next relapse is 12 to 14 months. If you were to add maintenance immunosuppression to 1 dose of rituximab, it makes a benefit by increasing the time to relapse to 14 months. But it has no impact if you are using 2 doses or 4 doses. So that's the main message. So if you were to do 2 doses of rituximab, probably you will get away without adding on maintenance immunosuppression, versus if you were to use just 1 dose, you probably need to get some MMF or something else later in the picture to sustain that remission. Always, it's very important to look at B cell depletion afterwards. So after you give 2 doses, you look at the B cells and you expect to find less than 0.5% in circulation or less than 5 cells in circulation. And if B cell depletion is not there beyond 2 doses, you might want to give another dose, then check for B cell depletion again, and then give another dose to a maximum of 4 doses. So B cell depletion lasts for about 4 to 6 months. What afterwards? Does coming back of B cells predict relapse? Well, relapses almost invariably happen in the context of B cells having come back. But it's not as if once the B cells are back, relapse is bound to happen. The disease really varies. And some people have shown a relatedness between time to B cell repopulation and the relapse happening. Some have not. Adding on therapies, as I said about MMF, there is a Japanese experience that says, yes, it helps. We say that it doesn't help. One uniformly reported recent variable of interest is age at administration. So now we consistently find across publications the fact that the younger you are at administration of rituximab, the more likely you are to relapse early on. So it is better to postpone the rituximab administration to an older age, say beyond 10 years or 12.5 years. And this is coming up in all papers across the globe. Patients who have historically had steroid-resistant nephrotic syndrome course and are now turned into steroid-sensitive course are tending to have a difficult course. So do remember this algorithm. Whenever we are discussing rituximab, do understand that it remains a very, very pricey drug, no doubt, but it is something that has to be reserved for a very, very niche audience. We do not use it indiscriminately. In our algorithm, which we were discussing with Dr. Sushmita as well, and in the questions, rituximab comes really at the bottom of the page, and it doesn't really come up anywhere higher. And that's because of the toxicities associated with it, as also the fact that the later you give, the better it is. So what about guidelines for when would you use it in steroid-sensitive nephrotic syndrome? We would really use it as rescue agent in patients who have failed to respond to at least 2 lines of immunosuppression and are showing features of steroid toxicity. You may use it as an alternative to steroid calcineurin inhibitors in severe steroid dependence, but always administer in remission, rule out infections, ensure B cell depletion, and only give it in a very monitored environment under nephrology supervision. What about steroid resistance? Do you use it in steroid resistance, and what impact does it have? As Dr. Narayan Prasad said, we first reported 5 patients and we found good response in them, either complete or partial response. But maybe that was just the beginner's luck. And then as we turned around to looking at more people, we began to find that it's only about 25 to 30% of kids who would turn around in a situation where you had calcineurin inhibitor resistance and steroid resistance as well. And therein only 25 to 30% would respond. And this has been the overall response rate in various series. Very often these series are an admixture of patients. You might have steroid resistance, but now with CNI use, you have become CNI dependent and steroid dependent. You're no more refractory to therapies. That patient will respond better than a patient who has not responded to CNI as well as to steroids. So that admixture has contaminated this response rate to become 45% in the early reports, versus now when we begin to see it in cleaner cohorts of patients who are just steroids resistant, but also CNI resistant, therein the response rate is rather low at 27% in our work published in 2015. And then again, we look at this randomized control trial from Italy, 31 patients, really no change in proteinuria when you compare rituximab plus CNI plus prednisone on one side to CNI plus prednisone on other side. And if you were to summarize all the evidence as we did in 2013 review in Nature Reviews Nephrology, as also CME et al. Did for 2018 in Pediatric Nephrology, overall the rates of remission in reported literature is 50% with half and half of complete and partial remission. But as I said, this might be an admixture of patients who had responded to CNI but were historically steroid resistant. Overall, non-response predicted progression, and therefore it's worth trying out rituximab in a context of CNI resistance. We also found that late resistance is better responsive than is initial resistance. And probably that's because of contamination by monogenic disease, which will not respond to immunosuppression in the initial resistance, which is not contaminating the population of patients with late steroid resistance. Overall, this is the most recent data set emerging from, again, an international collaborative effort of 29 centers across the globe, 246 children. So Eugene Chan, as well as Gel Talus, as well as several units across the world, have looked at 246 children together. And this abstract is just being prepared for ESPN. And the rates of remission are still at around 32-33%. 42% at 6 months, and patients who had late resistance do better than patients with initial resistance. If you were in partial remission already at time of rituximab administration, you would do better than if you were in non-response state at rituximab administration. Obviously, it's worth trying out because people who don't respond will really go on to have kidney failure. So we look at our experience now in a third domain. Steroid resistance, given a CNI, became steroid sensitive but is now relapsing while on CNI and steroids. That is steroid sensitive relapses. So this is CNI and steroid dependent nephrotic syndrome. When we look at that patient population, something like steroid sensitive disease, but a tougher group, and they tend to relapse very early on. They do respond to rituximab, but they probably require more support, such as a maintenance immunosuppression or more doses of rituximab. So now we are looking at this randomized control trial, which has recently been funded only this year by DHR, and with support from pharmaceutical companies as well. We have funding to randomize 160 patients to switching to therapy from CNI, because you are relapsing while on CNI and time duration on CNI is already 2 years. You want to get off the CNI, but you can't because the disease is relapsing still. So you try out either rituximab or MMF, and this RCT is on way, and probably we'll have better answers 3 years down the line. So overall, in therapy for SRNS in KDIGO guidelines, CNI remains the mainstay of therapy for steroid resistance. We would assess response, give up after 6 months, think about alternative arrangements such as rituximab, but beyond 2 years of CNI therapy, begin to discuss other options of switch such as MMF or rituximab and or discontinuing CNI. So rituximab does find a place in that set of patients. So this is again another algorithm. When you have no response to CNI, 30% cases may not respond to CNI and steroid resistance. Therein, look for genetic causes. If you don't have a genetic cause, consider a therapy add-on such as MMF or rituximab. Likewise, if you're responsive to CNI, but you have had a long time on CNI, you want to get off the CNI because of toxicity or prolonged use, but continuing to relapse, consider use of rituximab. What about redosing and sequential therapy? What is the data on that? Because we know B cells come back, the disease comes back. What do you do then? So there have been attempts at looking at sequential therapy in 3 different manners, either at the occurrence of the next relapse, or at the recurrence of frequent relapses, or the moment B cells come back. These are the 3 strategies that have been in place. People have shown it in adults that it is safe to use sequential redosing at 6 months and you get away. I'm sorry, I'll just need 3 more minutes, please. So, but this sequential administration, when we have looked at our own data set, we have found good use of this practice in patients with the most difficult kind of nephrotic syndrome. Among the steroid sensitive disease, those who have failed 2 or more lines of therapy plus minus a CNI, and in resistant patients who have really been having a difficult course even while on a CNI. And therein we had looked at 250 patients and we have demonstrated good sustained remission for almost 3 years in steroid sensitive disease and 2 years in steroid resistance disease when you're using sequential therapy for 2 to 3 years. Frequent relapses do occur in a small proportion, but it's only at about 10 to 25%. The concern with such sequential therapy is the risks of persistent severe immunosuppression, the topmost of which is hypogammaglobulinemia. As I said, plasma cells do not bear CD20, but then the B cells that form into plasma cells do have CD20, and consistently removing the B cell fraction might have an impact. Secondly, rituximab is said to induce some kind of a switch change in the memory B cells such that IgG stops getting formed in a very small proportion of patients. The other concerns that emerge are latent viruses reactivation, such as BK virus, viruria, or less response to vaccines. Vaccines are an important context in childhood nephrotic syndrome. Adverse events such as infusion reactions, etc., do remain a concern. So we again look at the international survey of use of repeated rituximab. This echoes findings of our own experience. Again, 346 children, relapse-free survival relapse was postponed for 10 months with 1 course, but with subsequent redosing, relapse was postponed further. Adverse events, chief of the list was hypogamma, noted in almost 51%. So adverse events are of few kinds: infusion reactions, low IgG levels, and non-infectious poorly reported, very rarely reported adverse events such as lung disease or other forms of reactions. The risk of hypogammaglobulinemia is immense. This is what we have summated from all various series in nephrotic syndrome, and we find that the overall risk is somewhere around 28%, which is an immense risk, especially with repeated use. These are some less commonly reported adverse events, but very, very sinister side effects. Agranulocytosis is also reported, and the development of human anti-chimeric antibodies can result in serious serum sickness as well as non-response to rituximab. So this is about anti-rituximab antibodies. The third indication for rituximab use is recurrent FSGS. In interest of time, I'll just skip this, but recurrent FSGS is an important indication for use of rituximab in nephrotic syndrome, and this combined with plasma exchanges remains the mainstay of management of such cases. So ofatumumab, just a word on it. Humanized anti-CD20 antibodies have been promoted recently as being useful in the sense that they might have better efficacy because they bind to a different area of the CD20, or they might have less side effects because they are more humanized. Ofatumumab has been anecdotally used for rituximab resistant or patients with rituximab allergies, and you can see that in a variety of indications shown to be useful, inducing remission in a fair proportion of cases. But do look at the 2 RCTs in red. The RCTs did not really provide good evidence for its use, and ofatumumab is far out of reach of the majority of our patients because it's far more expensive than is rituximab. So this is my summary slide, and I'll stop here and take questions.
Thank you. Thanks a lot, ma'am, for a very nice, informative presentation of a very important topic. Now the house is open to receive questions. Yes, sir.
Dr. Aditi, very nice presentation of this rituximab in nephrotic syndrome. I have 1 or 2 questions. You said this could be used as a, instead of tacrolimus long. I have a patient who has been followed up for a long time, for almost 4 years. Patient has been 3 years on tacrolimus, steroid dependent nephrotic syndrome in between. So question, I told the father, he said, yes, sir, if you want now. Question is, what are the strong indications for giving? Because when one person you say it's beneficial, and how many doses to give, and looking at the side effects, is it good? Another question, do we need to monitor with CD19? Yes, how often? And do you believe in giving repeated doses like 375 meters square, or a low dose as we are tried in PGI in patient membranous CN?
May I just have the last slide projected, just for sake of completing this? So, sir, our indications, I think your patient is quite a good candidate for use of rituximab, because you are not able to go off tacrolimus in that patient because of a relapsing illness, and you need to go off it because of irreversible risk of nephrotoxicity to that patient because of tacrolimus. So we would promote using 2 doses of rituximab in that context to begin with, while in disease remission, while free of infections. 375 mg per meter square is the dose that we have conventionally used, and we find that even with this dose, sir, after 4 to 6 months, the B cells do come back. So if we were to use a lower dose, which we have not tried out, or it's not backed by evidence yet that lower doses can work, they will definitely induce depletion, sir. But then there's a rituximab pharmacokinetics involved. The rituximab stays in circulation probably for longer with 375 than with 100 mg per meter square, which will kill off all the B cells that keep emerging. So that's one thing, sir. And we would probably need to redose this patient after 6 months when the B cells come back, while looking at the immune globulin IgG, if it's normal. So needs a mic. If the immune globulins are low, we would be reluctant to use it again. But otherwise, redose for a couple of years for 6 monthly intervals.
No, giving 2 doses, and after 6 months, you like to give full dose of
1 dose, sir.
I mean, 375 milligram per. But
we have not tried out 100 mg per meter square.
Like in mentor trial and the trial membranous, just correlating with it. How long we can go on with that?
We have not gone longer than 3 years. We have not, for risk of toxicities which are yet to be defined.
Good evening, ma'am. So, ma'am, I just wanted to have a couple of questions. One is, what is the role of doing a MAN2 test before giving rituximab? And what are the vaccinations that you give to a child before starting him on a course of rituximab?
In an ideal world, you would do both. MAN2 test, I know that, I mean, most of our kids with nephrotic syndrome would have had a MAN2 test done when they started out with steroids. So we don't really end up doing it again for lack of value also when older. We do screen for infections properly, do a chest X-ray for sure. And if they are infection-free, we would go on without a MAN2 test. That's one. Second, about vaccination, hepatitis B is an important vaccine. Pneumococcal, yes, ideally. Flu shots, ideally every year. These would be things that we would practice. Problem is that patients don't end up getting, say, varicella vaccines because of the long steroid usage that they have been having. That remains a concern. Hepatitis B hyporesponsiveness will be there, whether you're giving it during high dose CNI or high dose steroids or after rituximab. So you'll have to monitor levels and ensure immunity. Flu shots is something we would recommend.
Follow-up question to the previous question that was answered. In our experience in Chandigarh, I mean, I at least screen for my adult patients, I'm talking about tuberculosis, and we find roughly about 30% of the patients have biopsy proven or other evidence of active tuberculosis, even though they are afebrile. So, I mean, it may vary from institution to institution, but screening does help, but again, it carries the burden of anti-tubercular therapy before you embark on the therapy with Ritux.
Hi.
Oh, hello. Thanks very much. Yisan Say here. I'm from the UK. Yeah, that's a very nice talk. We've been using rituximab for over 10 years now, and it's really good. And as you said, it's very effective. For children who've got steroid, who've got SRNS, who've been very difficult to control, but with tacrolimus, they've done well. If you see toxicity on kidney biopsy, would you change them over, or would you keep them on tacrolimus despite a little bit of toxicity?
We would change them over. If we find toxicity on kidney biopsy, is that your question, that on kidney biopsy, if you find calcium inhibitor induced nephrotoxicity, would you want to change them over to a less toxic therapy? Yes. We would want to move on to either rituximab or MMF in that context.
Yes, I mean, I suppose the question is because tacrolimus is so good that if you change them over, you're likely to lose control. So actually, it's a balance of whether you keep them on something that works or you change them.
Excuse me, sir, you are not audible to the, your questions are not audible.
Okay, so I think what he intends to ask is that you are, suppose you have a patient with steroid-resistant nephrotic syndrome who has entered disease remission with tacrolimus and he's doing well. And you rebiopsy and you find some evidence of toxicity. Would you want to, whatever? I mean, what do you call it? Rock the boat by giving rituximab and risking another relapse while getting him off tacrolimus or not. So usually the nephrotoxicity would emerge beyond 3 years or so of tacrolimus use, not earlier than that. And around that time, when we have used this strategy, if you were to look at the Kaplan-Meier's, I mean, we've done really, if you monitor the B cells and you give another dose and you give another dose, you stay off CNI as well as steroids in 90% of kids. The Kaplan-Meier's are that high for the relapse-free, so at 2 years. So I think once they are in remission, if you were to administer that, monitor B-cell depletion, look for repopulation, administer again, we have managed like that. But it's a difficult disease. You miss one dose of rituximab and the relapse comes back and it's back to resistance.
Only one question. Yes, Dr. Narayan.
Aditi, thanks.
Dr. Prasad also. Yeah, ma'am.
So you touched on hypogammaglobulinemia, but in the really difficult patients, when you want to redose them, but you are having a hypogammaglobulinemia, do you resort to gamma globulin infusions? And if yes, then how many doses and for how long?
I don't know whether we should be preaching to this audience all this, but I think we should not. We do what we have to do in anecdotal cases, one of balancing risks and benefits. We have had to do this on occasion, that we have given IVIG, we have waited 4 weeks for the immunoglobulin levels to climb up, but that's not what we should be telling that we should do.
Yeah.
Oh, Dr. Narayan. Dr. Narayan,
Just one
that's
comment.
the last question which we are going to.
Yeah. So rituximab, what our experience say, in none of the patient of the steroid resistant nephrotic syndrome who was resistant to steroid plus CNI has responded in our series. Then steroid dependent, you have multiple options. Then you have this CNI, tacrolimus, cyclosporin, mycophenolate mofetil. You are monitored with the AUC. And as far as concern of the CNI toxicity is concerned, sometimes you can just get by acute kidney injury is thought to be fine.
Yeah.
And that can be easily recognizable and you can reverse back. But you are maintaining in this dose, recommended dose, then that is also not the problem. Chronicity pupils of the use of the CNI toxicity do not believe too much. No. Because you can see the many patients of the renal transplant recipients are there on the 40 years, 50 years doing repeated biopsy. And this kind of the fibrosis, which has been done in the 70s or 80s, when cyclosporin came into the picture of the use, very high doses of the CNI causing this kind of the problem of the chronicity, interstitial fibrosis, tularotrophy. Now people do not believe. But then comparison of the rituximab versus side effect profile, that remains important. Like a PC at your institute, that patient has hypogammaglobulinemia, making a lot of confusion for so many different kind of
hypogamma.
So that kind of complication, again, pupils have seen the zero count is making up CD19 count. Again, you are giving the rituximab. Again, it is coming down. Again, giving this. This is the too much of the toxicity for the patient. Do you still believe that we should use repeated use of this rituximab?
I think very often we take a patient perspective in picture, and I think all of us pediatric nephrologists have patients who want rituximab on their rituximab birthday. I mean, Dr. Srivastava has them, Dr. Sushmita ma'am has them, Anil has them. They are like, why don't you give him rituximab? He did so well on rituximab. And we are like, please don't ask for more rituximab because we have had too many rituximab. That's how it often goes the other way. And the other example I'll give you, sir, is 2 years of COVID, we did not use rituximab, and we had so many CNI and AKIs. We had so many CNI nephrotoxicity on biopsy biopsies, which we had stopped doing biopsies for 10 years. Since 2013-14, we have not been doing biopsies for CNI toxicity. I mean, I think it's the experience for many of us. The third argument for rituximab is these kidneys need to last 15-20 years longer than the audience that you probably pander to. That's all that I would say. But I think, yeah.
So with this, we are concluding the session. It was always very great to see so many interest and questions which are coming from the audience. And if there is any further questions, we can you can ask all these questions maybe later at the tea stall. And now we are ready for the next session. Thank you.
Before we move to the next session, I'm sure all of you are looking towards. I request Dr. Sushmita to come to the dais because she has to make some announcements.
Thank you very much. I would take this opportunity to invite everybody, all pediatricians, all nephrologists from the East Zone particularly, to come and attend the Indian Society of Pediatric Nephrology conference, which will be the national conference, which will be held in Kolkata on 13th, 14th, and 15th of October. This is a very important week for us because it's the week preceding Durga Puja. So it's the stars will be right, and I think we can give you a extremely good experience. On the 13th, we will have 3 workshops. They will be on nephrogenetics, on acute kidney injury, and on bladder and bowel management. So these will be small groups, hands-on, very intense workshops. And then the next 2 days, we will have 2 different tracks, one for nephrologists and one for general pediatricians. Our theme for this conference is from foundation to frontiers. So we will be covering the entire gamut of pediatric nephrology, from very simple basics like nephrotic syndrome, UTI, congenital anomalies, etc., to critical care nephrology, genetics, maybe gene therapy. So we would really aim to cover the whole gamut and make it a very interesting experience for everybody. For this conference, we have a discounted rate of registration. So I would request all of you to avail of this. Rajiv, do you have anything more to add? If you there is a standee in front, and there is a digicode. So if you scan that with your phone, you will be able to enter the registration site and to register online as well, if you would like to. Many of us from West Bengal and from Kolkata are present here. If you have any queries, we can try to answer them. So look forward to seeing you all in Kolkata in October. Thank you.
Thank you, Dr. Sushmita, for your important announcements. And now we are going to hear about journey of nephrotic syndrome in last 50 years. And I think you all would agree that we will feel blessed that we are going to hear someone whose books we all had been reading, and we consider him as a Vism Pitama of pediatric nephrology. So we are very glad to welcome Dr. Arun Srivastava sir to the dais to deliver his lecture. And for that, we have chairpersons, Dr. Jai Prakash, who is consultant nephrologist at Panisha Hospital, Kabir Nagar, Varanasi, and Lifeline Super Specialty Hospital, Varanasi. We have Dr. Harsh Vardhan from our state, who is assistant professor of nephrology at Patna Medical College. We have Dr. Gyan Prakash, who is consultant at Ford Hospital, Patna, Bihar. And we have Dr. P.S. Patel, assistant professor at IGMS Patna. So I welcome all the chairpersons, and I feel glad to welcome our speaker. And I request our chairpersons to introduce our speaker. Thank you. It's there.
Okay.
It is a matter of honor for me to introduce the Professor Srivastava. In fact, he needs no introduction. Some of you may not know it. I just want to share two important points on his personality. Professor Srivastava initiated pediatric nephrology at Albany Institute of Medical Sciences. In fact, he one of the pioneer member to start pediatric nephrology services in this country. Dr. Srivastava is a very humble person. I remember Indian Society of Nephrology conferred on him Lifetime Achievement Award in 2011. At that time, he said, I got the Nobel Prize. That was his expression. So you can imagine how humble he is. And his topic of keynote address is nephrotic syndrome over last 5 decades. I'm also eager to hear his lecture, so we don't want to come in between. I humbly request Professor Srivastava to go with his oration. Thank you, Professor Srivastava. Over to you now.
Thank you, sir. I have your autograph on my award certificate. What I'll do is to you all know nephrotic syndrome is a very common condition, and most of us spend nearly half of our time in treating nephrotic syndrome, either in practice or in hospitals. There is an early history here. Okay. Yeah, it was reported long time back, mostly adults. And the condition, the MS Sarka was noted. It was suspected to be cardiac or renal or hepatic. But in 1484, Rollins in Belgium described 54 children with swelling of the whole body, but there was no mention of kidney. 1722, Zingenball, second description of NSALPA, but urine was not tested, not reported. We all know about the Bride and Bride disease, 1822. In 1905, Miller and Monk defined nephrosis as we know it now. And there was a lot of debate whether it was nephrosis versus nephritis, degenerative versus proliferative, inflammatory. Now we know in 1950s that there were a small number of children who had the secondary condition, but it's mostly idiopathic. Then a very definite report in 1950 by Barnes, Small, and Janway. Some of us, the pediatrician, will be knowing about Janway. They called it lipoid nephrosis. And then early in 1961, again, he called it lipoid nephrosis. And the reason was that on the cut surface, the kidneys were large and pale, and there were lipids in the tubular cells. But there were similar features in many other conditions. So they decided to term it nephrotic syndrome. Initially, the focused on the management of 50 and 60s. It was a chronic recurrent condition, very difficult to treat, and the drugs were not effective. So they provided nutrition, tried to control edema. Now diuretics were simply not available. They tried xanthine derivatives, acetazolamide. We even tried mercurial. We also, I remember myself trying mercury chloride, something very effective, but will knock the kidney out as well. Chlorothiazide, alactone in late 1950s, these were not very effective. There were a repeated paracentesis, all kinds of manipulation. It's only when Lasix came in 1962, then we were effectively able to control edema. Outcome, before 1940s, the mortality rate of 40%. And this was mostly for infections like peritonitis, pneumonia, cellulitis, also thrombosis. Penicillin came in 1944, and then the mortality decreased to about 16%. And when they introduced corticosteroids, it further fell down to about 3 to 7%. And even at that time, we know that many of the, well, small number progress to chronic disease. They even tried ACTH by Metcalf Janeway in this dose. It seems to lead to diuresis and even some reduction of proteinuria, but it was considered hazardous and not used further. Now, cortisone and prednisolone, of course, they caused abolition of proteinuria and clinical benefits. Different regimens for use, but it was like a magic drug. I mean, the way the child responded was really something magical about it. Majority responded, but again, there's a long-term genetic course. They lumped all cases together, but even so, the majority seemed to respond. The renal biopsy was not carried out then, so it was very much a clinical situation. The biopsy was introduced only in 1951. Versen and Brun 1951, they biopsies, aspiration biopsies in adults, a very few conditions. Using the William Silver and needle with modification, the kidneys were localized with plain X-ray film, mainly to make certain that there were 2 kidneys were present. Of course, ultrasound was not available. There were very few serious complications. There was a series of reports from our own training center, UTM Galveston, from 1962 to 76. There was a lot of apprehension in the pediatrician at that time that it will be hazardous to do it. So in our center here, some of us reviewed 890 biopsy consecutively done, the large number. We were doing biopsy left and right, but there was few serious complications, hematuria, of course, but we didn't lose a kidney. So it was followed by, widely adopted. A big landmark, which many will be familiar with, the International Study for Kidney Disease in Children, ISKDC. This really was a big multilateral, multinational study on those times, starting in 1966. They have studied clinico-pathological correlations and treatment trials in 521 patients between 1966 1974. There were 24 centers in Europe, Japan, Mexico, and so on, and large number of patients from England, Japan, Finland, our own center, and all biopsies had light, immunofluorescence, and EM examination, talking 1960, those times, so early on. And all biopsies were seen by 3 experts without knowing the details. And these were Dr. Chur from USA, Dr. White, UK, and Madam Habib from France. Our own people will be familiar with these names. Showing this picture, this is 1966 in London. The first meeting of the group, I show particularly my own mentors, Dr. Travis here, Dr. Drashner, Madam Habib here, Gavin Arnell, Ira Greifer. These are the big names, all big names at that time. A picture 20 years later, this is a Japan meeting, Kamakura. They have gone much older, Dr. Arnell here, and somebody here. And anybody can guess, adult nephrologist, Stuart Cameron. You heard his name? I'm sure you heard. The big names on those times, this is 70s. Now, the major contributions of ISKDC were they defined histological features very lucidly. Description of FSGs, Byzantial proliferative, membranous proliferative, and so on. Features of minimal change disease, 77% were in the patients, and the clinical correlates. And the response to treatment, corticosteroids, and actually even they study cyclophosphamide later on. Now, the initial regimen they used was prednisolone, 60 mg per meter square per day, 4 week. We all know this. And this schedule was empirical. There wasn't any trial, no evidence like that. But even so, this schedule were followed by most centers for the next 20, 30 years. The result was that you could compare the findings in many centers, and most centers around the world followed this. the observations were nearly identical. This is showing the response. It's just like magic, I mean, the majority of children, the first week, second week, third week, it's about 80–90% patients respond within a month. A few take a bit longer. This was something extremely interesting. Now, this was followed for some number of years. Then only the German study group 1993, they described it. This was discussed by Dr. Sushmita here, that using 6 week daily, 6 alternate day may lead to a better outcome. And this was confirmed in several studies. Now, this is the guidelines for many of these groups. The ISN trial, UK saying the 4 week may be sufficient. So we have a choice now to either use 6+6 or 4+4. The global pattern of idiopathic nephrotic syndrome, it seems to be very homogeneous. Age, sex, response outcome-wise. Studies from UK, France, Japan, Australia, India, our own study reported almost similar findings. The incidence, the age pattern, and the response. The incidence of FSGS, basically proliferative, this was also comparable. Again, 75 to 80% have minimal change, are still responsive. So this is no longer called as a minimal change, simply called SSNS, steroid sustained nephrotic syndrome. The long-term course is punctuated by relapses, but eventually most get complete recovery. Briefly, steroid resistant nephrotic syndrome, they have defined how to label these. I think we are doing that now. Many patients have FSGS. And in those times, talking of 70s early, the cyclophosphamide was used in these patients and found to be effective in a good number of patients. And that was the only drug at that time, mind you. And it was widely used, but later on given up. But there was a small number of patients who had late resistance. And there was a lot of discussion whether it was a minimal change to begin with, and it sort of morphed into FSGS. And it was even suggested all these conditions, they form a spectrum at one end minimal change, other end all kinds of things. This was intensely debated during 1980s. I don't know what you feel about it now. Treatment of nephrotic syndrome relapses, this has been discussed by previous speakers. Again, the endoxin was the only drug for about 20 years, and the usage for 2.5 mg per kg, 8 to 12 weeks, led to long remission. And some of the drug, like, almost a cure in some patients. And the benefits have been confirmed, but of course, there are better drugs now. In the beginning, they tried NSAIDs, but these were not effective but toxic. Levamisole came much later, and you have been listening to all the drugs besides steroid. They call it stress sparing. To my mind, this is a total misnomer. To call them steroid sparing is like insulting these drugs. You talked about rituximab and all that. Now, this is very interesting. The mechanism of proteinuria was intensely studied in 70s and 80s. We know about endothelium, basement membrane, epithelial cell, and so on, the food process and so on. And the effacement of food processes were seen early. Now, this is again a picture showing the normal EM here, and the minimal change, the effacement here. Now, this on those times was something extraordinary. I mean, you couldn't believe all this, but it was there, shown very, very clearly. A lot of studies on the composition of the GBM structure and all that listed here. Extensive work in 1970s and 1980s. Now, filtration of proteins are very, very incisively studied. Filtration depends upon size and shape and charge of proteins. High molecular weight proteins and those with anionic charge, they do not penetrate lamina densa. There were clearance studies using tracers, different sizes and different charge. And this was very clearly shown, very elegant study. If somebody is interested, it'd be worth looking at. Now, this is a frightening slide, but very simple actually. The capillary lumen here, the GBM here, the urine space here, and the anionic charge molecules here, the neutral here, and the cationic here. Is really the tracer different sites, ferritin, catalase, albumin, phosphorus peroxide, and so on here. These, the large molecule, they do not penetrate. And here, the neutral one, the smaller ones, they will penetrate, but large ones don't. The cationic proteins, the small size easily penetrate. If the large ones with cationic, so they can penetrate. This is really from 1970s onwards. Dr. Venkat Stalam, one of the leading workers here, worked with us in AIM for some time, then he left. Anyhow, then there was a lot of discussion about the polyanionic charge, and decrease in the staining for polyanionic coat epithelium in the GBM was shown in congenital nephrotic syndrome and also in the pyromycin-induced proteinuria. The GBM was regarded as the main filtration barrier. This is like 1980s, but probably not proven to be causally related to childhood nephrotic syndrome. Then there were some studies again in 1970s, 80s, measuring the size of the molecule. So they measured the protein clearances of different molecules, and they thought, well, this minimal change nephrotic mostly albumin, and finding that could differentiate between the others, but there was a lot of overlap, and this was sort of given up. The pathogenesis or minimal change nephrotic syndrome, we discussed about the immunological changes, the measles and all that, you mentioned that. And a lot of work on the T cell subsets, different kind, but there's no uniform pattern. Doctor mentioned about the circulating factors. Lymphocytotoxin, there was a vascular permeability factor, 1975, lymphocyte inhibitor plasma. These were our historical interest. Findings were inconsistent and inconclusive. And more recently also, Dr. Aditi will tell about the SUPAR and so on, but there is no clear pattern diagnostically. In the 1990s, there was a slight interest in what they call reactive oxygen metabolites. These sort of come into fashion. At that time, for about 7 or 8 years, a lot of studies came in different conditions. And they were thought to be injurious to cell membrane, cell components, and membrane lipids. And lipid peroxidation could be detected by measurement of malondialdehyde in the urine. And pyromycin aminonucleoside-induced proteinuria is the most reproducible model of minimal change nephrotic syndrome. And this can be prevented by administration of free radical scavenger like dimethylthiourea. Our own study here, we are studying in 3 groups of rats, one control, other given pyromycin, other given pyromycin plus DMTA, and shown clearly that the ones who had DMTA, they had little proteinuria, very little proteinuria. And we may have actually measured the glomerular and malondialdehyde and DMTA. But of course, this is out of fashion now. If somebody has to waste time, you can look at this paper somewhere. Now, this is the era of podocytes and genetics, as you have heard a lot about that. Study of podocyte structure, mechanism of injury and repair, genetic abnormalities, and so on. The podocyte injury is involved in everything now. Then everything is working through modification of podocyte structure and function. It probably is not as simple as that, but as Dr. had mentioned, it will take perhaps many years now to translate this into clinical effect or even understanding. Now, steroid-sensitive nephrotic syndrome remains an enigma. advances in genetics, immunology have not led to identifying the etiology and the regimen, or despite guidelines and everything, but the initial regimen, I hope don't fight with me on later, and subsequent management is still debated. The guidelines, are they globally applicable or they're local modifiers? We don't know, at least I don't. The SSNS can be managed successfully and serious complications avoided until the condition remits permanently. That's being done for the last 60 years. Questions are, what initiates podocyte injury that leads to massive proteinuria? Circulating factors are likely but remain elusive. And the mechanism of action of agents, including all these, or do they act similarly at that one point that abolish proteinuria and restore podocyte architecture and function? It's unknown. And what causes relapse? They talk about viruses and EB virus and all that, but not defined still, I think, some time. And what are the changes taking place, what takes place during the relapse? Oh, 3 times it's up. It's up anyhow, I know that. Show my last slide. Last slide दिखा दो मेरे भाई. नहीं चल रहा? बिजली काट दी क्या? नहीं आ रही भाई, कोई बात नहीं. लास्ट स्लाइड नहीं आ रही, आप चला दो. है लास्ट स्लाइड है, नहीं छोड़ दो. Leave it.
You can continue.
I think the slide is missing probably. Oh, thank you very much. That's all. It is actually all the historical interest, but nevertheless, I think that's how things have developed. You take any disease, any condition, that's the way it has come up. Nothing has come with a bang. And when you read this, you really feel how intensely these people, they were not dumb people, they were brilliant people. We met some of them, they're highly intelligent people and doing all this. Now, this may not be relevant, but that's it. That's how history. Thank you.
Thank you, sir, for an excellent talk. And we can definitely take on few questions or comments. Okay. So let's give a big round of applause and standing ovation to
Thank you very much. It was interesting to see the early parts when you were developing the biopsy, left and right. We don't do that now. You were doing biopsy in post-septicoccal nephritis and so on, but that's how we learned. Thank you very much.
Thank you, sir. Thank you.
So good evening again. So after a plenary session by none other than legendary Dr. R.N. Srivastava, I think most of us have tea. So we'll skip that tea break and we'll continue with our second session. The first session, as we all know, it's on nephrotic syndrome, the unasked questions. Now moving to second session, that is on mixed bag. And the first lecture on this session is on revival and survival of CAPD in children. For that, I would like to invite Dr. Sanjay Gupta, who is Senior Consultant Nephrologist at Bhopal. Dr. Amresh Krishna, who is Additional Professor, Department of Nephrology at IGIMS, Patna. Dr. Deepti RV, she is Associate Professor at Division of Pediatric Nephrology, Department of Child Health, CMC Vellore. And Dr. Santosh Kumar, who is Consultant Nephrologist and Renal Transplant Physician at Paras Hospital, Patna, to chair the session. May I request Chairperson to introduce the speakers? And I'll request all the audience to please keep the silence so that this session will go smoothly. Thank you.
Good evening, everybody. We all have now listened to various topics of nephrotic syndrome and their treatment. Now we go ahead in the pediatric population, the most difficult task to deal with, and that is the chronic renal failure and ESRD. So technically, very highly demanding hemodialysis cannot be performed in these patients, and they don't do as well as the peritoneal dialysis, which remains the only alternative to treat these patients. We would be interested in knowing about the continuous ambulatory peritoneal dialysis, which is nowadays very much prevalent for pediatric age group of patients. Dr. Georgie Abraham has pioneered the CAPD in India, and he has been trained with Oriopolis in Canada, who actually invented this technique. He's a professor and consultant, MGM Healthcare Chennai, adjunct professor IIT Madras, president ISOT, founder president PDSI, trustee of Tanker Foundation, 342 publications and 266 abstracts in his back, 33 book chapters, 3 nephropathology CDS, and recipient of many regional and international awards from NKF America, ISN President Sri Lanka, and Federation of RCP UK. So without taking much time, I invite Professor Georgie Abraham to speak upon this technology of CAPD in pediatric CRF patients.
At the outset, I want to thank Professor Hemant Kumar, Dr. Kumar, and the organizing committee for giving me this opportunity. I love this theme, children and kidney disease. Suffice to say that with over 30 million pregnancies in this country every year, we have a lot of children, and we face the challenge of kidney disease in these children, either acute or chronic. The treatment is predominantly either dialysis, transplant, or palliative care. And I would take you through this presentation, what I have done, my experience, and also the experience of my colleagues. So any renal replacement therapy, the most important thing are the cost, the quality, and the accessibility. It is sad to say that even though we have progressed over the last 30 years, the accessibility to flexible or bags which are aseptic and safe for children are not available in the country in half-liter and 1-liter bags. The appropriate catheters are not available. So there is a question of accessibility. Cost, the PMJAY scheme, I also put a recommendation through the ICMR, and it was very nice that the Prime Minister Modi ji has included it in the PMJAY scheme. And the quality, there are issues with regard to the quality, especially the dialysis fluid. And I have noticed, I'm sorry to state that some of the manufacturers, they have inferior quality fluid, which is leading to a lot of peritonitis. And this I have spoken to them, but it is falling in deaf ears. So essentials of a PD program are, evaluation and selection of patients for PD modality options, evaluation and management of medical complications in patients on PD, understanding principles and practice of PD, choosing appropriate catheters, dialysis fluid in small collapsible bags, long-term follow-up, dialysis prescription, modification and assessment of dialysis adequacy, and use of automated PD. This is the first child we started nearly 30 years ago on peritoneal dialysis. This was Kirti, 1.5 years old, referred to me by Dr. Fatke from Bangalore. And I am the one who is holding the kid. I just want to bring you to your notice that when William Kolff started the hemodialysis, the first 15 patients died. He never gave up. So even though many of the children died, not being able to access, and I'm happy that over the last 30 years, with the support of my dearest colleagues who are sitting here, both in pediatrics and in adult nephrology and pediatrician, we have been able to achieve many things. And seeing this photo, it was published all over the country and Press Trust of India. Professor Srivastava is not here. An incredibly fantastic role model he is. And he gave me in a meeting a few months later when I was in Delhi, Georgie, you have done something good. Encourage me. That is the positive attitude of a person who wants to support the country and the people in this country. And recently he was felicitated by Arvind Kejriwal and for his multitasking achievement he has given to the country. And also he has been given a Lifetime Achievement Award by IPNA in 2022. So advantages of PD are fewer side effects compared to hemodialysis, no needle-free treatment, do not have to travel to dialysis center for treatment, greater flexibility and freedom in the treatment schedule, can do dialysis while sleeping, and allows travel and allows children to go to school and also in engaging sports. I will skip that. So what are the absolute requirements for peritoneal dialysis? You need a healthy peritoneum, which should have enough surface area, and it should have hydraulic permeability, and there should be osmotic agent, which is provided through the dialysis fluid. Then these dialysis fluid should be in sterile collapsible bags and a permanent and safe access to the peritoneal cavity using a permanent catheter. So when you look at that, you can see you have the capillaries here, you have the interstitium and the mesothelium and the peritoneal cavity. So you have three types of pores. The first one are the aquaporin pores, which are intracellular. And then you have the intercellular pores and the large pores. The aquaporin pores and the intercellular pores are responsible for the water removal because of the hydraulic permeability and also because of the osmotic agent in the peritoneal dialysis fluid. So if there is a problem with aquaporins, then you may have to use, I have a patient recently, you have to use predominantly icodextrin. So these are the three important components of peritoneal dialysis. Excuse me. Yeah, got it. So I wouldn't go in detail into the blood circulation in the peritoneum, but what is peritoneum? The peritoneum has two layers, the parietal layer and the visceral parietal layer and the visceral layer. And the parietal layer is the one which is responsible for peritoneal dialysis. And you also have the blood vessels there. And as you see that the blood vessels are here seen in the peritoneal in this cartoon. And this has to pass the solute and the water has to pass this distance to reach the peritoneal cavity. And these are the mesothelial cells. So the peritoneum is a serosal membrane that covers the peritoneal cavity, the visceral and the parietal peritoneum. The role of peritoneum is to protect peritoneal organs, prevent friction of moving organs, and host defense mechanisms such as mesothelial cells, macrophages, and immunoglobulins. So when you implant a catheter, it is very important. We don't have suitable catheters for children available all the time in the country. I'm sorry about this complex cartoon. But when you put a catheter, if you are going through the rectus muscle, you should always avoid injuring the inferior epigastric artery, especially when you do a blind procedure. Well, this is how a catheter looks like in the cartoon. This is the outer cuff. This is the inner cuff, which sits on the muscle or the linea alba. So what are the types of catheters? And preferred are a Swannock catheter. I use Swannock because I have used all types of catheters in the last 34 years, but Swannock catheters are the ideal catheters for adult and pediatric peritoneal. And this is a catheter which we have given to, because we make our own catheters, but it is stopped for the time being, and it is being implanted by Dr. Arpana Iyengar and her colleagues in Bangalore. So peritoneal membrane and anatomy, it's a serosal membrane with an area of equivalent to body surface area. 80% is visceral peritoneum, and it gets its vascular supply through the mesenteric arteries and the portal veins. 20% is parietal peritoneum and gets its vascular supply through the arteries and veins of the abdominal wall. Lymphatic drainage of peritoneal cavity is mainly through diaphragmatic stomata. It is a semi-permeable bidirectional membrane continuous with the fallopian tubes in female. So sorry about this busy. So this is the peritoneum again. You have the basement membrane, you have the mesothelial cell. This is the interstitium with the blood vessels. And the 3-pore model. And this is how you prepare for the peritoneal dialysis exchange in a child. You need to take aseptic precautions with mask, clamps, and these are the catheters which we manufacture in Coimbatore, much cheaper than the one you import. And this is the insertion set which we manufacture. So looking at this cartoon, you can have problems anywhere from the dialysis bag, the Y set, the adapter, the catheter, catheter cuffs, exit site, catheter tunnel, and peritoneal cavity and bowel. So the composition of the peritoneal dialysis solution, because we know that it is an osmotically derived solute and water removal. So the osmolality between the 1.5% is about 340. It's about 345, and that of the 2.5% is 395, and 4.25 is 484. But that of icodextrin is 282 because they are large molecules. So terminologies are in peritoneal dialysis are ultrafiltration, a reflection coefficient for most osmotic agent. The glucose has a reflection coefficient of 0.03, so it gets absorbed, whereas the reflection coefficient of icodextrin is 0.7 to 1, so it doesn't get absorbed. Sieving occurs, and this is another property which is important in peritoneal dialysis. So the principles of ultrafiltration are net ultrafiltration equal the volume collected in the and minus the volume installed and the duration of the dialysis dwell. So this is the peritoneal equilibration test, which we do 1 month after the initiation of PD. It shouldn't be done prior to that because the peritoneal membrane characteristics may change. So in child, it is 1100 cc per meter square body surface area. There are different studies which are published, but it is an individual property of the kinetics of the peritoneal cavity and the peritoneal membrane. So what happens with the solute removal during COPD dwell? Diffusion is maximal, and so urea and creatinine equilibration are fastest in the first hour, but become slower as the gradient lessens with time. By 4 hours, urea is over 90% and creatinine over 65% equilibrated in most patients. Dialysate to plasma or D by P ratios measure degrees of equilibration at a given dwell time, and so it could be usually a peritoneal equilibration test. You have it at the end of 4 hours, and they are classified into low, low average, high average, and high. This is depending on the D by P of creatinine, and the drain volume also will vary. In low, they have very high drain volume, whereas in high, it is low drain volume. So framework for PD eligibility, incident ESRD patient, children or adult, peritoneal PD candidates, eligible for PD, contraindications to PD, medical or social, you have to look at it, and barriers to self-care in PD. Then patient start PD in 6 stages, new PD patient, identify, assess, eligible, patient chooses PD, PD catheter implantation, PD start, time on PD, and loss of PD patients. So the loss is either due to technique failure, death on PD, transplantation, or transfer out of the region. So this is PD in children. Dialysis inflow volume is 1100 cc per meter square or 30 to 50 cc per kilogram per exchange. The child is holding the transfer set. This I downloaded. This is not my patient. I downloaded from the internet. So all vaccinations should be given. I know pediatricians are quite familiar with that. Adult nephrologists are naive about it. So I just copied it. And so all vaccinations should be given. So peritonitis in children, I need to acknowledge Sushmita. She wrote this article in Indian Journal of Peritoneal. I'm sorry that I didn't put your name there. So prevention is use of Y connecting system, systemic antibiotics given within 60 minutes before catheter insertion, daily antibiotic application to exit site, prompt and effective treatment of exit site infection, and tunnel infection, antifungal prophylaxis with antibiotic therapy, training by qualified staff, testing skills of a person, and institutional continued quality improvement. So this busy slide, anemia and growth retardation in children on chronic peritoneal dialysis, malnutrition due to decreased nutrient intake, then increased nutrient losses through dialysis fluid, then increased nutrient requirement when there is peritonitis, and the risk factors for growth retardation in children with CKD are malnutrition, age of onset of CKD, underlying renal disease, use of corticosteroids, residual renal function, water and electrolyte disturbances, syndrome associated with CKD, metabolic acidosis, anemia, and hormonal imbalance due to growth hormone, gonadotrophins, parathyroid hormone. So this is recombinant human. I have used it in one of my girls, 0.3 milligram per kilogram per week on 3 alternative days, 3 times, 6 times. And these are the nutrient requirements, infant, pre-puberty, puberty, and post-puberty. And the calories are shown here, and the protein requirements are shown there. And 50% of the dietary intake should be fat, and carbohydrates 35% of the dietary intake, and you need all the B complex vitamins to be supplemented. So the complications are infections or non-infectious. This can happen both in adults and children. And so we need to look at that and carefully evaluate for this. So roots of infections in PD are exit site infection, tunnel infection, contamination, migration from the gut and vagina, and septicemia. So local and systemic effects of PD, long time, high glucose PD solutions, the local effects, high glucose injury to the peritoneum. Then systemic effects are shown in 10% of adult patients on PD will become diabetic in 1 year. Then peritoneal membrane changes are shown here, and the patient malnutrition, obesity, inflammation, atherosclerosis, fluid overload, and metabolic alterations. So this is a paper from St. John's, and when you look at duration of CPD, change in BMI, change in height, centile, prevalence of short stature, residual renal function, PD adequacy, and peritonitis rate between those below the age of below the 15 kilograms and above 15 kilograms. The only thing we showed a little statistical significance is prevalence of short stature. So when it was a structured audiovisual training in the same institution for caregivers of children on chronic ambulatory peritoneal dialysis, a prospective study of the impact on the rate of peritonitis, structural training program in 40 compared to regular training program, you can see that there is a significant difference in the survival functions. This is the survival function over a period of time. Those cohort group who had structured training program did better than the regular group. And even in peritonitis rate also, you can see that there was a significant, statistically significant difference compared to the structured group and the control group. So peritonitis is diagnosed in presence of any of the following criteria: abdominal pain or fever, cloudy peritoneal effluent with over 100 cells per cubic millimeter with greater than 50% polymorphonuclear cells, demonstration of organism in the PD fluid by smear. So this is a bag before infusion, this is after infusion, after drainage, and this is a cloudy bag. So peritonitis take-home message: patient and caretaker education, proper specimen collection and culture techniques to reduce culture negatives, identify and treat peritonitis at the earliest, establish your own center-specific microbial and antibiotic sensitivity data. Do not hesitate to remove the catheter. Microbiologists to be sensitized regarding CAPD and peritonitis. Optimizing outcomes, infection. There are also been a dramatic reduction in the exit site infection with use of topical antibiotics at the catheter exit site, mupirocin or gentamicin ointment. There has been a dramatic reduction in peritonitis in recent decades, but we are still not yet there. So this is another one on peritonitis from the same number 38 during the pandemic phase and 43 non-pandemic. And they found that during the pandemic, there was a very high incidence of peritonitis in this particular institute. So this is one of our patients with mitochondrial deceased child, and there was catheter erosion. See that? And so we were worried what to do with that. Usually you will remove the catheter. No, we can relocate the catheter. See, the catheter was on this side. We closed it in and we relocated without removing the catheter to the other side, and the patient continued on peritoneal dialysis. So management of children with peritoneal dialysis, growth failure, development, nutrition, hyponatremia, hypophosphatemia, poor ultrafiltration, infectious complications, hypogammaglobulinemia, mortality, dialysis consideration, and transplantation. This is another one, a child with bilateral ureterostomy. We did peritoneal dialysis. Later on, after 2 years later, he lost his mother in front of him. They were going in a motorcycle. The mother was killed instantaneously. The child went into depression. He had pseudomonas peritonitis and we lost him. This is the peritoneal biopsy of that child. And this is another child, see that. You want to have a standard child. And this is another one, which we are doing peritoneal dialysis currently with severe heart failure. Hemodialysis, he wouldn't have survived. In between, we had to put in a jugular line to remove the fluid because he went into fluid overload. So conclusion, CAPD and APD are two modalities of RRT in children. Nutritional advice and growth monitoring are important. Prevention and treatment of peritonitis should be center specific. Anemia correction and CV monitoring is essential. Mineral-borne disease should be assessed periodically. Target for adequacy dialysis should be followed. Thank you for your kind attention. Thank you.
Thank you for the excellent overview, sir. It's open for discussion now.
Sharma.
Like to put on record your contribution in the field of peritoneal dialysis. And I don't know what is your experience. Like when I was in SDPGI, the PD really picked up. Despite patients had to pay for it, it was not a free treatment. But in the corporate sector, PD is a very neglected therapy because of so many reasons. The other interesting thing in PD, I think pediatric patients can be managed best with the PD because of so many reasons. But when we were having a very active PD program and majority of patients were adults, the pediatric patient number was not that significant. And what has bothered me in India is that children with nephrotic syndrome would be taken care of, but children with chronic kidney disease, and especially when they have advanced renal failure, the way they are treated, because of so many reasons, they are actually to some extent neglected because of the cost, because we feel that they are not going to be the earning members. Then the question comes how long they would survive. When it comes comparing a child versus a young person or a male, even females are not treated so well. So I think there is a discrimination in that regard. But I fully agree with you that the pediatric population, when they develop advanced kidney disease and need dialysis, they will be better off on PD as compared to on hemodialysis.
I concur with you fully with that. I'm sure my pediatric nephrologists and colleagues, including Anil, is sitting there and smiling, because Anil was making a comment while we were going through the pediatric kidney transplant patients, especially those with the CACT. They do not do well at all, because even though we transplant them, some of them do very well. And Anil, I want you to make that comment which you told me. Please use the microphone. Right. Right.
We analyzed the data and we found that, that they do well initially, but somehow after 10 years, the survival rate seems to significantly drop. And the only difference we found was in the number of incidents of UTI. They tend to have more UTI, but the rejection rates and all that surgical outcomes are all similar. So we were wondering what is that where we are missing, especially in the long-term management of these patients. And an important point from the CAPD perspective is the ethical challenges that we have, especially when we are dialyzing somebody like newborn or early infancy, because it's a burnout of these caregivers that bothers us. And we finally end up thinking, what are we doing in these group of patients?
Sir, just one question that we in pediatric nephrology, we are still not getting 1 liter back.
That's what, I am telling. I have been hitting on a rock for the last 30 years to the vendors to produce bags which are 500 cc and 1 liter. And that has never happened.
And what I understand from my interaction with Baxter, it will never happen.
30 years back, Baxter came to India because of me. And from the day they came to India in 1991, I have been talking to them. Nothing happened.
Mitra has come up.
I don't know whether they have,
but it is not easily available.
So in the same context and given the meeting that it is, can there be a joint ISN and ISPN written document to the companies like Fresenius, Baxter to provide pediatric consumables in the country? We all struggle in procuring hemodialysis catheters, filters, plasma filters, perm cats of appropriate sizes, PD accessories and everything. If there's a joint statement, because ISPN is a small society, if it's a joint statement, it would have a better impact.
Definitely, we have to pursue. Without pursuing anything, nothing works out. Narayana.
Yeah. Just in response to Dr. Aditi, this is all business. Yeah. So there was one liter bag available there. And so we have not to write to the companies. What we have to write to the government. There should be a quite subsidy on all these, because 18% then add on the tax, GST, making it too costlier. And I have talked in depth with this Baxter people. They have just calculated everything and has shown me each bag they are selling at our center at 10 rupees deficient cost. So they are not there. Even it was very difficult for last month to get the regular supply of the PD fluid. So this is always important, and we have to write to the government to get all these subsidies, make it off the GST, so that this can at least this childhood bag, that is very important. Actually, sir, Permacath for the children, it was out of stock. It was out of stock. We have got 3 from somewhere from this corner of the Rajasthan. They have came with this, only 3 are available. That I understand. But we have to request to the pharma as well as we have to write to the government. Yeah, definitely joint statement always has some weight. We are ready to do that. Thank you.
So if there is no more question, we can conclude the session.
Thank you,
sir.
Thank you.
So moving ahead, we have next session on approach to a child with suspected tubular disorder. For that session, may I request Dr. Arga Majumdar, who is Director and Head Department of Nephrology, Ambri Hospital, Calcutta. Dr. Sujit Kumar Sinha, who is a Senior Consultant Pediatrician from Patna. Dr. Abhishek Kumar, who is Consultant Nephrologist at Paras HMRI Hospital, Patna. And Dr. R.K. Jha, who is Consultant Nephrologist at Big Apollo Spectra Hospital, Patna, to chair the session. May I request Chairperson to introduce the speaker.
Good evening and welcome to a very important session. Renal tubular disorders are often a cause of failure to thrive and growth retardation in children. And to talk on this very important topic, it's none other than Professor R.K. Sharma, He's the ex-head of the department and dean of SGPGI. And he has a particular interest in this subject, and it will be a pleasure to listen to him and how he approaches these diseases in children. Professor Sharma.
Good evening. Thank you, chairpersons, and thanks to the organizers, especially Dr. Hemant and Om, for organizing this combined meeting between pediatricians and adult nephrologists. My interest in renal tubular acidosis started when I was on a fellowship in USA and was working with many of the seniors might have heard Neil Kurtzman, and spent a year doing in vitro and other testing on rats and turtle. Turtle bladder is actually is a good model for acidification. You can use it to test acidification. And when I came back to India after the fellowship, I got into this clinical issue about the renal tubular acidosis. And as we know, just for the sake of the time, I am restricting to a subset of renal tubular acidosis in pediatric patients, which is quite interesting. And we did some longitudinal work in this area. And we know that the renal acid and base handling involves the bicarb secretion, bicarb absorption, ammonia production and secretion. And renal tubules are very important in terms of the hydrogen secretion. And there could be, because of the renal tubular acidification defects, our body homeostasis of acid-base milieu can get disturbed. And we have this set of disorders, which could be as a result of the bicarb resorption being defective, or there's a hydrogen secretion being affected, and ammonia production is also an important component. These are the classical types of renal tubular acidosis, which all of us have learned: the type 1, type 2, type 3, and type 4. The type 1 is basically a disorder of hydrogen ion secretion by the renal tubules. And the type 2 is disorder of bicarb resorption. There's an excessive bicarb leak, and you can have a combination of hydrogen secretion and hydrogen resorption defects. And there are a set of disorders which we call as type 4 RTA, where it is the disorder of ammonia handling and aldosterone bioactivity. The spectrum is so large, and you can have different types of patients. We know that now there are a lot of genetic disorders with renal tubular defects. So the distal renal tubular acidosis, about which I would restrict this presentation, is basically affecting the distal tubule and the CC, the cortical collecting duct, which can have hydrogen ion secretion, ammonia handling, and aldosterone bioactivity. All these occur at the distal tubular level. So they could all be affected, and you could get disorders resulting in hydrogen secretion defect, ammonia handling, and even aldosterone bioactivity. And it can result in a spectrum of renal tubular acidosis with different
derangements being picked up. The other definition which you might be aware is translating the same defects into a so-called secretory defect, which is a classical distal RTA, where the hydrogen secretion is not being done as it should be by the distal coronary tubule, or there is a back leak which is occurring, which is called the gradient defect. These are definitions that are based about some of the testing techniques which were in vitro used to see how the tubule could be involved in acidification, and then the voltage defect, where the inability to generate a lumen negative transepithelial gradient, and as I mentioned about the ammonia and aldosterone bioactivity. Then we realized that there are special pumps which are there at the involved in the distal renal tubular acidosis, which are defective and producing the same gamut of defects which I have talked about, the hydrogen ATPase, the hydrogen potassium pump, and the sodium potassium exchanger getting defective, and a gradient defect. So all that these pumps have been really characterized. Their structure has also been very well studied. So classically, these are the three defects which we talk about. The distal, which is basically decreased distal acidification, where you will find a urine pH which is not going down below 5.3, where you have diminished proximal bicarb reabsorption, the type 2 defects, you may find that the pH may go down below 5.3. So you may miss these patients if you're just depending on the urine pH. So you have to have a higher threshold to pick them up. The type 4, you may find a urine pH is less than 5.3. So urine pH is not an absolute way to rule out renal acidification defects. The plasma bicarb may also vary. The type 1 can have untreated, much lower bicarb levels, while the type 4, the bicarb levels may be above 15, or type 2, you will find bicarbs which may actually be normal as well. In type 2, you will find, as we know classically, the fractional excretion of bicarb would be much higher. So the diagnosis of these different acidification defects will be based on clinical suspicion and then going through this gamut of tests to try to see if the body of the patient is able to acidify the urine. So you look at the blood pH. If blood pH is acidemic and you find the urine pH is more than 5.3, it gives you an idea that this patient has probably a distal renal tubular acidosis. But if the person is not acidemic, you have to induce acidemia, and that is why the classical ammonium chloride load test. If you suspect type 2, then you do the bicarb filtration test. The other classical clinical presentation, which we have always been taught, that type 1 will have nephrocalcinosis or renal stones. Type 2 will have more of bone disease. Type 4 may not have any bone disease at all. So these I have already mentioned. We have patients who have partial distal renal tubular acidosis who may be totally missed by just looking at the conventional urinary findings of pH or the serum bicarb. So you have to suspect them, and then you have there the urinary PCO2 is one way to pick up these partial acidification defects. Once you have loaded these patients with bicarb, giving intravenous bicarbonate. These are the set of patients who may have aldosterone deficiency or insufficiency or bioactivity is affected. Some of these are genetic disorders as well. For the sake of time, I'm not touching those entities as such. I'm going to present you a set of distal renal tubular acidosis. Distal renal tubular acidosis could also be familial and can have some genetic basis. But there are some renal tubular acidosis which are secondary with systemic diseases, some drugs can produce, and another important cause is low renal tract abnormalities. And this is pertinent to both pediatric nephrology and pediatric urology. The obstructive uropathy and vesico-uretary reflux. How I got interested in this area is that our pediatric endocrinologist, they used to send these patients to me who came with bony abnormalities, rickets, children, normal renal function. So they thought it's a renal bone disease. It is a renal bone disease in some way, but actually these patients had renal tubular acidosis. And to my surprise, many of them had, most of them had distal renal tubular acidosis. But mostly we think distal RTA would present with stones, nephrocalcinosis, but these children were presenting with low urinary tract abnormalities, quite a significant number of them, and bone involvement. And renal function was not very much impaired. The GFR was affected. So what we took these patients and then went into the detail. Many of these patients had posterior urethral valves. They had presented with growth retardation, rickets. Some of them had nephrocalcinosis, hypokalemia, polyuria, polydipsia, dehydration. So there was a significant problem. These were referred patients. I agree. It's not that if you go in general population of pediatric, you will not find such large numbers. And they were on investigations found to have classical distal renal tubular acidosis with lower urinary tract abnormalities and vesico-uretary reflux. So we prospectively looked at these patients with posterior urethral valve and vesico-uretary reflux. These are the testing which we had used for the bladder dysfunction, cystometry, looked at the proteinuria. These children were managed by urologists for the vesico-urethric valve. The acidification tests were done, the bladder abnormalities were documented, and MCU and voiding cystograms, the VUR grading, then the urodynamic studies. Then they went for the surgery. And like fulguration of valve is one standard. Some of them were also subjected to vesicostomy and fulguration. They were evaluated for distal RTA at the baseline and then every 3 months. And the urological follow-up and evaluation like cystometry was done at baseline and then at the last follow-up. And we tried to look at the age of presentation and at what age the surgery was done, how long the children waited for the surgery after they presented, what were the grades of the vesico-uretary reflux and the urodynamic abnormalities. As you can see, some of these children were 5 months old, some of them were older. The period they waited from presentation to the intervention, because of so many reasons, varied from 1 month to 80 months. Some of them on their own decided to delay, and some of them, the intervention was delayed because of other administrative factors. And after follow-up, they have been observed for around 2 years. So what we were looking at is what happened to the distal renal tubular acidosis after they were intervened. And also the other important thing is the proteinuria. Because one problem remains that many of these children, even after they were intervened, they continue to progress. And by the time they reach adulthood, many of them develop CKD because they have proteinuria of different grades, which is also one of the important factors for progression of CKD. So they were subjected for urine protein measurements, and also these are the other manifestations like the metabolic bone disease, the stature and hypercalciuria, the urodynamic abnormalities of different types like detrusor instability, hypocontractile bladder, and the compliance of the bladder. What was very evident that the age of presentation, the age at which they were intervened surgically, and the period, the delay in the intervention, they were the three important factors besides the degree of urodynamic abnormalities. If they didn't have much of urodynamic abnormalities, they did much better. Much better in the sense of the proteinuria progression and also the distal RTA, whether it continued and persisted. So this was seen even on follow-up. And by the statistical evaluation, age, as I told you, was very important. The delay was the other thing. And if they had more urodynamic derangements, the both distal RTA and the progression of the proteinuria is more likely to occur. So despite the intervention in terms of the posterior urethral valve or other abnormalities, many of these children continue to have distal renal tubular acidosis and also the proteinuria, though it got reduced, but it persisted. And many of these patients, the proteinuria actually increased. The other important thing was that in patients who progressed, both in terms of their distal renal tubular acidic defects persisting and also the proteinuria, the urological dysfunction was also of the higher grade. So ultimately, these are the important factors of the age, the delay in intervention, and the degree of lower urinary tract urodynamic abnormalities which decide about the outcome in these children. The important thing we learned that in children with lower urinary tract abnormalities, we should look for distal renal tubular acidosis, even if it is not very evident, because it will be seen in majority of patients, especially if they have high grade of urological or urodynamic abnormalities with the posterior urethral valve. Why? Because if you take care of it, you will be able to also take care of their bone disease. Secondly, distal RTA, though classically considered not so much associated with bone disease, but it is associated with bone disease. If you take care of this acidemia, which is mainly because of the distal renal tubular acidification defect, you will correct the bone disease, and also I feel it will have a positive effect in terms of retarding the progression of the chronic kidney disease and managing the systemic manifestation as such. The persistent distal RTA, though it may be an important contributor because acidosis is responsible for kidney disease progression, but it is a marker that the disease is persisting. So I think there is a complex interplay of tubular damage, the glomerular injury. At present, we have no definite interventions, at least in pediatric patients. In adults, besides the ACE inhibitors, but in adults, we have other two interventions like using Fineron or using the SGLT2 inhibitors, which could be very important in combining, but at present they are not cleared for pediatric use. So we are quite handicapped, but this is really giving us this experience that distal RTA should be looked for in these children. Some of them were very young, 4 to 5 months old, who present with bone disease and lower urinary tract abnormalities. Thank you very much.
Thank you. Thank you, sir. Considering your vast experience and knowledge, everything, I don't think that due to the quorum, I open the house for the question and any queries from the house.
So one question from my side. I want to know during your times when there was no solution for this soda bicarb, because we have recently had a company come up with the solution. So what was the way you would replace the alkali in children, for say 4-year or 5-year-old children who the soda bicarb tablets are quite big, difficult to swallow?
Like we were using the commercially available soda bicarb, which is used for IV. You can use it for oral also, but that's a little more expensive. Soda bicarb tablets or soda bicarb solution which is available now is quite cheap. But the very small children, it may not be easy to use tablets. I think solution is definitely, now it is available and we can use it very easily.
Thanks. Any questions from the house, then we can take.
Yes, that we have been using during our MD day for soda bicarb and for calcium. I think we are able to use the powder form solution and then was not very what we are available now. Max solution and other soda bicarb solution.
But then dose, how do we know how much?
Like ASM is 2.5 grams. Okay.
So thank you very much.
Thank you. Wonderful question.
So moving on to next session, we have a session on childhood UTI, the Newcastle model. For this session, may I invite Dr. Ratan Jha, Senior Consultant Nephrologist at Care Hospital, Hyderabad, Dr. Shravan Kumar, Senior Consultant Neonatologist at Patna, Dr. Madhu Sinha, who is a Senior Consultant Pediatrician as well as Secretary, Bihar Academy of Pediatrician, Indian Academy of Pediatrician, Bihar chapter, Dr. Pragya Pant. She is a faculty and in charge of Department of Nephrology at Rajendra Institute of Medical Sciences, Ranchi, and Dr. Binay Ranjan, Consultant Pediatrician from Patna. May I request Chairperson to introduce the speaker.
Good evening, friends. It's a pleasure for me to introduce Vincent C., a delegate from UK, who is a consultant pediatric nephrologist, clinical director for quality and safety is his designation. Present affiliation is he's attached to Great North Children's Hospital, Newcastle, UK. He's consultant from 2019, that is roughly 5 years in that hospital. He's chair of many of the societies, has many research publications and many other affiliations and awards. I request Dr. Vincent C. to now talk about a very common topic of childhood UTI, the Newcastle model. What is there for us as even an adult nephrologist to learn about this model of care of common disease, the childhood UTI. Over to you, sir.
Great. Well, thank you very much for inviting me. I especially want to thank Rajiv Sinha, who's a great friend of mine. And actually, there's a slight typo there. I've been a consultant since 2009. Both Rajiv and I trained at Great Ormond Street together. And when we left, I went to Newcastle and he came back to Calcutta. And we've been very good friends since. And we've done a lot of collaboration, and he's a fantastic guy. And I also want to thank Herman for inviting me. So actually, you know, one question is, why am I here? I work in the northeast of England, and it's a delight to come to the northeast of India to be with you all. This is a regional meeting, and I'm actually extremely proud to be in a regional meeting because I'm the representative of the Royal College of Pediatrics and Child Health for the Northeast, and it's so important to have regional meetings, especially with your adult colleagues. So that's delightful to be here. Also, I've learned recently that the Indian Society is changing your childhood UTI guideline. So maybe I can share some of my reflection because we've changed over time as well, and it may be quite timely to do this. So this is where I work in the Northeast, and in Newcastle, it's somewhere in the middle. But we influence the whole of the region in the guidelines that we've set. In Newcastle, we've been looking at UTIs for the last 20+ years. My predecessor, Malcolm Coulthard, has published quite a lot on it. And really, I'm just following in his footsteps. So imagine you have a child with a urine infection. One question is, after you treated him or her, do you screen for underlying abnormalities? And there's been a lot of debate, you know, recently about that. You have to consider what the risks of the tests are. And a few years ago, Rajiv did a randomized controlled trial. And even if you give antibiotic cover, 1.5% will get a UTI because of the VCUG. So actually, it's not risk-free. Then you get a result. What do you do with it? What if you get grade 1 reflux? Will you get grade 4 reflux? And will you actually reduce future complications with knowledge of the result now, or could you wait till you have more infection? And that's what I'll try to discuss. So this is what we used to do in Newcastle and the northeast of England, and actually in the whole of the UK until things have gradually changed. So imagine a 5-month-old girl not feeling very well, quickly improve. So in the UK, general practitioners will treat them, see them, but they'll send them to us to image afterwards. In the past, we'll do all the imaging, including a VCUG. We find a grade 2 reflux. What do we do with her? You know, how long should we put her on prophylaxis? In the past, we may have put her for many years because we will test her to see if she's growing out the reflux. And if she doesn't, we'll just carry on antibiotics. Was that the right thing? What about a 10-year-old girl who keeps having urine infection and you image her and she has a small scar? You've done all you can, you treated bad and bowel, you put in prophylaxis, still getting urine infections. What can you do? What about a newborn child? We used to do a lot of familial screening. When they're born, we'll put a catheter in, they've got reflux, what do you do? And what about a boy who's got Pseudomonas UTI? Is that a typical UTI? This is the NICE guideline. It came out 15 years ago. So Newcastle was the last to change, and we actually changed last year. And with the NICE guideline, essentially, if you have mild UTI, then you either don't image for your first UTI, or if you're less than 6 months old, you just do an ultrasound scan. So Newcastle service, we were very aggressive with imaging in the past with antibiotic prophylaxis, but we changed last year. And I'll share with you some of the evidence why we think we had to change. So which guidelines right? And you're changing your guidelines soon. The problem with the reflux, how do you reduce recurrent urinary infection, sibling screening? We know 1 in 5 children, offsprings, will have reflux if you look for it. The result of moving the nice. And one question is, should we image even less the non-E. coli UTIs? Okay, so start off with the problem with reflux. So the prophylaxis antibiotics, and it was really nice to hear your talk about the history of nephrotic syndrome. Jean Smelly was a very famous nephrologist in London, Great Ormond Street, and she recognized that 50 years ago, if you have recurrent UTIs and you got referred to Great Ormond Street, there's high chance you find some untreated abnormality, a 10-year-old boy with valves. If you put them on low dose antibiotics, miraculously, a lot of urinary infections disappear. It was a retrospective cohort. So since then, there's been a movement to actually image children to make sure we don't miss any of these. But actually, times have changed as well. I think parents are less tolerant of recurrent urinary tract infections. Oh, sorry, my clock has reset, so do tell me if I'm running too late. So the RIVER study, you've all heard of this. This came about 5 years ago from the States. This is the best study that there has been in reflux. And it's a multi-center study. They took children, young children who've had a couple of UTIs, see whether they got reflux, and then randomized them. They were mainly girls, huge study, 300 in each arm, prophylaxis or not. 2 years follow-up, and they found it really halves the amount of UTIs, on prophylaxis. But actually, even if the research nurses phoned the family, children were only taking prophylaxis, 75% of the meds, 75% of the times. Antibiotic prophylaxis really has a great place. It reduces symptomatic urine infections. But actually, when you look at the meta-analysis, that it doesn't actually matter whether you got reflux or not. Even for children without reflux, it can reduce symptomatic urine infections. However, none of the meta-analysis show that it reduces scarring, and maybe you need a much greater population, but then the numbers needed to treat this will be so high. There are downsides for long-term prophylaxis. With increasingly, we recognize that if you are a very small child, and you get lots of courses of antibiotics, there's a high chance of obesity. They have lesser response to vaccines for some reason. So it's something to do with their immune system, the microbiome. And this 40% antibiotic resistant, it may be that the other 60% just wasn't taking the antibiotics. You should be resistant to your prophylaxis if you're taking it. But this is a good take home. This came from the RIVER study and the parallel QT study, when children who didn't have reflux were just observed over time. And what they found was that actually what causes scarring, what are the factors? Well, duration of being febrile. And it's not like 1 day versus 5 days versus 10 days. It's 1 day versus 2 days versus 3 days to 4 days. So it's like any other infection, we need to stamp on it quickly. What was associated with new scarring? Your ethnicity, you can't change that. Older children. Bladder and bowel dysfunction, huge a factor, and recurrent urinary tract infections. So I think we need to jump on children with recurrent urinary tract infections, especially febrile ones. What was not associated though was interesting as well. How rich or poor the parents were, and whether the child had reflux or not, how high their temperature was, and whether they were on prophylaxis or not did not influence scarring. So how do you reduce urine infection? Prophylaxis 1, but bowel and bladder dysfunction. We in our UTI clinic prescribe more laxatives than antibiotic prophylaxis. Constipation is very much related to incontinence and urinary tract infection. And on the right there in the Venn diagram, these were children who didn't end up on prophylaxis. And what it showed was that bowel and bladder dysfunction had a bigger effect than having reflux on whether you get recurrent urinary infection or not. And if you have both, you have a double whammy. And why does bladder and bowel dysfunction cause this recurrent infection? So the MRI scan, the brown bit is stool, and then the white bit is urine. And if you have lots of stool in the rectum, you don't empty your bladder very well. And this is very old data, but there's a clinic in Iowa in the States, which if you go there and they treat you really aggressively, everything gets better, wetting, nighttime wetting, and urine infections. If you've done everything, what we're doing now in Newcastle, and this is where the next talk comes in, maybe very interesting, is that we're using these PIC cystograms. So these are children who we've done everything for. We don't find reflux in traditional imaging, but the urologists now are putting a scope in the bladder and actually directly trying to induce, putting a dye in to look for occult reflux. And they're finding about 90% of reflux. So they put a scope near the ureteric orifices. And if they find reflux, they'll do some deflux or anti-reflux procedure. And 84% of children in this small pilot study were off antibiotics within 2 years. So maybe something we should think about. Okay, so what about newborn screening? We used to do this because we were really worried about children developing UTIs if we're not looking for reflux and treating early. So there's some truth from studies since people started it. We know that most children, even if they've got a reflux, will never have a urine infection if you find out at birth. Even if you have high-grade reflux, majority of reflux will resolve, and the red line is grade 3 to 5 reflux. They also, many will resolve. In Boston's Children's, they used to do newborn screening, and they actually did not find that it reduces urine infection. They actually found that if they screened them and found they got UTI, they had more UTIs, maybe more awareness. Siblings who never have urine infection were screened. Some of them had abnormal DMSAs from birth. They've never had a urine infection. So this concept of dysplasia is there. And some of these didn't have reflux. And the most important thing is it's very expensive. To prevent one urine infection, you have to screen lots of children, and it costs lots and lots of money. And the more philosophical question is reflux actually normal, a part of growing up in normal children? You only know that if you do MCGs on normal children, and you think actually no one ever do that, it's not very, research ethical, but actually someone did in 1967 in Germany. They actually went to the children's wards, found children who came in with a headache or something, and asked the parents if they want to participate. And look, you have the same graph as you have on the children who were screened after urine infection. In Scandinavia, in Finland, people used to do a lot of screening after urine infection, but actually recently they took all their data and classified the children whether they had a definite urine infection and those which are less and less likely, and children who they probably never had a urine infection. And look, the reflux rate was exactly the same. So maybe reflux isn't associated with urine infection in the babies. And so we looked at our own data for sibling screening if they had normal antenatal screening. And then we found that our pickup rate for high-grade reflux was only 5%. Another 10% were low-grade reflux. One question was actually, if we can we use ultrasound scan to choose the ones that are more likely to have reflux and do MCGs only on those? But look, these were the ones of high-grade reflux. The box shows the one of abnormal scans. So it didn't really correlate very well. So it wasn't a particularly good idea. So actually, we've stopped doing newborn screening, and no one else in the country were doing them either. So we've moved to NICE because of these new evidence in the last 10 years. Previously, we had very high antibiotic use because a lot of children had put on antibiotics while waiting for the scans. And we did an antibiotic first approach rather than bladder bowel approach first. And we got this data, and these were children less than 5 years old prescribe one of these antibiotics for recurrent urinary tract infection, for prophylaxis. And we were a big outlier because everyone else had moved to NICE. So if you move to NICE, you can reduce antibiotic prescription quite significantly. And our colleagues at Middlesbrough did some modeling data for us, 100 children who got admitted with UTIs and what would have happened if went to NICE. You would halve the number of ultrasound scans you do, reduce by to a third number of DMSAs, and then reduce to a quarter number of MCUGs. And look, our pickup rate was so low anyway, and we actually picked up nearly all of them the first time. So we've changed since Easter last year, and we're doing much less imaging. So one question is, we've had 20 years of data of UTIs in our service, and our service mainly take children from primary care. And I want to challenge you whether we should actually image non-E. coli UTIs. When you look at the literature, I found 13, I suspect, well, 15 papers where they actually, most of them said actually non-E. coli UTI did have a high pickup rate in imaging. But look, they were nearly all tertiary centers, like what most of us work in. And the recurrent UTI rate was quite high in some of these studies. So we looked at our own data. We had nearly 8,000 children over 20 years, less than 12 years of age, had a first urinary infection, but these were children who were not ill enough to be admitted to hospital. And we actually found less abnormality. So E. coli had about 9%, Enterococcus 5%, Capsulitis proteus pseudomonas 5%. So maybe for children who were not admitted to hospital, were not septic, who had non-E. coli UTI, it may not be necessary. Okay, so take homes. VUR may not be pathological unless your child is getting recurrent urinary tract infections. I think it's really important to treat febrile UTIs early, and that's days, not like weeks, and minimize recurrent urine infections to reduce scarring. Treat bladder and bowel very well. Prophylaxis can be very helpful, and we need a pathway to urology. Newborn familial screening is very difficult to justify, and ultrasound scan is not useful to risk stratify. And I think in the UK, if a non-E. coli UTI who were treated outside the hospital, we probably don't need to do too much imaging for. So moving to NICE was quite sensible for our healthcare system. Question is it sensible for you? Should all countries image less? Well, I think it very much depends on prevalence. You know, are you working in primary care or tertiary care? And what interventions do you have? Because actually, Rajiv and colleagues in Calcutta looked at their first UTIs in infants, and we looked at our first UTIs in infants. Look, in Calcutta, 30% pickup rate for ultrasound and DMSA, we were only picking up 5%, but the VCUG were about the same. And the UK NICE guideline is not applicable for many other countries because it's written for a whole healthcare service. And importantly, they had cost considerations to minimize the economic costs. So I'll leave you to ponder that, and I hope it's been useful. Great. Questions? Did I stick to the time?
I think the take-home points are quite interesting from an adult perspective, that we said that what you said, three things. VUR in a normal child is normal. That is what you said. One point that is a message to be given.
Well, I think if you have urine infections, if you have one urine infection and you never have another one, having VUR probably doesn't matter. But if you are having febrile recurrent urine infection, yeah, VUR is important. You can do something about it.
One of the interesting treating point that you said that febrile UTI has to be treated early to prevent scars.
Correct.
Is it so?
Yes, so that's what the literature tells us. So really, if you, so this is, so the darker line is risk of getting new scarring over 2 years, and how long you wait before starting effective antibiotics. And it's not days and days, it's actually a small number of days. 1 day is better than 2 days, better than 3 days.
And regarding the investigation that you said, it is not worth doing as a routine for siblings, just based on the data that you presented.
Correct. Yeah. So in the past, and I don't know what your practice is, but in the past, we were asking, babies when they were born, we're asking families, oh, have your child, do you have reflux yourself, or your other children have reflux? And if they did, we will stick a catheter in them.
Yes. Thank you for such a nice model of Newcastle's. And I want to know that you are saying that infection, and whatever infection we should treat immediately. And but asymptomatic bacteria is also may cause scar in renal. So what is your idea about the asymptomatic bacteria?
Well, I mean, I think firstly, one question is, how do you know that they have, say, asymptomatic bacteria? So you have to take a urine. Yeah, so if they haven't got symptoms, I wouldn't take a urine sample.
You are saying that imaging is not important and treatment is important. So how long we should give, and what is the your idea we should know?
Yeah, I mean, really, I think what I'm trying to say is that you may not need to image so quick. You may not need to jump to imaging after the first urine infection. You may, unless they're very young. But if you have a 2-year-old who have a first urine infection and it's quite mild, there's from our data in our country, there's no great need to be too aggressive with imaging. But if you're having multiple infections, then yes, imaging is very important. Or if you get a UTI that's so severe, very difficult to treat, imaging is very important.
After that,
you mentioned that imaging may not be necessary. First time, your own chief used to say BUR is not a benign condition.
Sorry?
I'm quoting Dr. Coulthard. He said BUR is not a benign condition. When you say imaging, does it mean only ultrasonography or the MCUG and everything? I would probably recommend any suspected UTI to have a good ultrasound. If that is normal, you can probably wait.
Yeah, so in our NICE guidelines in the UK, if you're less than 6 months and you have any urine infection, you'll get an ultrasound scan. If you're over 6 months, but it's very mild and it's your first or second urine infection, or they're very infrequent, then we would not image now, just because the pickup rate is so low. And also, when you have a result, you're unlikely to action it.
Dr. Bani.
A question, Vincent, here.
Hello.
Thanks for raising some very interesting points. I think you were wondering in your last slide whether all the NICE guidelines are appropriate for the Indian scenario. There are some differences between UK and India. I think follow-up of patients right from the antenatal period to subsequent, later stages does not occur under the same healthcare system in India. So we would not, many children in India presenting with a UTI we would not have access to the antenatal scans. Many children presenting to me with the first UTI may have taken antibiotics, over-the-counter antibiotics for a fever 1 year ago without a urine test. So this kind of longitudinal follow-up, we do not have access to quite often. And therefore, I think I would really support what Dr. Srivastava was trying to say, that in our country, at least a good ultrasound is essential, because sometimes people miss something like posterior urethral valves presenting with UTI, spinal abnormalities, gross, voiding abnormalities, where you would get some clue from a good history and from a good ultrasound. So that is, I think,
Yes,
a good ultrasound, even in the first UTI, I think is
Yes,
vital.
you're absolutely correct. Because so people sometimes criticize NICE guideline for, for not picking everything, but you're absolutely right, because it very much depends on what your healthcare setup is. In the UK, if you don't come to clinic, for example, if you don't come to my pediatric clinic twice, the social services will come to your door and knock on your door and say, why have you not come to clinic? So it's a very different system. And I think your guideline needs to reflect what your healthcare system is.
I think you have very impressive follow-up and record keeping. But what we have to understand that if you have a guideline which has been made for NHS, they need to be followed. And what you have said, that one of the important guiding principle for these guidelines is the cost cutting. In India, the problem is that if the child comes and we say that VUR is innocuous, and the parents are demanding to have something to be done, and if you miss it, if you don't do it, there is nothing which is going to come to our help, because we will be questioned, why did you get a simple ultrasound done? So what the point you are making is very important, that guidelines have to be specific to the type of setup we are having. And especially in our situation where the medical treatment is actually on demand. I can go directly to any institution and anybody and can take treatment. While in NHS, you have to go from one step to another, and you have a very tight system functioning, which is controlling the cost also, in which even if you may get an appointment after 1 year, nobody is going to question the clinician.
Yes.
Because that is as per the guideline and as per the system. So here we have to be more careful. So I would not consider VUR as a totally innocuous thing, because we have seen these patients, one, they present late. Second, they have been intervened. They look fine, but they continue to deteriorate.
Absolutely. And look at this. So this is first UTIs in infants less than 12 months. Your pickup rate for DMSA abnormality is already 27%. Ours is only 3%. So that is such a big difference. So your guideline needs to be very different from ours. Absolutely. Excellent point.
Excuse me. Good evening, sir. Actually, after this presentation, I mean, there are so many confusions which I am having as a pediatrician. So I think from Indian context, somebody from Indian faculty, they should give a clear-cut guideline on this platform that number one, that below 1 year, if you get UTI documented with urine routine and urine culture with a history of fever, then what all imaging should be done or not done, what age, and for how long antibiotic prophylaxis. I think just a protocol based, I think from ma'am or someone from Indian context. So the imaging, the age, and antibiotic prophylaxis, just in summer.
So a couple of points. One is that before I go to the Indian guideline, one is that VUR is a controversial thing. And it is always a chicken and an egg. Whether VUR causes the damage or whether the damage was there already before the VUR happened, we will never know. And this controversy will go on. I completely agree that we need a guideline. And there is a very clear guideline at the moment by the Indian Society of Pediatric Nephrology guideline. It was published in 2011, where they say that below 1 year, all UTI should be investigated. Above 1 year, if the ultrasound is abnormal or a DMSA is abnormal or there is any features of atypical UTI, should be investigated. That guideline will be updated very soon. We are becoming slightly more nicer, but I think it will be updated in about a month or two. It will be published. But till now,
Like
that
below
is
1
the-
year, all those 3 imaging, you have to get it done.
at the moment, that's what I
Okay,
also.
right.
So this was a discussion to sort of generate interest and for all of us to appreciate the lot of uncertainties that there are in the viewer management. As Dr.
But
Srivastava,
if
sir-
in like less 6 months, if you get a viewer, and if you get grade 3, grade 4, then definitely the intervention should also be there.
What intervention?
I mean, that only I'm asking from your.
Prophylactic antibiotic.
To
There
give the
is
antibiotic.
prophylactic antibiotic.
Prophylactic antibiotic.
Low dose antibiotics should
Yes.
be continued for 3 years.
Choice
For
of
the-
antibiotics,
for the
sir.
grade 3 and above, low dose antibiotics should be continued till the child is potty trained. At
Till
least
the child
is potty trained at least. Toilet trained.
Okay.
Around 2 years.
Okay.
And what antibiotic? Less than 6 months, Sporidex. After 6 months, maybe cotrimoxazole. So not Sporidex means cephalexin.
Cephalexin and then cotrimoxazole.
I don't get anything from Sporidex.
Yes, yes.
And
Understood.
more than that,
Understood.
cotrimoxazole.
Fine, fine, fine.
I'm very sorry,
May I ask you
confused all of
something?
you.
I mean,
Yes.
Yeah. So basically, from a surgeon's perspective, we have been, for the last 3 decades, we have completely changed our outlook on reflux. Maybe 3 decades back, we used to operate on more than 60% of our cases of high-grade reflux, and maybe now it has come down to 10%. So we are also more into conservative treatment for VUR. Now, I have one question. Like, we had a concept that many of these children, and in fact, all those studies were published from UK, that many of the girls, especially with high-grade reflux, but no recurrent UTI, are who were kept unoperated, unintervened, non-intervened, go on to develop pyelonephritis during their pregnancy. So that was a compelling point, asking the surgeons to get a definitive treatment for the high-grade reflux in girls, even if they were asymptomatic and even if it was diagnosed beyond 5 years. So any update regarding this?
Yeah, that's an interesting point. I mean, perhaps you should invite me back in a year's time, and then I can look at the literature about that, because I wonder whether a lot of what was said in the past is what people's personal experiences, rather than really rooted in the literature. And because you need really good records to get something like that. So pass.
So to conclude, few points which I understood after discussion from all the colleagues, that patients who are below 1 year of age who are having UTI has to be investigated. It cannot be left like that. Ultrasound followed by maybe a DMSA scan, and whether to go for BCUG or not is a personal choice. But beyond 1 year, probably we can be a bit liberal unless the person has recurrent UTI. But ultrasound will be a basic test that has to be done in all patients, followed by DMSA. Regarding the antibiotic prophylaxis, below 1 year, what I understood, at least has to be given for 1 year or till they become toilet trained. And beyond 1 year, this will be a personal choice to go for 1 year or beyond. If there any other contradiction to my understanding, my teacher, Dr. Sharma is there, Dr. Srivastava is there to at least highlight this point. How long to give antibiotic prophylaxis and whether to do all the 3 tests in case we decide to go for an investigation.
That if somebody has a VUR alone, or somebody has a VUR with other bladder abnormalities and dysfunction, that is also very crucial. Sometimes in children, it could be missed. So I personally would have high index of suspicion in a child who is less than 6 months or less than 1 year. Even as the guidelines, the Indian Pediatric Nephrology, even more than 1 year, they are indirectly suggesting ultrasound and DMSA scan, because these are non-invasive investigations and not very expensive if the patient can afford. The prophylaxis will depend at least 1 or 2 years of prophylaxis. But if somebody is having recurrent UTI, the prophylaxis has to be much longer.
Can I?
I think ultrasonography is all right. I think probably any child should be having it, VUTI. DMSA, I would very much hesitate to do, or MCUG even much more, uncommonly.
Can I add one point? I think what hopefully my talk has stimulated the debate. But I think the important take home is that you got, with all the research that you guys have presented earlier, you guys are doing so amazingly, in your research output that maybe all the previous research done in the UK, US, they're very specific to the healthcare system. And you may be able to create research in your own healthcare system to justify, to actually see what your changes will do.
All toilet trained babies with recurrent UTI, can we rule out the bowel bladder dysfunction, and how? Toilet trained babies with recurrent UTI, how will we approach for the bowel bladder dysfunction, which is a very important finding for the recurrent UTI in toilet trained babies?
So I couldn't hear her, but I think your question was, how do you find out about the bowel and bladder dysfunction? Is that correct? Yeah, so bowel and bladder dysfunction is best. So we have a nurse-led service who use charts. They ask the family to document everything. Just because if you ask the family, "Are you constipated?" they'll always say no. But if you go into it in real detail, then you might get a very different answer.
Thank you, Dr. Vincent, for this wonderful presentation. I think we should wrap up this session now.
So moving on the last topic, so it's a panel discussion. The topic for this panel discussion is pediatric bladder disorders, a crosstalk between pediatric nephrologist and pediatric urologist. And for this session, it's my privilege to call upon Professor Rajesh Kumar Tiwari, who is Head of Department of Urology at Indira Gandhi Institute of Medical Sciences, Patna. May I request, Dr. Professor Tiwari to introduce the moderator.
The lower urinary tract, the lower bladder and the sphincters, if they are not behaving properly, their dysfunction can cause not only impaired quality of life, that is incontinence, but they can also lead to the silent damage to the kidneys. So to identify the abnormal voiding dysfunction in the children is very important. And for that, this session is devoted to the discussion on bladder dysfunction. And we have got a moderator, Dr. Subhasis Saha. He will moderate the panel discussion. And Dr. Subhasis Saha is a consultant pediatric surgeon at Amri Hospital, Kolkata. He has got 25 years of clinical experience in the field of pediatric urology. His areas of interest are posterior third wall, neurogenic bladder, hypospadias. He has chaired many societies. He was the chairman of the Society for Pediatric Urology, editorial secretary, Journal of Indian Association of Pediatric Surgeons, and he has many publications, national and international, to his credit. So I invite Dr. Subhasis Saha to moderate the session.
Thank you, sir. Thank you, sir. So first of all, I would like to thank the organizers, especially Professor Hemant Kumar and the entire team for inviting us and extending an unparalleled hospitality. So I am the odd man out in this entire crowd, being a surgeon. But as the caption says, a crosstalk between a pediatric urology and the pediatric nephrology. So I think this background has helped me a lot in my entire career. So I was very lucky, I was very fortunate to have the support of pediatric nephrologists from the beginning of my career. And many of my children bear fruit to that. And I think they have done pretty well due to the support of the nephrologists. So I would like to welcome Professor Himesh, Professor Orpita, Professor Shumantro, Dr. Jayati, and for this panel today, Dr. Jayati Sengupta, Dr. Jayati Sengupta is consultant Department of Pediatric Nephrology in the Department of Pediatrics, AMRI Hospital, Kolkata. Her experience is 25 years. Her areas of interest are nephrotic syndrome, UTI, enuresis, and bladder disorders. She has several chapters in the textbooks and several publications in peer-reviewed national journal. So I would next like to invite Dr. Himesh Bormon. He's a professor and head of the department. Dr. Himesh, of Pediatrics, Northeastern Regional Institute of Medical Sciences, Shillong. So his areas of interest are pediatric nephrology and medical education and quality improvement. He's a life member of IAP, ISPN, and many other organizations, and is a president of IAP Meghalaya State Branch. I would like to invite Dr. Orpita Gogoi. She's an assistant professor, Department of Pediatrics, Assam Medical College, Dibrugarh. And Dr. Sumantro Raut. He's an assistant professor, North Bengal Medical College, Darjeeling. His main areas of interest are cystinosis, peritoneal dialysis, and he also has a lot of publications. So without going into much details, so today the system in the next 30 minutes we are going to do is we'll discuss a few cases. And basically, we would like to impress upon you the role of various investigations, history taking, clinical examinations, and how we can actually very simple disorders. It's very important for the proper diagnosis to go in details into all these things. So basically, it will not be it will be very simple discussion, but we would like to highlight certain points. So firstly, I would ask Dr. Himesh to just enlighten the audience. What are the armamentarium in the hands of pediatric nephrologists and neurologists to diagnose any disorder?
So it's not different from any other disorder. We have your history taking, examination, and some tests that are required. And for history taking, it's very important so that we can define what is the problem. So what is the frequency? Is there any incontinence? What is the bowel pattern? Is there any holding maneuver? And these all we need to take in more detail. And then an extension of history taking is a bowel and bladder diary. That is very important. I think we'll be talking about that in next few slides. And then in clinical examination, we need to examine for any stigmata of your spinal problem, like examining the back is very important for any neurocutaneous markers, examining from cremasteric reflexes, anal tone, strength of the lower limb, especially the grasping power of toes, which corresponds to the your sacral levels. So these are important. Palpating for any lump. So all these are very important. And imaging, like we have X-rays, ultrasound, MRI, CECT, Euroflow, and Urodynamics are again some things that we can do.
Yeah. Now here I would like to stress upon this simple investigation called uroflowmetry. Now, urodynamic study involves putting a catheter in the urethra, but uroflowmetry can actually be done in the OPD basis. And if you add EMG electrodes to the patient, to the child, and he or she just voids, this just an uroflowmetry can give you a host of informations, and sometimes it's as good as a urodynamic study. So that's a very basic investigation, but is often neglected. So the first case, we'll discuss 4 or 5 patients. Now, this is a common scenario. Many of your, in many of your chambers, you get patients. This is a boy with a 9-year-old boy with a genital pain and increased frequency. So basically, this is the main complaints are the pain at the tip of the penis, on and off, especially during voiding. And this is a very short duration, lasts 2-3 weeks. So it's more during the evening. There is no history of dysuria. Apparently, there is no history of constipation, according to parents. This is very important. And there is increased frequency of urine. So I would like to ask Dr. Orpita, what would you think about this case and how would you just proceed?
Yes, sir. So this child presented with complaints of penile tip pain along with increased frequency without any dysuria. So per se, this looks like a urinary tract infection. Right. So we would do the general examination followed by a focused local examination of the genitalia, which was essentially normal. The prepuce was unremarkable and it was retractable. The ultrasound KUB turned out to be normal, but the finding here, which was important, was a rectal diameter of 40 millimeters. The transrectal diameter cutoff is 38 millimeters for children with a high sensitivity and specificity. So we definitely see that there is rectal dilatation here. However, on history, the parents categorically denied that there was a history of constipation. They said that the child used to pass pass stool every day, once every day. After this, we did an X-ray abdomen, and this is the X-ray abdomen, which is showing a loaded colon and a loaded rectum. So this is definitely a constipation which was there. This needs to be addressed by removing the fecolates first by giving bowel washes. And then we need to give long-term laxatives to this child, which will improve his symptoms. So this was done. Stool softeners were started after evacuation, and the pain, in fact, disappeared after some days. However, the increase in the frequency of urine persisted.
So, I mean, at this point of time, I mean, basically, many of these children who are habitually, chronically constipated, the parents will come and tell that there is no constipation, child is passing urine daily. So the point is, it's not that he's passing stool daily or not daily, but important is the amount and the frequency. So basically, it might, so it's a fraction of evacuation of the entire rectal load. So in these cases, there are two very simple maneuvers. One is an ultrasound. So you can ask your sonologist when he is doing an ultrasound of the kidney and bladder just to add the transverse rectal diameter. It's a very simple maneuver to note whether the constipation is present or not. And once in a while, to convince the parents, you might as well go for a single abdominal X-ray, because that will show the entire colon is loaded with stool. And these constipation patients will never improve with just laxatives. Plain polyethylene glycol will never solve these problems unless these patients are disimpacted properly. And that disimpaction also includes a search for an anal fissure, which might need treatment, because as you all know, whenever there is an anal fissure, there is a spasm of the sphincter. So the laxatives won't work. So you need to work upon the fissure, you need to work upon proper evacuation of the colon, and then only the laxatives are going to work in the long term. So here we find that the pain completely disappeared just by disimpacting the colon and putting him on laxatives. But the increased frequency persisted. Parents coming to the OPD and saying that he is passing urine 30 times, 40 times. So what are you going to do now? What's the next step? Yeah, please. Exactly. Correct. Exactly. So this is a very important point, because per-rectal examination is something which is a taboo for many of the physicians. So I think this is a very simple maneuver, and I think all clinicians should not hesitate to do a per-rectal examination. That actually tells you on your face that the child is constipated. It's a very, very important point. So, Orpita, would you just...
So now we also looked at the bladder diary which the child was maintaining, and it showed that the amount of intake was as high as 6.5 liters per day, 6 to 6.5, and the output was around 5.3 liters per day. So was this a polyuria in fact, because that is what the bladder diary looks like. However, on further historical examination, it was found that the child was being asked to drink lots of water in order to maintain kidney health. So he was being forced to take excessive water, and that was probably the reason for the polyuria.
So basically, I mean, this is a simple case. The moment the intake was reduced, this all polyuria, etc., everything went away. So the point is, this is a simple bladder diary is a very simple tool. You don't need any fancy investigation, nothing. You can just ask the parents to maintain a proper chart of the intake and output. That will tell you give you a lot of information. It will give you an information about what is the capacity of the bladder, unstimulated capacity of the bladder, whether there is any incontinence, whether there is any strain, what is the interval, what is the duration when he is peeing the most, and whether it is at all related to the intake or not. So bladder diary gives you a treasure of information, and it's a very simple thing to maintain. So you should make a habit of going through the bladder diary before you go for other higher investigation, more invasive investigation.
what was the
Yeah.
urine report, urine examination?
Urine examination, there was no urine culture, didn't show any growth, and the pH, etc., was fine. Specific
What I'm
gravity
trying
was,
to say is that the first test
yeah.
will be the urine examination.
Yeah, I mean,
because
that I think I had
somebody
mentioned.
is constipated.
Yeah.
That's fine.
Yeah.
So you have to rule out
Yeah.
whether
Yeah,
there's any UTI.
yeah, of course. In the first visit, urine routine and culture was done, and which was normal. And this child didn't have any phimosis or any
The
other.
child did
special-
not have any fever.
Yeah.
The child was febrile, firstly, and there
Still-
was, yeah.
No,
but
he's
still,
not having
yes,
any
still
frequency.
you
We should
can have
always
lower urine.
rule out
You can have a cystitis.
bacteriuria.
Also, we urologists are always asked whether it is daytime frequency or nighttime frequency.
Yeah, right.
If it is daytime frequency only, then it is behavioral mainly.
Yeah.
If it is nighttime frequency as well, then we can look for the pathology.
Yeah. So now this is an 8-year-old female child. The first episode of UTI was as early as 6 months, and then the child had been having recurrent episodes of febrile UTI. So there is a history of constipation going back since 2 years of age. So when we took a detailed history, the urinary frequency was normal, but there was severe urgency and urge incontinence. Often the child could not control, and there was severe pain. She had to run to the toilet. There was dampness of underpants and the need to change underpants almost 5 to 6 times a day. And there is a sense of incomplete voiding. And immediately after voiding, she used to dribble, and the child sat to void again and complete the rest of the void. That was the pattern. There was mild hesitancy, and there was both diurnal as well as nocturnal enuresis. So I would ask Dr. Sumantro, how would you go ahead? I mean, plan.
Okay. First of all, good evening to my all colleagues from Patna. So regarding this lower urinary tract symptoms, actually ICCS has clearly defined 6-7 symptoms which are of different lower tract etiology. So either they have specific cutoff point after which they are maybe below which they are physiological and after which they are mostly pathological. Suppose, for example, a straining or a poor stream is pathological since day 1 of life. So there are such cutoffs in ICCS guideline also. So here the child, some lower urinary tract symptoms are suggestive of overactive bladder, just like a increased urgency or urgency leak. And some symptoms are classical for underactive bladder, just like straining. So here the child's behave with some abnormal behavior. So after completing the proper history, and as sir told, after a proper examinations of the genital, of the spine, back, after searching for renomegaly, renal angle tenderness, and abdomen fecoris palpation, we can, and the blood pressure, obviously, blood pressure and height. So then we can move away to our simple investigations. The investigations other than our routine urine test and maybe a RFT, we can proceed to the next investigation, that may be some imaging. We will start with the imaging of some non-radiation imaging. Ultrasound is the key investigation for that one. But we need preferably a detailed renometry, where everything just like a hydronephrosis, the epidiameter, the cortical thickness, hydroureter, particularly post-void residue, and that needs a patience for the sonologist, because child may not pee in a single attempt whenever he is in ultrasound lab. So maybe 2-3 attempts may be needed for the child to be comfortable. And after this whole ultrasound, suppose this child in ultrasound shows some there's a picture, sir, in the next page, I think. Yeah. So
no, that ultrasound is not, because ultrasound was
next page, I think there. Anyhow, so in this case, after the ultrasound, we have the next, whenever there is bilateral hydroureter nephrosis, our next line of management is probably a radiation investigation, that is an MCUG, at least for our part of India. So we did an MCUG for this child, and this MCUG is supposed to be bilateral grade 4 or grade 5 view vesico-uretary reflux with a more or less normal looking bladder and a normal looking urethra as per we will see it. So that can be a case of maybe a primary viewer, but we don't have a control film here, but seems to be a background constipation or the bowel shadows which has been visible. So regarding this bilateral viewer, is there any kidney permanent scarring or not, that we can see in a later radiation, that is a DMSA scan. So we have a next picture of DMSA scan also, I think.
Yeah.
And here DMSA, here right side is the right one. So right kidney is showing some lower pole permanent cold area, cold spot, and maybe some cold spots in the upper pole also. So maybe right side kidney is showing some permanent scar, possibly. And then this is the ultrasound, what I am just telling, that we need to check each point of the renometry, and among them we can see the bladder volume, which was as per the expected volume capacity. The post-void residue is still present after 2-3 attempts of the child. So there is a high PVR. So it carries a significance till a 8-year-old child currently who is having a high PVR with a bilateral hydrourotonephrosis with a bilateral high-grade reflux with scar on one kidney. So we need to suggest, is there any anatomical defect or just only a functional defect that we need to address?
Now, and another thing is very important is encopresis. That means constipation is something. And if you continually have a pant soiled with stool, this is overflow. So basically encopresis is a direct indicator from history that this child is constipated and is completely retaining stool. So there you should start the treatment with proper enema and proper washout. So this was a partial voiding diary, which is actually incomplete. Yeah.
Yes, sir. So as sir already told us, sir, the basic investigation and the key factor is this a good proper diary, maybe of consecutive or non-consecutive 3 days at least. Here we need to mention every point that is better done in holidays when all the parents' cooperation is also needed. How many voids are there? How each amount of void on each time? How much there is a incontinence or leak or accident? And how is the stool frequency also? Parallelly, we can see it, the timing also. Here, though there is not a complete diary, but at least we can realize the girl is 8 years, so the expected bladder capacity is around 10 ounce. That means around 300 ml. So at least 75 to 80% of the expected bladder capacity should be there. Here, most of the voids are 30 to 60 ml. So they are too much less voiding in a more frequent manner. So here, and so small frequent void. So next step, what we can do, either preferably we can go for a non-invasive test because the toilet trained child, we can go for a uroflow. And as sir told that if you can attach some electrodes in the urethral sphincter or in the, at least in the pelvic area, so we can get an EMG along with uroflow.
So basically in such cases, we first treat the bowel and then follow up for a couple of weeks. If the symptoms still persist, then we go for higher investigations, including a uroflow. And this is a little higher thing. That's an urodynamic study. I mean, now urodynamic study is not something very fancy or very rocket science. So we do urodynamic study in investigation evaluation even in small infants also. I mean, that's not a big deal. And the child is as comfortable because here the child lies in the mother's lap, a very small child, or they are comfortable. They can sit, they can relax in the room. There are videos and there are play toys and everything to make them relaxed. So here, if you can just say the salient points.
Okay. So as I told UDS, we are not directly jumping to UDS properly unless the child is having some known neurological defect, some known meningomyelocele operated, maybe a post-operative case of PUV or any other CACUD. Otherwise, for this type of dysfunctional voiding suspected, we can always try a good bladder training, a good bowel training for at least 2 to 3 months. And even if the symptoms are not getting corrected after that proper training, then we can jump to either a uroflow or a urodynamic study. And here we can see the pink color line is actually the flow pattern. And the flow pattern is occurring in 3 or 4 bouts. So there are multiple bouts of void which is not touching the baseline, probably a staccato type of void that can suggest that there is a good pressure during voiding, but there are multiple time of obstruction. So this is a classical case maybe of DST, that is a detrusor sphincter dyssynergia can be possible. So again,
this is basically another child with a 4-year female with dysfunctional voiding. Now here the child used to post void, there was a dribble in every time. And here we find something interesting. I mean, would you like to highlight? You can.
So in this child, as MCU starts with the control film, we can again see some of the bowel gas shadows are there. Bladder in full dilatation looks wall more or less okay. And during voiding, there is no gross view or is been located in the AP film. In the lateral oblique film, the urethra seems more or less okay. But as it is a girl child, in the 5th picture, the middle of the lower picture, we can see some amount of dye has been accumulated in the vaginal area. So that can be a case of vaginal void, which is again a common thing in today's era where most of the parents are working parents and we give less amount of time for our child's bowel habit or the bladder habit, how to sit properly in a potty. That is a difficult thing to get trained to a child. So unfortunately, many of the child don't have a good potty training and good bladder training, and they can capture the urine in their vagina and cause a vaginal void, which can subsequently causes multiple time leaks and can get infected also. So we have a next picture, we have a proper training picture also. So for this child, what we can suggest to treat the constipation effectively, at least for 4 to 6 months or maybe more than that, And as there is no other MCU abnormality, the vaginal void can be easily treated with proper urinary habits to wide apart the leg while sitting in a proper toilet. Either it is a Western type of toilet, or if the child is little bit less age, they can use any type of potty seat like a horse potty, where the legs are wide apart and they can fully pee on that period.
So I mean, that's very important to show the mom how to just separate the this thing. The child needs to be trained properly. Now, this is the uroflowmetry of the same child. It shows a sort of tower-shaped curve, and all these things can be. So the average flow rate is much more, 27.5 here. You can see. So these are all cases of frequency of urine, but each has a different story behind. So this is another extraordinary high daytime frequency, another child. This is a 4-year-old male child with severe increased daytime frequency for the last 3 months. Now, child has urgency and can sense the urine. So informs before passing urine. There is no incontinence, no nighttime symptoms, passes stool daily, no constipation at all, and good amount of stool. He had a similar episode 1 year ago, but went to some local GP and there was no urotherapy given. The child settled of its own. Now, the child complains of poor urinary flow, bad flow. Now, poor urinary flow per se can have two connotations. Either it could be some obstruction or it could be poor muscular activity. So these are the two broad connotations from a poor urinary flow. Ultrasound is absolutely normal. So, Dr. Jayati, would you just
Yeah, so we have this child who is otherwise quite well, in the sense that he's passing there's just increased frequency of urine, and mainly in the daytime. So there are no problems at night, firstly. Secondly, there is no incontinence. So he knows that he wants to pee, he just goes and pees, but he is never wetting his pants. So these are two very important things which will tell us that probably we are not dealing with something very organic. Probably we are dealing with something more functional. And first thing is obviously to see whether these children are constipated. This is a very common reason. Constipation is a very common reason why this happens, because the loaded rectum presses on the urethra, and they gives it rise to this feeling of urgency. Here
there is no constipation.
There is no constipation.
And this is a 4-year child, so we are expecting a capacity of 150 ml.
Exactly. Now, so when we do the voiding diary, we find that with the child is passing is the huge increased frequency. Normal frequency in a child of this age should be around 6 to 8 times in a day, and this is more than I think 20 times. So, but there is no nocturnal enuresis. So the first thing in this child would be to do a proper ultrasound, and to see, first thing would be a routine urine, obviously, to rule out anything, to see whether often these children have worms also. So those are small, simple things which we need to rule out. The next thing, which is very common, is psychogenic causes. Any problem in the family, any examinations going on, or any disruptions in the household things. So these have to be ruled out. If these are also normal, and ultrasound obviously has to be done first to see if there is a very low capacity bladder which is making him pee so small amounts, or there is an obstruction or a increased post-void volume for which he is going and peeing very frequently. So if the ultrasound shows a normal bladder, no PVR, normal volume bladder, that there is no claviculation, the bladder wall is not thickened, the transrectal diameter is normal. So if you have all these things, so then we can more or less establish that this child is having a functional bladder disorder, which is very common in children nowadays, which is known as what we call as pollakiuria, in which is very common in boys. They have these episodic increased frequencies for a few months, and with a lot of distraction, sometimes biofeedbacks, they slowly settle down. But some of them do not, and if it is a persistent problem, then we may need to go for a uroflowmetry. So now, if worst case scenario, probably even a urodynamics if it is not responding. Now, in this case, we did a uroflowmetry, and we can see that it is a very staccato curve. Normally, in a uroflowmetry, we are supposed to have a bell-shaped curve in which the Qmax, or the maximum voided volume, happens within the first a few 5 to 8 seconds, and then it follows a bell-shaped curve. Now, whenever you have a staccato curve, we know that there is a kind of a straining. So there's a kind of an overactive bladder, and the bladder is trying to force against either a urethra, which is dysnergic. So the bladder detrusor is contracting, but probably the urethral sphincter is not relaxing. So these patients then need to be taken up for further investigation and further management.
So this VCUG is actually normal. I mean, this child had a normal obstructed uroflowmetry, normal VCUG, normal cystometry. There is no.
So we can see the voiding cystometry that there is a lot of we can see the detrusor pressure. The pressures have not increased.
On the baseline.
Yeah, the baseline the pressures
Normal
are fine.
compliance.
Yeah, but there's a lot of contraction of the abdominal muscle. So he's basically trying to voluntarily generate some pressure. So very common is constipation in these patients, which can happen. And biofeedback things for these children are very important. If you give them this idea that of voluntarily relaxation and contraction of bladder, if you can teach them, very, I mean, they really do improve. But if still they don't, then sometimes a small trial of oxybutynin may be helpful if the frequency is really bad.
So I would now just briefly brush about what are the issues in neurogenic bladder which we need to be aware of. I would request Dr. Orpita to highlight what are the points you want to know and why a neurogenic bladder is a matter of concern to all the pediatricians.
Neurogenic bladder is basically alteration in the nerve supply of the bladder and the colorectal apparatus, which may in children mostly it is due to spinal dysraphisms and spina bifida. The bladder disorders which may happen along with in a neurogenic bladder could be ranging from bladder overactivity, loss of compliance of the bladder, or in some cases lack of sphincter tone or myogenic failure, out of which overactivity is more common, and that leads to back pressure changes. Along with that, there may be some post-void residue, and it may predispose to higher tract affection of the higher tract. Thirdly, there is also a mechanical overdistension of the rectum due to poor anal tone, and this may indirectly impact upon the on the bladder and compromise the bladder function. And this compromised bladder function ultimately leads to renal damage, and they may end up in CKD. The point here to remember for us is that most of these neurogenic bladders, as they are detected quite early in life due to the spinal dysraphism, they are operated, but sometimes they are lost to follow up. So what we should instill in them is that a CIC should be, regular CIC should be started early on, and it should be continued. So how does CIC help? CIC basically removes the post-void residue so that prevents the urine from staying in the bladder for too long and leading to urinary tract infections. At the same time, the overactivity of the bladder, which is quite common, that is taken care of by decompressing the bladder frequently. So these are the things which are there in a neurogenic bladder.
So basically, even in 2023, we find that many of our colleagues, I mean, even after the neurosurgeons operate on a myelomeningocele and the parents are not counseled about the issues of bladder and bowel, they come to us at 5 years, 6 years with raised creatinine. This is the unfortunate part. So basically, on the part of the pediatricians, one should be very much aware and start counseling the parents from day one that operation is fine, surgery is fine, but these children will lead to, because all of them are born with normal kidneys. So it's our responsibility to see that the renal function is preserved.
Nobody goes home without learning how to do a CIC after myelomeningocele surgery. Secondly, I think an urodynamic should be done, as is the practice and the recommendation, as soon as we can, to see basically what is the filling pressure, because not everybody is going to go into a neurogenic bladder probably, but if it's a safe bladder, we know the filling pressures is okay. The storage pressure is not very high. There is not the bladder bowel, the bladder and the sphincter coordination is more or less okay. So these patients we can know will not do too badly and can be followed up better. So I think safety is very important.
Due to lack of time, we are just skipping through the last few slides. So basically, this is a graph showing, this is something we call loss of compliance. Because you can see this is a neurogenic bladder patient who had been operated twice in the age of, within the age of 3 months. And actually, she presented to us with all these issues. passing urine in small amounts, continually passing urine, passing stool every 5 to 6 days. So both the bladder and bowel are affected. So here, I mean, this
I
is
think, the dribbling, sometimes we have to tell them that dribbling is probably a safety mechanism. If the bladder, if the sphincter is open and the urine dribbles out, probably it will prevent the pressures from going into the kidney and cause damage. So just doing an unnecessary surgery by controlling the incontinence or tightening the sphincter probably is not the answer. So I think that should be, the nephrologist should be just aware.
Dr. Sumanto, you can highlight what are the things in this study in a short, in 2 seconds.
It's basically a high capacity bladder, and that's too having significant provoked spontaneous as per the EMG record shows there. There are some detrusor pressure intermittently. So no, though there is no leak properly. So this is very atypical case actually, sir. We rarely find this type of case, maybe for post-neurogenic case only. And as I already told, for neurogenic bladder, we need to go for a early UDS, no matter, because our center, Subhash sir, is doing UDS in case of infant also. So for this type of patient, we need to do a early UDS to know what exact management do we need. Do we need a bladder neck relaxer? Do we need a anticholinergic to increase the bladder volume, or do we need separate some entity of bladder feed biofeedback techniques? Next slide, sir.
This is basically a very unsafe bladder because parents are happy. There is no leakage. Child is not leaking. Child is not smelling of urine. But we are absolutely unhappy because high pressure is going on and the child is not leaking. That causes damage to the kidneys. A child who is continually leaking of urine, the kidneys are safe. So this is after we started oxybutynin. Any changes you find?
Okay. Now here the spontaneous high pressure has been reduced. That was initially more than, actually people say more than 20 pressure is not safe one. Then that can cause the upper tract damage. So here the pressure has a little bit dropped down from the earlier one. And then here what we fear of giving oxybutynin or tropan, that the bladder becomes more residual volumes, and also there is an increase of constipation. But anyway, these neurogenic bladder child are on CIC, so we are not fearful for a residual volume of urine, and also they are on regular bowel wash, so we are not fearful for the constipation also. So we can safely give the tropan and do the regular CIC, that is clean intermittent catheterization, and a regular bowel wash.
So this is a last case. Basically, we are happy when the PUV patients, they are having normal creatinine, voiding well, no incontinence, no residual urine. We are extremely happy. Now, this is one of our such patients whom we had operated in infancy. We had done a check cystoscopy after 6 months, and then again at 5 years. He has been absolutely well after that. Now at 14 years, the only complaint is occasional dampness of pants. Now, all these children, now we are going for follow-up and urodynamic study at adolescence. Now, what is happening, you see? So I would request Dr. Orpita, can you just highlight what are these things here?
Yeah, so in this study, we can see that there is increased amount of frequency of urination. It's more than 10 times, I think. And the amounts which are passed are also more. So frequency is high and void volumes are high with 24-hour output of around 2.2 to 3 liters with urgency. The stars which are seen, those are indicative of urgency.
So here, Dr. Jayati, would you highlight? This is the ultrasound.
Yeah, so any child with PUV, we have to remember that just surgery, doing the surgery is not the end of the story, it's just the beginning of the story. So this child is going to be the child who has been under pressure, the kidneys have been under pressure for so long, often have irrepressible, changes in the kidneys. And the most important thing is the bladder. These bladders, even if they are relieved, they still are less compliant bladders. They have problems in the output, and there will be some kind of overactivity in this. So the ultrasound, if the ultrasound shows, I think, can I just see the ultrasound once? Yes. So the pelvic, the APD is increased. We can see though the wall thickness of the bladder is just within normal limit, but the child is having a lot of post-void urine. So, and if you see the uroflowmetry, you can see that this is a plateau kind of a curve. So that means the child is trying to pee against the pressure. It is not being able to pee out. So there is against the kind of obstruction is persistent.
So basically, we find a huge residual urine, bilateral upper tract dilatation, and a staccato flow, interrupted flow. Now here we did a video UDS, which is showing absolutely pressure at baseline. There is no loss of compliance, nothing, and there is no reflux, and a nice contour of the bladder. So what is wrong? Because the child apparently was wrong. Good, apparently was absolutely well. So this is the voiding study. Now, voiding study, you can see there is a good amount of pressure being generated by.
Lot of pressure, the bladder is not very compliant. So the child is being against a lot of
The
pressure.
bladder is absolutely compliant because this is a filling curve. Filling curve is on the baseline.
Sorry.
This is a voiding curve.
This is a voiding curve. Yeah, sorry. So this is a very high pressure. I mean, the pressure is going up till I think 36.
So the idea of presenting this case was all these sort of patients were included in myogenic failure. That was our classical teaching during 10, 20 years back, that the PUV patient goes from hyperreflexia ultimately to myogenic failure in the adolescence.
So
But is there anything that is beyond our vision? So this patient, is it myogenic failure? I mean,
so these patients will at some point of time, they can become the bladder pressure can become underactive and then go into myogenic failure. So that's
a different story.
That is what we have to.
We don't want to highlight that. We want to highlight that a huge residual urine, very poor flow and interrupted flow apparently was considered by us as myogenic failure. But this simple investigation, urodynamic study, shows us that enough of muscle force is there. Detrusor is absolutely active. So this is a voiding image.
Yes, but the flow is still very poor. Still the child is, not the amount of flow is still coming a little less than what it should be.
Dr. Shumanto, would you just enlighten?
Most likely the MCU looks fine, apparently, and reported was also normal.
Understand, we may deal with in the first line, we can have anticholinergic, anti-alpha blockers. And even if some of these patients did very well by cystoscopy and injection of Botox at the bladder neck. So whatever treatment is a different story, but the diagnosis is, this is the reason why the child is having a huge post void. So if you treat it as a myogenic failure, the whole management is different. So what we did was, we started, so since there is raised voiding pressure and normal bladder contractility, it is not a myogenic failure. So we just added tamsulosin, nothing else. And after 6 months, you see that this is a bladder diary. It has entirely changed. So this is a bladder diary, this is a residual urine from 105 has come to 15.
Yeah, so that is I think what we have to project, that the tamsulosin means it's acting, it's an alpha blocker. So the bladder, neck, the detrusor and the urethra, the sphincter. So this has to coordinate. So when the detrusor contracts, the sphincter has to relax. So in these patients, that sometimes even after surgery, that is sometimes not possible. And if we do not act at that point of time, the child, in spite of having a very good detrusor capacity, is going to still retain a lot of urine, and there will be post-void volume. And ultimately, these children can go on to a myogenic failure, because it will keep, the detrusor will keep on acting, and at some point of time, it will become unifatigue, and failure will happen. So these patients, even if you see a lot of post-void volume, post-void residue, does not mean that they are into myogenic failure. So just giving them a relaxation of the urethral sphincter by giving tamsulosin, hydrogen or oxazocin, can relieve the symptoms of low flow and improve these children.
So I'd like to thank all the panelists and the chairperson for, and due to lack of time, we had to skip a lot of slides.
Any comment from the floor, or anybody who wants to share his experience of bladder disorders? No.
So basically,
it is all right.
No. Yeah. So the take-home message is, bladder was a neglected organ. We used to worry a lot about the kidneys, but it is high time that we have to concentrate on bladder. And that's the reason for last 7 years, we had created a bladder clinic in Kolkata. And I think all across the country, nephrologists should come together with pediatric urologists and create bladder clinics to create awareness and actually find out all these issues which lead to chronic problems. And we welcome you all to Kolkata next year for the ISPN call. This year, sorry, this year.
Sorry,
Yeah.
it's a just pre-puja event, so all are welcome also to view the Durga Puja of Calcutta. And now it's the early bird, and for today for Patna delegates, it's 1,000 rupees less than what is normal. The standard price is going on. We have better workshop also, and Subhashi sir is going to organize the bladder workshop also for general pediatrician. So you all are welcome. Thank you.
Thank you to the organizers, Professor Hemant, Professor Om, for giving you this opportunity, and to you all for the patient hearing. Thank you.
Thank you for a nice panel discussion. So thank you, Chairperson, moderator, and all the panelists. And this is the end of academic session of today's, but it's not end of the day. So I request all the delegates to come again at 8 p.m. sharp for the inaugural ceremony. So we have inaugural ceremony at 8 p.m. So kindly, I request you all to assemble at 8 p.m. sharp. Thank you.
There is a small announcement. After the inaugural ceremony, all the faculties are invited for dinner in the backyard of this hall, that is Vatika, Darbar Vatika. So please remember, all the faculties, they are requested to assemble there after the inaugural ceremony. Thank you very much.
Waking up this entire.
Yes. चलो यार लड़का. चलो बंद करना है.
आईफोन नहीं कोई आईफोन के ले लेता अच्छा मैं दोनों में ले लेता हूँ
Hello, check. Hello, check.
सीधा करना मुश्किल होगा ओडिया तो थोड़ा तो कनेक्ट हो पूरा अगर सीधा कर देंगे तो मेरा फेस सीधा रहेगा इधर नहीं कनेक्ट होता इधर से कोई प्रॉब्लम हो रहा है क्या
चेंज करो सर
कॉर्डलेस लगाइए ना दे दीजिए
इधर खड़ा हो जा सर
यहाँ पे किधर है मेरे उधर अच्छा नहीं जाएगा आउट ऑफ स्टेशन
हेलो इधर लेके
उसके बाद
आपको कॉलर माइक लेके चले
कॉलर माइक आवाज जाएगी अच्छे से क्लियर
और एक कॉलर
ये दो ही साइड वाला देख लीजिए तबला पे दे दीजिए एक बांसुरी पे दे दीजिए
यहाँ रख देंगे तो काम नहीं चलेगा
उसे चलाने के लिए तो काम चले जाएगा फिर अच्छा नहीं लगता है देख अगर बात कीजिएगा खूबसूरती की तो खूबसूरत नहीं लगेगा देखिए काहे हिला रहे हैं जनाब हेलो कॉल करेंगे रुक जाना क्या है कल से रेगुलर नहीं कल से रेगुलर क्लास होगा हाँ कल संडे है ना हाँ है होली में कहीं जा रहे हैं कितने बजे तारीख को जाओगे क्या हाँ 8 कल करोगे ना कल संडे ठीक है कल से रेगुलर हो जाएगा क्या कि आज तक थोड़ा कल नहीं है वही तुम बोलते हैं क्लास नहीं हो रहा है हमको बोल रहे हैं कि कॉलर में चला दो, बोले कि आवाज आएगी ना अच्छे से। दो स्टैंड हो जाए, एक इनको स्टैंड चाहिए, एक
हेलो हेलो
और हमको बोले कि
हेलो
यहाँ
हेलो
हेलो
हेलो हेलो हेलो हेलो
आपको अच्छा लगेगा तो रख दीजिए।
हेलो हेलो आपके तक तो बोले माइक में आवाज आएगा। हेलो 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 वहाँ देखिए लाइट जल रहा है, देखिए। हेलो हेलो वहां से नहीं आ रहा है, वहां देखिए लाइट जल रहा है उसमें मिक्सर में। हेलो 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 हेलो
तो आवाज उठा इसका।
हेलो हेलो हार्डवेयर शुरू हो जाएगा।
अरे
भाई
उसको
तो पता था ना
ठीक है। हेलो ठीक है।
हेलो हेलो
हेलो
हेलो
हेलो
हेलो
हेलो। अरे
तार लगा हुआ है? नहीं जी।
प्रदीप
हेलो
प्रदीप
हेलो 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 बंद नहीं होगा, हाथ घुसाना पड़ता है।
हेलो 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 हेलो
तीसरा हाथ में
हेलो 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 चेक चेक हेलो हेलो चेक 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 हेलो हेलो चेक 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 हेलो हेलो
अब बोलिए। आवाज इसका बढ़ाइएगा कॉलर का।
बोलो। अरे अपने तो बोलो ना।
चेक हेलो चेक हेलो चेक चेक
हेलो
हेलो चेक चेक हेलो चेक चेक हेलो चेक हेलो चेक चेक हेलो चेक बेस बढ़ाइए थोड़ा।
हेलो 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 चेक हेलो 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 हेलो
Check. Hello. Hello. Check. Check. Hello. Hello. Check. Check. Hello. Hello. Check. Check. Hello. 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 Check. Check. Hello. 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 Check. Hello. Check.
ऐसा कॉन्ट्रैक्ट
देखिए माइक ऐसा नहीं है कि कोई भी किसी को दे दीजिएगा तो फिर वो चीज़ नहीं आ पाती जिसके लिए आपको बुलाया गया है वो चीज़ फिर आप नहीं दे पाइएगा फिर आपको बुलाने का क्या फायदा। अगर आप हमको बुलाए हैं गाने के लिए मेरी आवाज़ आपको पसंद नहीं आएगी तो दोबारा आप बुलाइए। कंप्लीट साउंड सिस्टम पे डिपेंड करता है मेरी आवाज़। आप कितना भी अच्छा गाते हैं या फिर कितना भी बेसुरा गाते हैं अगर साउंड अच्छा रहेगा तभी आप इसके बाद वैसे नहीं मिलेगा उसके लिए वहां से घंटा आएगा।
या फिर शिखा भी ऐसा कर सकती है यहाँ पे पैसे लेते
बड़ा बेकार है। इधर करना पड़ेगा माइक्रोफोन को इधर करना पड़ेगा फिर इधर करना पड़ेगा फिर इधर 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 एट लास्ट
एक गाने में एक
पूरे उसको पूरे कुर्ता पहना रखते
check, hello, check.
फ्लूट में थोड़ा गेन बढ़ाइएगा राधा सब थोड़ा इफेक्ट डिले अगर डाल सकते हैं तो डाल दीजिए रिवर्ब और डिले थोड़ा सा मिक्स कर दीजिए
हेलो ठीक
साउंड एकदम ड्राई है थोड़ा सा रिवर्ब पे मिले हल्का सा रिवर्ब दीजिए फ्लूट पे
हेलो थोड़ा इसका वॉल्यूम बढ़ा दीजिए वोकल हेलो हारमोनियम से ऊपर रखिए हेलो
फ्लूट में
हेलो हेलो थोड़ा सा डिले दीजिए ना थोड़ा रिवर्ब भी दीजिएगा थोड़ा स्वीट बनाइए ना आवाज को
तबला का लेवल बढ़ाइए थोड़ा सा इसमें थोड़ा बेस डाल दीजिए ना तबला में
फ्लूट का बढ़ाइए कोई नहीं साउंड चेक कीजिए थोड़ा साउंड चेक करते हैं थोड़ा साउंड चेक करते हैं हेलो सांसों की माला पे सिमरूं मैं पीका नाम सांसों की माला पे सिमरूं मैं पीका नाम अपने मन की मैं जानूं और पी के मन की राम, सांसों की माला पे सिमरूं मैं पी का नाम, सांसों की माला पे सिमरूं मैं पी का नाम।
अभी जस्ट टेस्ट हो रहा था सर। हाँ बहुत ज्यादा रखिएगा, बंद है ना।
कंफर्टेबल।
हेलो।
हाँ, आप लोग कभी ले लीजिएगा ना तो
हेलो। सर यहाँ से जाना लेकिन सर वो तो हम लोग आगे खड़े रहे यहाँ से आगे हो पाएगा सर, आगे से नहीं हो पाएगा, चढ़ना ऐसे कंटिन्यूशन में थोड़ी देंगे। हाँ 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 ऊपर चढ़ जाएंगे जी।
नहीं नहीं अब लोग
Namaskar. Good evening. I would like to request all of you, please be seated. Please be seated so that I can start the program. Bihar is the land where two of the most popular religion on the planet, Buddhism and Jainism, took birth. Bihar is also the place where concept of non-violence originated. Bihar, which finds their mention in several ancient texts, were Magadh, Mithila, and Ang. All this kingdom flourished for centuries. Bihar is a group of hardworking, intelligent, and intellectual people. The world is full of diamonds and gems. The world is full of diamonds and gems, and we are having some of them here today to build this event. A very good evening to all the dignitaries gathered here today. It's my pleasure to extend a cheerful welcome to all of you. I, Soma Chakravarti, feel privileged to welcome you all on behalf of the organizing committee of Patliputra National Kidney Foundation to the 2 days seminar program, First State Conference on Pediatric Nephrology. The program ISN, Eastern Zone Midterm CME 2023, organized by Patliputra National Kidney Foundation. I would like to request all of you to give a big round of applause to Patliputra National Kidney Foundation for organizing this historical event. The 2 days seminar, the theme of 2 days seminar is children and kidney. Approx 200 national and international doctors are participating in 2 days conference and around 160 doctors from Bihar. Really, we are very grateful to all of you. Really, it's a historical event as it's a huge number of doctors are present over here. Thank you so much for being a part of this historical event. Patliputra National Kidney Foundation. You all aware of this foundation, and this foundation has been working for last 5 to 6 years above, and it has organized several programs based on health issues. Really, this foundation is working and in the field of health, and we are honored that all the doctors, honorable doctors, are present over here in 2 days seminar. So, first of all, I would request all the dignitaries to come one by one and take their respective seats on the dais. I would like to request Dr. Megha Sehgal to Scott, Dr. Professor R.N. Srivastav, who is the inaugurator of the ceremony. With a big round of applause, I would like to welcome Dr. Professor R.N. Srivastav, the inaugurator of the ceremony. Dr. Megha Sehgal, I would like to request to Scott. Dr. Professor, Arun Srivastav on the dais. I would like to request Dr. Shashi Kumar to escort Dr. Professor Binde Kumar. He is the chief guest of this ceremony, this program. I would like to request Dr. Shashi Kumar. And now I would like to request Dr. Rajeshwar Rao to escort Dr. Professor Georgie Abraham. Please escort Dr. Professor Georgie Abraham on the dais. Dr. Rajeshwar Rao. I would like to request Dr. Gyan Prakash to escort Dr. Professor Sanjeev Gulati. Dr. Sanjeev Gulati, I would like to request Dr. Rajeshwara to escort him on the dais. I would like to request Dr. Manoj Gupta to escort Dr. A.K. Badh. Dr. Manoj Gupta to escort Dr. A.K. Badh. I would like to request Dr. Chandan to escort Dr. Arghya Majumdar. Dr. Chandan, please escort Dr. Arghya Majumdar. I would like to request Dr. Anil Jaiswal to escort Dr. Nigam Prakash, sir. Dr. Anil Jaiswal. Ajay. He is FAT'd. Okay, no problem. Dr. Raja Ram, I would like to request, please escort Dr. Amresh Krishna. Dr. Raja Ram, I would like to request to escort Dr. Amresh Krishna. Dr. Abhishek Kumar, please escort Dr. Professor Om Kumar. Dr. Abhishek Kumar, you are requested to escort Dr. Professor Om Kumar. Dr. Khushbu Rani, I would like to request, please escort Dr. Professor Hemant Kumar, the organizing chairman of Patliputra National Kidney Foundation. Dr. Shalini, I would like to request to escort Dr. Madhu Sinha, present over here. Dr. Madhu Sinha, I would like to request Dr. Shalini, please escort Dr. Madhu Sinha. And Dr. Satya Mohan, please escort Dr. Rajiv Sinha on the dais. Welcome you all the dignitaries. Give a big round of applause of all the dignitaries present over here on the dais. Really, it's a great occasion. The huge number of doctors and dignitaries are present over here in this occasion. And now, all the guests who are present over here, I would like to welcome them also. Our patrons, Dr. U.S. Rai sir, Dr. N.C. Prasad sir, Dr. V.K. Singh sir, Dr. Gopal Prasad sir, and Dr. Pankaj Hans sir. Thank you so much, sir, for being a part of this gala event. And now, a presentation of bouquet to all the dignitaries present over here on the dais. I would like to request Ms. Julie Kumari to present a bouquet to Dr. Professor Arun Srivastav, Senior Consultant, Pediatric, New Delhi. He is the inaugurator of the ceremony. With a big round of applause, please welcome Dr. Professor Arun Srivastav, Senior Consultant, Pediatric, New Delhi. He is the inaugurator of the ceremony. Ms. Aparajita, you are requested to present a bouquet to our chief guest of the ceremony, Dr. Professor Binde Kumar, Director, IGIMS Patna, Indira Gandhi Institute of Medical Science. Please present a bouquet. Ms. Anita, I would like to request to present a bouquet to Dr. Professor Georgie Abraham, President, Indian Society of Organ Transplantation. Ms. Jinnat, please welcome with a bouquet to Dr. Professor Sanjeev Gulati, Guest of Honor, President, Indian Society of Nephrology. Ms. Julie, you are requested to present a bouquet to Dr. A.K. Badhya, Honorable Secretary, ISN, Eastern Zone. Ms. Aprajita, please welcome with a bouquet to Dr. Arghya Majumdar, Chairman, Scientific Committee, ISN Eastern Zone. He is the special guest of today's ceremony. Ms. Anita Singh, please welcome with a bouquet to Dr. Nigam Prakash Narayan, Chairman, Reception Committee. Ms. Julie Kumari, again, I would like to request to present A bouquet to Dr. Amresh Krishna, Chairman of Scientific Committee. Ms. Jainat, please present a bouquet to the Organizing Secretary, Dr. Professor Om Kumar. Ms. Aprajita, you are requested to present a bouquet to the Organizing Chairman, Dr. Professor Hemant Kumar. Ms. Anita Singh, please present a bouquet to the convener, Dr. Madhu Sinha. She is the convener of this 2 days program. And Ms. Aprajita, you are requested to present a bouquet to Dr. Rajiv Sinha, convener of this 2 days program, 2 days conference. Ms. Aprajita. Thank you so much. And now we will have a traditional auspicious lamp lighting ceremony as a tribute to Mother Saraswati, Lord Ganesha. Let us hope that the brightness of education overcomes the darkness of division and leads us to growth, equality, and liberty. I would like to request our inaugurator, sir, please, and all the dignitaries present over here to please light the lamp, the inaugural lamp of this ceremony. All the dignitaries present over here on the dais. The inaugurator of today's ceremony is Dr. Professor R.N. Srivastav, Senior Consultant Pediatrician, New Delhi, and the chief guest, Dr. Professor Binde Kumar, Director, IGIMS Patna, and other dignitaries, Dr. Professor Georgie Abraham, Guest of Honor, President of Indian Society of Organ Transplantation. Our guest of honor is Dr. Professor Sanjeev Gulati, President, Indian Society of Nephrology. Om Shubham Karoti Kalyanam. Arogyam Dhana Sampada. Shatru Buddhi Vinashaya. Deep Jyoti Namastute. अपने लौ को सदैव मध्यम ही जलने दो, प्रकाश पर खुद कभी घमंड ना, दिखाना राह नजर, दीप तुम जलते रहना यूं ही निरंतर। अंधेरी गलियों में हम जो भटक जाएं, तेरे उजियारे से प्रज्वलित आशाएं, दीप तुम जलते रहना यूं ही निरंतर, दीप तुम जलते रहना यूं ही निरंतर। I fold my hands before the light that brings prosperity, auspiciousness, good health, abundance of wealth, and destruction of the enemy's intellect. The inaugural lamp is being lighted by our dignitaries. Give a big round of applause. Such a special moment. 2 days conference organized by Patliputra National Kidney Foundation, ISN Eastern Zone Midterm CME 2023 has been inaugurated by our chief guest, our inaugurator, Dr. Professor R.N. Srivastav, Senior Consultant Pediatrician, New Delhi, and our chief guest, Dr. Professor Binde Kumar, Director, IGIMS, and other dignitaries present over here. I would like to request all of you to please take your seats on the dais. Thank you so much. All our honorable doctors, please take your seats. And now, to welcome all the dignitaries present over here on the dais and in the front of the stage, the artist of Prangan Patna will present a welcome song followed by a holy song. So put your hands together to welcome the artist of Prangan Patna, a welcome song followed by a holy song. The artists are, as a singer, Kundan Kumar and Shikha Kumari, in tabla, Muhammad Alauddin, and in flute, Muhammad Salim. Start.
गजाननं भूतगणाधिसेवितम् कपित्थजम्बूफलचारुभक्षणम् उमासुतं शोकविनाशकारकम् नमामि विघ्नेश्वर पादपङ्कजम् वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। किस तरह से नमन मैं करूं आपका, किस तरह से नमन मैं करूं आपका। स्वागतम 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 आपका, स्वागतम 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 आपका। किस तरह से नमन मैं करूं आपका, किस तरह से नमन मैं करूं आपका। स्वागतम 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 आपका, स्वागतम 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 आपका। बाट देखे ये अखियां अतिथि देव की, पदम पगम रे ग सर नि सा धनि रे। बाट देखे ये अखियां अतिथि देव की कृपा जो हुआ आगमन आपका, की कृपा जो हुआ आगमन आपका। आप आए कि महफिल की रौनक बढ़ी, आप आए कि महफिल की रौनक बढ़ी, आप आए कि महफिल की रौनक बढ़ी। दिल की कलियां खिली है करम आपका, दिल की कलियां खिली है करम आपका। किस तरह से नमन मैं करूं आपका, किस तरह से नमन मैं करूं आपका। स्वागतम 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 आपका, स्वागतम 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 आपका, स्वागतम आपका, स्वागतम आपका। क्योंकि अभी फाल्गुन का महीना चल रहा है, तो मैं एक होली, छोटी सी होली पेश करने जा रहा हूं। होली खेले रघुबीरा अवध में, होली खेले रघुबीरा, होली खेले रघुबीरा अवध में, होली खेले रघुबीरा, होली खेले रघुबीरा अवध में, होली खेले रघुबीरा, होली खेले रघुबीरा अवध में, होली खेले रघुबीरा। के कर हाथे कनक पिचकारी, के कर हाथे कनक पिचकारी, कनक पिचकारी, कनक पिचकारी,
कनक पिचकारी, कनक पिचकारी।
के कर हाथे अबीरा अवध में, होरी खेले रघुवीरा, के कर हाथे अबीरा अवध में, होरी खेले रघुवीरा। होरी है,
होरी खेले रघुबीरा अवध में, होरी खेले रघुबीरा।
राम के हाथे कनक पिचकारी,
राम के हाथे कनक पिचकारी,
कनक पिचकारी, कनक पिचकारी,
कनक पिचकारी, कनक पिचकारी।
राम के हाथे कनक पिचकारी, कनक पिचकारी, कनक पिचकारी, लक्ष्मण हाथे अबीरा अवध में, होरी खेले रघुबीरा, लक्ष्मण हाथे अबीरा अवध में, होरी खेले रघुबीरा। होरी है, होरी खेले रघुबीरा अवध में, होरी खेले रघुबीरा, होरी खेले रघुबीरा अवध में, होरी खेले रघुबीरा। होरी है, होरी खेले रघुबीरा अवध में, होरी खेले रघुबीरा, होरी खेले रघुबीरा अवध में, होरी खेले रघुबीरा। होरी है, होरी खेले रघुबीरा अवध में, होरी खेले रघुबीरा। होरी है, होरी खेले रघुबीरा अवध में, होरी खेले रघुबीरा। होरी है,
होली है,
बहुत
होली
बहुत
खेले
धन्यवाद।
रघुबीरा अवध में. The artists of Prangan Patna, singers were Kundan Kumar and Shikha Kumari, in tabla Muhammad Alauddin, and flute Muhammad Salim. Thank you so much. Give a big round of applause to the artists of Prangan Patna. Thank you so much for the melodious welcome song and holy song. And now, let's proceed to the next program. Let us have the pleasure of listening to the opening and welcoming remarks of our most dynamic and experienced organizing chairman, Dr. Professor Hemant Kumar of Patliputra National Kidney Foundation. Welcome you, sir.
Good evening, everybody. Honorable guests on the dais, off the dais, and esteemed delegates. On behalf of organizing committee and Patliputra National Kidney Foundation, Professor Om Kumar joins me to welcome you all to first state conference on pediatric nephrology. At the outset of today's inaugural program, I would like to extend my heartfelt gratitude to the dignitaries on the dais. I welcome inaugurator of today's ceremony, Professor R.N. Srivastava, pioneer of pediatric nephrology in India, former professor and head department of Pediatric Nephrology, AIMS New Delhi, and past president of Indian Society of Nephrology, whose accomplishments and recognized contributions to nephrology needs no introduction. I welcome our chief guest, Professor Binde Kumar, Director, Indira Gandhi Institute of Medical Science at Patna, who is a renowned pediatric surgeon. He has championed the cause of health services in Bihar and whose progressive views and foresight have been instrumental in strengthening premier medical institutions like Indira Gandhi Institute of Medical Sciences and AIMS Patna in our state. I welcome our guest of honor, Professor Georgie Abraham, who is a pioneer of peritoneal dialysis in India. He is the president of Indian Society of Organ Transplantation. I welcome Professor Sanjeev Gulati, a renowned nephrologist and president of Indian Society of Nephrology. At present, he is the chairman of nephrology and kidney transplant at Fortis Group of Hospital, NCR. I would like to extend a special note of gratitude to Dr. A.K. Badya, Secretary, Indian Society of Nephrology, Eastern Zone, Dr. Arghya Majumdar, Chairman, Scientific Committee, Indian Society of Nephrology, Eastern Zone. In today's program, we have a galaxy of stalwart nephrologists and luminaries, including Dr. R.K. Sarma, Dr. J.P. Ojha, Dr. K.L. Gupta, son of the soil, Dr. Vivekanand Jha, the immediate past president of International Society of Nephrology, Dr. Narayan Prasad, Dr. Sanjay Dikruj, Dr. Manish Rathi, Dr. Sujata Sani, Dr. Susmita Banerjee, and Dr. Aditi Sinha. I welcome Dr. Professor N.R. Biswas, the immediate former Vice Chancellor and Director of Indira Gandhi Institute of Medical Sciences, who is at present Vice Chancellor Sri Balaji Vidyapith at Pondicherry. I heartily welcome Dr. Vincent C., who has taken all the pain to travel from United Kingdom to enlighten all of us with his pioneer work on childhood UTI. The soil of this ancient city of Patliputra has nurtured Patliputra National Kidney Foundation in a very short span of time, and enormous support of all the nephrologists of the state of Bihar, and is taking lead of hosting such type of conferences under the aegis of Indian Society of Nephrology, Eastern Zone, having academic leaders like Dr. D.K. Pahadi, Dr. D.S. Ray, Dr. Sauvik Sural, Dr. Arpita Rai Chaudhary, and Dr. Prateek Das of national repute. To set the stage of this landmark event of first state conference on pediatric nephrology, let me begin by answering why do we need a conference on it. Today, this conference is giving an opportunity for interface between pediatrician, pediatric nephrologists, and adult nephrologists from all over country. Pediatric nephrology is a super specialty that straddles the intersection between pediatric to adult renal care, as the number of young patients graduating from pediatric to adult renal care has progressively increased due to improved management, resulting in patient survival rate to the tune of about 90%. On this conformity, Dr. Vincent C. is going to highlight pediatric CKD as a harbinger of adult onset comorbidities tomorrow. You are welcome, C. to Patna. The organizing committee of this conference has worked tirelessly to present a wide range of scientific program that covers diverse aspects of pediatric nephrology. I am confident that bringing increased focus to pediatric nephrology, that this conference will mark the beginning of a new era in child care in the state of Bihar. I acknowledge sincere effort to Dr. Madhu Sinha, Senior Consultant Pediatrician, and Dr. Rajiv Sinha, Senior Consultant Pediatric Nephrologist based at Kolkata. Both of them have been enormously instrumental in shaping the program under the leadership of Professor Om Kumar and Professor Amresh Krishna. The souvenir edited by Dr. Sasi Kumar, Dr. Pritpal Singh, and Dr. Rishi Kishore will come out as a heritage. Once again, I extend warm welcome to all attendees and look forward to a dynamic and productive conference tomorrow also. Thank you very much.
Thank you. Thank you so much, sir. Dr. Professor Hemant Kumar, Organizing Chairman, for sharing your deep knowledge. Thank you so much. And now I invite Dr. Amresh Krishna, Honorable Chairman of Scientific Committee, to address the gathering.
Good evening, respected inaugurator of today's function, Professor R.N. Srivastav, sir, Chief Guest of the function and Director of IGIMS, Professor Binde Kumar, sir, senior faculty members on the dais and off the dais. On behalf of the scientific committee, I extend my warm welcome to all nephrologists, pediatrician, and physician attending this conference. The response has been overwhelming from both the faculties as well as the delegate, and I bow down to you for your greatness. This is the first state conference on pediatric nephrology in Bihar, which is being organized as ISN Eastern Zone Midterm CME 2023. As we are aware that this subspecialty of nephrology, that is pediatric nephrology, remains somewhat neglected, not only during the training period, but also in clinical practice. Full-time pediatric nephrologists are a rare entity in our state and this region. This gap is fulfilled by us, the adult nephrologists, who also cater about the pediatric population. The scientific session has been composed in a manner that it touches all the major clinical topics and will update and reappraise our knowledge of pediatric nephrology. We warmly invite you to join this event, bringing together your participation to share the knowledge and spread best practices to enrich our pediatric nephrology community and ultimately benefit the pediatric population with kidney disease. Once again, we thank you for joining us. Come and enjoy the scientific discourse and many attraction of this unique place, which is guaranteed to create a lasting and pleasant memory. Thank you.
Thank you. Thank you so much, sir. Dr. Amresh Krishna, Chairman, Scientific Committee, for sharing your great knowledge with us. The next guest to honor us with his presence and address is our special guest of today's program, Dr. Orgho Majumdar, Chairman, Scientific Committee, ISN, Eastern Zone. Please, sir.
Good evening, Professor Srivastav, Professor Binde Kumar, all the dignitaries on stage and off it. Today, medical science is progressing at a very rapid pace in all specialties. And therefore, it's very important not just to interact with each other in our forums, but also to have interface sessions with other specialties. We started this trend earlier in the aegis of the ISN East Zone in Calcutta, where we had interface with various specialties, and Professor Hemant Kumar has taken it to a different level with this interface with pediatricians. And the scientific program has been formulated in a very, very nice manner, and the organization is, hospitality is excellent. So I hope you all enjoy this scientific feast. All the best to this conference. Thank you.
Thank you. Thank you, sir, so much for an amazing speech. Thank you. And now it will be my honor to invite Dr. A.K. Badhya, Honorable Secretary of ISN Eastern Zone, for his address. Dr. A.K. Badhya, Honorable Secretary, ISN Eastern Zone.
Good evening, inaugurator of the ceremony, Professor R.N. Srivastav sir, chief guest and Director of IGIMS Patna, Professor Vinday Kumar. Guest of honor and President ISOT, Professor Georgie Abraham. Guest of honor and President ISN, Professor Sanjeev Gulati. Chief Patron, Dr. D.K. Srivastav. Chairman, Scientific Committee, ISN Stern John, Dr. Argya Majumdar. Chairman, Research Committee, Dr. Nigam Prakash. Organizing Chairman of this conference, Professor Hemant Kumar. Organizing Secretary, Professor Om Kumar. And Chairman, Scientific Committee, Dr. Amresh Krishna. And Convener, Dr. Madhu and Dr. Rajiv. A very respected teachers, friends, delegates, ladies and gentlemen. A very warm welcome from ISN on the occasion of first state level pediatric nephrology conference under the banner of ISN Stern John Midterm Conference 2023. ISN Stern John is now doing a lot of academic activities. Like every month we are doing some kind of activities for the nephrologists and physician and different states of the zone. And we are also doing some kind of academic activities in peripheral areas for the clinicians. We have all the formalities to run the society, and today we are going to release the website of ISN Stern John, that is www.isnez.com. Patna is always the source of inspiration, source of education from the long back, that is 5th century BC, when we had Nalanda University. And today also, we have several prestigious educational institutions in the state, like Patna Medical College and Hospital. And you will get students of this medical college all over the world. We have IGIMS, we have All India Institute of Patna. So a lot of different institutions we have. Dr. Hemant Kumar is not for the first time he is organizing this midterm conference. Previously also he has organized, and that was on the Nephro-Oncology conference. But this time it was very appealing for all the delegates because all the topics were very, very clinical, and it was for the patient's benefit. So once again, I would like to thank Dr. Hemant Kumar, Dr. Om Kumar, Dr. Amresh, and the team, nephrology team of Bihar for organizing this kind of conference. Thank you very much.
Thank you so much, sir, for sharing your profound knowledge with us. And now I would like to request, it will be a privilege for me to invite our guest of honor, Dr. Georgie Abraham, President, Indian Society of Organ Transplantation, for his knowledge words on this special occasion.
Thank you and good evening. At the outset, I want to state that it's a great honor for me to be invited here. The Pataliputra National Kidney Foundation, the relevance of kidney foundations, because I'm also a member of the Tamil Nadu Kidney Research Foundation. The relevance is becoming more, as shown by Dr. Professor Hemant Kumar, because there is a definite role for the kidney foundations to play in terms of education, patient care, and look at the sufferings of the people. And also integrating with the Eastern Zone Indian Society of Nephrology with the other my nephrology colleagues is a great accomplishment for that. As Buddha said, impermanence. Impermanence is impermanence. What we had 30 years ago is not what we see now. So this shows that impermanence has a lot of relevance in our life. And look at me, I'm standing here because last 22 February, I had COVID. I thought that I will never be affected with COVID because I had 3 injections of vaccination. Bad COVID, record hospitalization, 18 days of hospitalization, never in my life. And complications after that, untold complications. So it is the family and the friends and the colleagues like you who have supported me in your prayers and in your good thoughts to stand here and speak. There are so many unmet needs in our pediatric nephrology, and there is a critical gap. And we have colleagues sitting there, and we also have people from the industry. We all have to work together to save the child. What is saving the child? The children are the future of this country. If we don't save our children with kidney disease and advance forward, nothing will work. Thank you so much, and God bless you all.
Thank you. Thank you so much, sir, for sharing your great knowledge with us. Dr. Professor Georgie Abraham, thank you. It will be my honor to invite our guest of honor, Dr. Professor Sanjeev Gulati, sir. He is the president of Indian Society of Nephrology, for his intellectual words. Please, sir.
Thank you. Good evening, friends. Guest of honor, Professor Binde Dubey, Professor R.N. Srivastava, who's been my role model, Professor Georgie Abraham, a close friend, mentor, and colleague, distinguished delegates in the audience, and as well as on the dais, dear friends. First and foremost, I'd like to thank all of you for your blessings and wishes, because of which I stand here as the president of the Indian Society of Nephrology. The ISN has taken upon itself to take up several new initiatives. We have formed a patient advocacy committee, a liaison committee, a medical legal committee, so that the enormity of the task that is there, we share with everyone and we take steps forward. I also take this opportunity to compliment Professor Hemant, who's been a visionary as far as nephrology is concerned in the state of Patna. And I think we conceptualized this meeting last year, and within no time I found that he came forward and said that, let me host this meeting on pediatric nephrology, and I found that really forthcoming, coming from a person who's been predominantly working as an adult nephrologist, but that speaks of his vision. And last but not the least, I welcome all of you to this academic extravaganza and hope that you enjoy this meeting. Thank you.
Thank you. Thank you so much, sir. Dr. Professor Sanjeev Gulati, President, Indian Society of Nephrology, for your rich words. Now let us have the pleasure of listening to our honorable and a great speaker, Chairman of Reception Committee, Dr. Nigam Prakash Narayan, sir.
Well, thank you very much for inviting me to this dais. Respected chairperson and the inaugurator of today's function, Dr. R.N. Srivastava, sir, who has been an icon for the pediatric nephrology, and now I think he has had a position of grandfather, rather father of pediatric nephrology. And Dr. Binde Kumar, Professor Binde Kumar, who is Director IGMS and today's chief guest. Guest of honor, Dr. Professor Georgie Abraham, President ISOT. Guest of honor, Dr. Professor Sanjeev Gulati, President ISN. Chief patron is perhaps not here, Dr. D.K. Srivastava. Honorary Secretary ISN Eastern Zone, Dr. A.K. Vaidya. Chairman Scientific Committee, ISN Eastern Zone, Dr. R.G. Majumdar. Organizing chairman of this wonderful conclave, I must tell you, and I've got great appreciation for this person, Professor Hemant Kumar, who is the organizing chairman, and he is a real visionary. I had a great appreciation once he was working with all of us, where in Patna Medical College, he was heading the nephrology unit, I was heading the pediatrics unit, and we had great appreciation since then, and today also he has shown his worth. He has brought laurels to Patna, I must tell you. With the kind of conclave he has had today and tomorrow also he is going to have, I think this is something which is a great step forward. And I must tell you that pediatric nephrology, the discipline is not as well developed as it should have been in this populous state so far. That is a little unfortunate, but I think this step is going to be a milestone now for the further development of this discipline in our state. Well, he has been well supported by the organizing secretary, Professor Om Kumar, Chairman Scientific Committee, Dr. Amresh Krishna, and of course the conveners, Dr. Madhu and Dr. Rajiv. Well, and all distinguished guests in this hall and all the speakers, faculties. Well, it's a great honor as a Chairman Reception Committee. It's a proud privilege for me to welcome you all to this holy city of Patliputra, which has been a sheet anchor for many religions, and it's a very holy place. I mean, there are a lot of places to visit around, but unfortunately, the time was so short that it was not possible for you to take us to all those places. But definitely, I'm really thankful to the whole committee, the committee who was working under guidance of Professor Hemant Kumar, who has really actually created, he has really assembled the jewels of nephrology. Not only across India, I tell you, there are a few persons like Vincent Zay, who has come all the way from Newcastle, a place where I was working way back in 20 years ago. But I think he is instrumental in coming over all across to India for this conference. So I think it's a wonderful feast, which I think everybody is enjoying. The venue is first class, and the reception by the whole committee is number one. And I think this conference will go a long way in actually holding the pediatric nephrology's flag up. Thank you very much indeed.
Really, we are very thankful to Dr. Nigam Prakash Narayan for appreciating our place, our Bihar, the holy place of Bihar, and for appreciation to the organizing committee of Patliputra National Kidney Foundation. To put your hands together for Patliputra National Kidney Foundation. Thank you so much, sir. And now we feel honored to have with us our honorable chief guest of today's inaugural ceremony. We rarely get this kind of opportunity to listen to the words of a great knowledgeable person, Dr. Professor Binde Kumar, Director of IGIMS, Patna.
Very good evening. Professor Arun Srivastava, a legend in the field of pediatric nephrology. Professor Georgie Abraham, President, Indian Society of Organ Transplantation. Professor Sanjeev Gulati, President, Indian Society of Nephrology. Professor A.K. Badya, the Honorary Secretary of ISN in Eastern Zone. Dr. Arghya Majumdar, my teacher, Professor Dr. Nigam Prakash Narayan, my senior and always doing mentoring, Professor Hemant Kumar, my colleague and co-worker. We have started the department together in 1996, the pediatric surgery, and he was in nephrology. Dr. Om Kumar, Dr. Amresh Krishna, a very dynamic man. I'm working with him. Dr. Rajiv Sinha, the ex-director, IGMS, Dr. N.R. Bishwas, Professor R.K. Sharma, Professor Jay Prakash, and my senior and mentor at PGI, Professor Vivekanand Jha, Professor Narayan Prasad, our colleague, Professor Arpita Chaudhary, D.S. Rai, Professor Jain Prakash, my batchmate, Dr. Sanjay D. Cruz, Professor Sanjay D. Cruz, Head of Department Medicine, Government Medical College, Chandigarh, Professor U.S. Rai, Professor N.C. Prasad, B.K. Singh, and many faces. Dr. Jyoti, I can see faces. I remember the journey starts, and when we entered in the field of pediatric surgery, precisely in 1995, when we started pediatric surgery, I always felt that most of the pediatric surgery what we are doing, the 60% belong to the pediatric urology. And those problems were having obstructive uropathy, the the congenital urinary tract, kidney and urinary tract abnormalities, the reflux nephropathy, the posterior valve, and many more things, glomerular nephropathy we are encountering. And that time we have interaction with those stalwarts like Hemant Kumar sir and Professor Om Kumar, Professor US Rai sir, and we have a very good team and we did good work. The conference which is addressing the pediatric and the kidney patients together, this is the one area, the pediatric population, which are making at least 8 to 10% if we are going in OPD in adult kidney OPD. And the 8 to 10%, the sad aspect is that what I have witnessed, the more than 50% are having advanced diseases, and most of them leading to end-stage renal diseases. So here, the need of hour is to have more such conferences and meetings and apprise the populations and the doctors about the preventive measures like avoidance of the dehydration, the aminoglycosides, and if there's a UTI, it should be treated promptly. I'm sure the 2 days conference will bring many new development and give new insight, which will develop our faculty and our doctors to improve the care of the pediatric patients who are suffering from kidney diseases. I wish all the good luck to everyone who is attending this conference and meeting, and I wish all the success for this. Thank you very much.
Thank you. Thank you so much, sir. Dr. Professor Binday Kumar, Director, IGIMS. Ladies and gentlemen, we have gathered here with a very nice cause and with theme, Children and Kidney. It will be a privilege for me to invite our inaugurator of this ceremony, Dr. Professor R.N. Srivastav, Senior Consultant, Pediatrician, New Delhi. Give a big round of applause to our inaugurator, Dr. Professor R.N. Srivastav, sir.
Thank you. Professor Binday Kumar, Professor Sanjeev Gulati, George Abraham, Dr. Hemant Kumar, and your organizing colleagues, leadership of East Zone INS, my very eminent colleagues sitting right here, Professor Jha, R.K. Sharma. This really is a unique and extraordinary occasion. I've been associated with the ISN since 1971. The first time that ISN, East Zone or any zone, had organized a meeting on pediatric nephrology. This really is a wonderful achievement. And I must say, it's extremely satisfying for me. Don't call pediatric nephrology a super specialty. It's just a specialty. Pediatrics is a discipline. Pediatric nephrology and others are just specialties. Now, today you all heard that pediatric diseases are very different. The spectrum is very different. The management is different. It does need people trained in pediatric nephrology to handle all this. Our own society has done well. I think about 37 years old now. And we have branches in most towns, most cities. And I must mention here the difficulties of our society, our people. Number one, initially there were problems with training of these people. We somehow managed to train them up to a certain level, but we could not find placements for them. There was no way to put them in academic positions, and some of them are not willing to go into practice. It's simply not possible to be in pediatric nephrology practice exclusively. And some of our brightest boys and girls, they left the country, went to US and other places. I appeal to all of you to support pediatric nephrology, be it in practice or be it in institution. Professor Binday Kumar and other institutes should have pediatric nephrology divisions. This applies across the board to all medical colleges and institutes, which is simply not there. Hopefully it'll be coming soon. We have corporate hospital, they can place our people, but they are not academic institutions. Some of them are doing very well, Calcutta and Bangalore and so on, but these are not academic research-oriented institutions. I really hope that this meeting here will be a torchbearer, and I appeal to Professor Gulati to see that if such meetings can be organized in other states also, and jointly with our people, actually. I thank you very much for patient listening.
That was really an amazing speech. Thank you so much, sir, for sharing a great knowledge with us. Thank you. Thank you so much. And now it's a time of felicitation. I would like to request Dr. Professor Hemant Kumar and Dr. Professor Om Kumar. Dr. Hemant Kumar is the chairman of organizing committee, Patliputra National Kidney Foundation, and Dr. Professor Om Kumar is the organizing secretary of Patliputra National Kidney Foundation. Both of them will felicitate Dr. Ensign Say. So I would like to request Dr. Ensign Say, sir, to please come forward. Please come forward, and Dr. Professor Hemant Kumar sir and Dr. Professor Om Kumar sir will felicitate you. Sir, please come in the front of the stage. Yeah. And all the dignitaries present over here, put your hands together to grace this occasion as Dr. Ensign Say is being felicitated by the Patliputra National Kidney Foundation, the chairman of organizing committee, Dr. Professor Hemant Kumar, and the secretary of organizing committee, Dr. Professor Om Kumar. Really, it's a big honor for this foundation. Thank you. Thank you so much, sir. And now, citation of Dr. R.K. Sharma, Lifetime Achievement Award. And for this, I would request Dr. Shashi Kumar, please come up here for the citation of Dr. R.K. Sharma, sir.
Good evening to all. Respected dignitaries on the dais and off the dais, seniors and dear colleagues. It's my proud privilege to read citation about my teacher, mentor and pathfinder, Dr. Professor Rajkumar Sharma. Whatever I'll talk over the next 2 minutes is just like showing candle to sun. He's such a towering personality in the field of nephrology. Born on 1st October 1953, he did his MBBS from Delhi University in 1974 and MD in 1979. He got MNMS DNB subspecialty nephrology in 1981 from National Board of Examination. He conferred with fellowship in nephrology, University of Alberta Hospital, Edmonton, Canada in 1986 to 87. Fellowship in nephrology, Texas Tech University, USA, 89 to 90. Fellow, National Academy of Medical Sciences, 1996, New Delhi. Fellow, American Society of Nephrology, 2004. Fellow, International Society of Nephrology, 2005. Fellow of Indian Society of Organ Transplantation, 2017. Over his 4-decade-long professional experience, in 1984, Professor Sharma joined as assistant professor in the Institute of Kidney Disease and Research Center, Ahmedabad. Later in 1987, he joined in SGPGI, Lucknow as faculty in Department of Nephrology, and later he was elevated to the post of professor and head of department nephrology. In 2005, he was assigned as dean, and in 2009, he became director of SGPGIMS Lucknow, and he is one of the longest serving director in the history of SGPGIMS Lucknow. Professor Sharma also served as director, Ram Manohar Lohia Institute of Medical Sciences, Lucknow. Professor Sharma is an outstanding nephrologist who has made seminal research contribution in the field of renal transplantation in the country. He is among the few who are trained both in clinical transplantation and transplantation immunology. His works for non-invasive evaluation of renal transplant for acute rejection, cyclosporine toxicity, and acute tubular necrosis are the pioneering contribution. Professor Sharma started an active renal transplant program in SGPGI MS Lucknow, is one of the largest kidney transplant program in India. He is one of the pioneers in establishing and developing peritoneal dialysis in India and has been instrumental in initiating percutaneous Tenkov catheter insertion in India. His special area of interest are transplantation, immunology, critical care nephrology, and intervention nephrology. The government of India has acknowledged his excellence by inducting him in many policy-making health committees like National Screening Committee for the 12th five-year plan spanning over 2012 to 2017. Professor Sharma was the Academic Council member of Medical Council of India. When we look at his publication, he has having more than 290 landmark publications in various international and national journals, along with 17 chapters in various books. He was the editor of Indian Journal of Transplantation and chief editor of Clinical Queries Nephrology. Among his major achievements, he got International Visiting Scholar Award from Texas Tech University 1989, Young Investigator Award from Japanese Society of Dialysis Therapy in 1995, Maharshi Susruta Award for Excellence in Research in Renal Transplantation at IKDRC Ahmedabad, Vigyan Gaurav Award 2011 by Department of Science and Technology, Government of Uttar Pradesh. He was Secretary of Indian Society of Organ Transplantation between 22 to 24, past President Indian Society of Nephrology 2012 to 2013, past President Indian Society of Organ Transplantation 2015 to 2016, awarded TTS International Science Mentee Mentor Award in 2016 and 2018. He got Doctor of Science from Hemwati Nandan Bahuguna Uttarakhand Medical University in 2022 and Lifetime Achievement Award from American College of Physicians in 2022. Seeing his immense contribution in field of nephrology and in the progression of society, Patliputra National Kidney Foundation privileged to bestowed upon the Lifetime Achievement Award to Professor Dr. Rajkumar Sharma. I request Chairman Professor Hemant Kumar and Patron Dr. Om Kumar to bestow this award to Professor Dr. Rajkumar Sharma.
The Lifetime Achievement Award to Honorable Dr. R.K. Sharma, and to present this award, Dr. Professor Hemant Kumar, Chairman of Patliputra National Kidney Foundation, and Dr. Professor Om Kumar, Secretary, Organizing Committee of Patliputra National Kidney Foundation. Really, it's a very proud moment for all of us. Honorable Dr. R.K. Sharma, the Lifetime Achievement Award, and this award is presented by our organizing chairman, Dr. Professor Hemant Kumar, and organizing secretary, Dr. Professor Om Kumar. Patliputra National Kidney Foundation. Thank you. Thank you so much, sir. And heartiest congratulations. Organizing Secretary of Patliputra National Kidney Foundation, to present a memento and a shawl to our inaugurator of the ceremony, Dr. Professor R.N. Srivastav, Senior Consultant Pediatrician, New Delhi. Dr. Professor Om Kumar, Secretary of Organizing Committee, and a renowned doctor, is presenting a memento and a shawl to Dr. Professor Arun Srivastava. And now I would like to request Dr. Professor Hemant Kumar Dr. Professor Hemant Kumar, Chairman of Organizing Committee, to present a memento and a shawl to Dr. Professor Binde Kumar, Director, IGIMS Patna. He is the chief guest of today's ceremony. Dr. Professor Hemant Kumar is presenting a shawl and a memento. And now, once again, I would like to request Dr. Professor Om Kumar sir to present a memento and a shawl to Dr. Professor Georgie Abraham, President, Indian Society of Organ Transplantation. He is the guest of honors of today's function. Dr. Professor Om Kumar is presenting a memento, and this memento is presented by the Patliputra National Kidney Foundation Organizing Committee. And once again, I would like to request Dr. Professor Hemant Kumar to present a memento to Dr. Professor Sanjeev Gulati, President, Indian Society of Nephrology. Guest of honor, Dr. Professor Sanjeev Gulati. Dr. Professor Hemant Kumar and Dr. Professor Om Kumar, both of them. Once again, I would like to request Dr. Professor Om Kumar and Dr. Professor Hemant Kumar to present a memento and a shawl to Dr. A.K. Vaid, the Honorable Secretary, ISN Eastern Zone. And now, a memento and shawl will be presented to Dr. Argho Mojumdar, Chairman, Scientific Committee, ISN, Eastern Zone, Dr. Professor Hemant Kumar, and Dr. Professor Om Kumar, sir. A token of gratitude, memento and shawl is being presented to all the dignitaries, and now to Dr. Nigam Prakash Narayan sir, Chairman of Reception Committee, Dr. Om Kumar sir, and Dr. Professor Hemant Kumar sir. Dr. Nigam Prakash Narayan, Chairman of Reception Committee, is being felicitated with a memento and a shawl. And now, to Dr. Amresh Krishna, Chairman of Scientific Committee, I would like to request Dr. Professor Om Kumar and Dr. Professor Hemant Kumar to present a shawl and a memento to Dr. Amresh Krishna, Chairman of Scientific Committee. And now I would like to request Dr. Professor Hemant Kumar sir to present a memento and a shawl to the organizing secretary, Dr. Professor Om Kumar. Put your hands together to grace this moment. And now it's time to honor our organizing chairman, Dr. Professor Hemant Kumar. And for this, I would like to request Dr. Professor Om Kumar, the organizing secretary, to felicitate our organizing chairman, Dr. Professor Hemant Kumar. And now, our convener. I would like to request Dr. Professor Om Kumar sir to present a memento and a shawl to Dr. Madhu Sinha, convener of this 2 days program. Dr. Madhu Sinha. And now with the memento and our convener, Dr. Rajiv Sinha. Dr. Professor Hemant Kumar and Dr. Professor Om Kumar, sir. You are requested to present a memento and shawl to the convener, Dr. Rajiv Sinha. Thank you so much, sir. And now, souvenir release. I would like to request Dr. Professor Om Kumar to bring the souvenir for release. Souvenir release. The inaugurator of today's ceremony, Dr. Professor R.N. Srivastava, sir, you are requested to release the souvenir. ISN Eastern Zone Midterm CME 2023 First State Conference on Pediatric Nephrology. A souvenir has been published, and this is being released by our inaugurator and the chief guest of today's ceremony, Dr. Professor R.N. Srivastava, Senior Consultant Practitioner, New Delhi, and Dr. Professor Binde Kumar, Director, IGIMS, Patna. Please grace this occasion. Put your hands together. The guest, the dignitaries on the dais, they are having the souvenir. And it's time to capture this moment. Thank you. And now, an official website of ISN Eastern Zone, release of official website of ISN Eastern Zone. I would like to request our inaugurator of this today's ceremony, Dr. Professor R.N. Srivastava, sir, and Dr. Professor Binde Kumar, sir, chief guest, and all the dignitaries present over here. This is an official website of ISN Eastern Zone. Put your hands together. Thank you so much, all the honorable dignitaries present over here on the dais. And for the vote of thanks, I would like to request our organizing secretary, Dr. Professor Om Kumar, sir.
So, good evening to all. I am very pleased, delighted, and obliged to do this honor of very pleasant work of giving vote of thanks. I am very thankful to Professor R.N. Srivastava, who has accepted to come to Patna and to inaugurate this first state conference of pediatric nephrology. I appreciate the gesture of our very dynamic director, Professor Binde Kumarji, who, despite of one of the busiest day of his schedule today, he consented to come and grace the occasion, be the chief guest of today's function. We are very lucky that both the presidents of national body of Indian Society of Organ Transplant and Indian Society of Nephrology, Professor Georgie Abraham and Professor Sanjeev Gulati is here with us. I thank office bearer of Eastern Zone, Dr. Ashok Vaidya and Dr. Arghya Majumdar, giving permission to hold this first state conference on pediatric nephrology under the banner of Indian Society of Nephrology Eastern Chapter. I am thankful to our organizing chairman, Dr. Hemant Kumar, about whom we all have heard so many things and we have witnessed his visionary and exemplary example of doing the things in great manner. I am thankful to Dr. Amresh Krishna, our convener, Dr. Rajiv and Dr. Madhu for untiring effort to bring this conference to this level. I am so happy to see so many luminaries in this hall. But as I am seeing that many DM students and PG students are here in the hall. And you must be knowing that we are having not only the first Indian, the first Asian to become the president of International Society of Nephrology, Professor Vivekanand Jha in this hall. And I am very proud that two of the most decorated personality in Indian Society of Nephrology, Professor Vivekanand Jha and Professor Narayan Prasad, are alumni of Patna Medical College and Hospital, PMCH. So we are very proud to have you, sir, today in our meeting. I think we all are having once in a lifetime opportunity to witness such great nephrologists, such great pediatricians, pediatric nephrologists. You have heard Dr. Aditi Sinha, about whom every student of pediatric nephrology is knowing and reading her articles. We are having our ex-director and vice-chancellor, Dr. N.R. Viswas, and now the vice-chancellor of Balaji Vidyapeeth University, Puducherry. I am thankful to you, sir, that you have spared time and you are here with all of us. I think every person in this hall deserves mentioning of their name. And I am very happy that the students, the young generation, and we all are happy that we are witnessing a great event in city of Patna. Professor R.K. Sharma is here. Dr. D.K. Pahari is here. Professor Ratan Jha, Dr. P.K. Rai, Dr. Dharmendra Prasad Bhaduria, Professor K.L. Gupta, Arpita Rai Chaudhary, Dr. Ashwini Gupta, Dr. Sanjay Gupta, Sanjay Cruz, Professor D.S. Ray, all are present in this hall, and credit goes to Professor Hemant Kumar, who has made this event possible. So after thanking all the dignitaries on the dais, off the dais, I am very thankful to all the students, delegates, and the organizing team members. Dr. Pritpal Singh, Dr. Harsh, Dr. Abhishek, all are here, and they have done a great job to bring this conference to this level. I am thankful to the management of Hotel Chanakya, who have helped us to bring this conference in this hotel. I am thankful to the audiovisual team who has provided us the materials and logistics to hold this event. Thankful to print and electronic media, and hope they will spread the message of pediatric nephrology in the state of Bihar. I welcome Dr. Manish Rathi. I am saying he's sitting back in the back room. So, and last but not the least, the industry, pharma industry. And it is not important that only they are helping us with financial support. The way the various pharma industry representatives and officials are doing the legwork, the logistics, that is very important for any conference to be successful. And I am also thankful to the international faculty who have accepted our invitation and participated in this conference. So with these few words, I thank you once again, you all. Thank you very much. Jai Hind.
I would like to introduce our anchor comparing today's program. She is none other than Mrs. Soma Chakravarti. She is a national anchor. She is a person who is anchoring the government program nationally and on a state level also. So I will request our inaugurator and the chief guest, Professor R.N. Srivastava and Professor Binde Kumar, to felicitate her.
Really, I'm very much thankful to the organizing committee of Patliputra National Kidney Foundation. Thank you so much, sir, Hemant sir, Om Kumar sir, and all the dignitaries present over here for this honor. I would like to thank our guest and who supported this event. Thank you all and all the wonderful audience present over here, and hope we have really done a good job and we have hosted this event as you have think about it. Thank you so much. And now I would like to request all of you, please stand up for the national anthem.
Vindhya Himachal Yamuna Ganga Uchchal Jaladi Taranga Tava Shubha Naame Jage Tava Shubha Ashish Mage Radhe Tava Jaya Gatha Jana Gana Mangala Dayak Jaya He Bharat Bhagya Vidhata Jaya He Jaya He Jaya He Jaya 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 He
Bharat Mata Ki, Bharat Mata Ki, Bharat Mata Ki. Thank you so much.
There is an announcement. All the faculties are requested to join dinner just in the backyard of this hall. That is Batika, Darbar Batika. Please join us on dinner in Darbar Batika behind this Darbar hall. They are requested to go to Utsav hall to have their dinners. All the youngsters will go upstairs, and that is the mezzanine floor, and all the faculties to Vatika.